initiatives that
Good evening, all the respected delegates. My name is Ranjit Kadam, and I am Marketing of Pharmacare, a division of Sun Pharma. At the outset, I welcome all the delegates from across the globe and India who are watching discussion on very important subject and which is very relevant to discuss now in current scenario of COVID and post-COVID, that is mucormycosis. Sun Pharma, being a #1 pharmaceutical company in India, always wants to associate and contribute in various scientific programs, and we feel extremely proud to associate with such an eminent group of ENT surgeons from overseas. In the past also, we had conducted several live and webinars to facilitate the knowledge sharing process, and we are committed to do so in future as well. I'm sure this program will help thousands of patients, and this is what is the ultimate objective of all of us today. So without taking much time now, I request Dr. Ajay Doifode to formally initiate the proceedings of today's meeting. And with this, I hand over the session to Dr. Doifode. Over to you, sir.
Thank you, Ranjit. Good evening. Welcome all. On behalf of AOI Mumbai, I welcome you all to this very important surgical webinar on mucormycosis, which is jointly organized by AOI Mumbai and AOI Pune. There has been a sudden surge of mucormycosis cases as the second wave is lashing out ferociously. Not only Mumbai, Pune, but rest of India is also being affected by this monster disease. We have none other than Dr. Satish Jain as our faculty to not only demonstrate a variety of surgical cases, but guide us on the appropriate management for this dreaded disease. There is a lot of uncertainty and situations where one is not sure whether the radical debridement is radical, what should be the post-operative antifungal therapy, how to monitor nephrotoxicity. So as we go along, we assure you that everything will be taken care of. Before we started the webinar, we have already 80 questions on waiting to be clarified. So our job of our moderators is going to be very difficult today. And we have an esteemed panel of moderators, very experienced, who will also share their inputs. The anchors for the evening would be Dr. Arpit Sharma, AOI Mumbai Secretary, and second half will be AOI Pune Treasurer, Dr. Pooja Palapure. And before I hand it to Dr. Arpit Sharma, I request AOI Mumbai President, Dr. Virendra Gaisas, to share his thoughts about this webinar.
Okay, thanks Ajay. I'm AOI Pune President, by the way, not Mumbai, so it's okay. Yeah, first of all, thanks everybody for accepting our invitation and joining as operating surgeon and moderators here. We know Pune people, they don't work in the afternoon, so our nap time is over 1 to 4 and we have started working at 5 o'clock. So this timing is because of Satish boss. We are missing IPL, and but our Dhoni, who's a wicketkeeper and a batsman, is ready to bat, and more than 3,000 people are eagerly watching to see his performance, and I'm sure he won't disappoint us. So thanks again, Ajay, for accepting and then doing this combinedly, and of course the Sun Pharma. So it was an initiative of, actually speaking, Abhijit Mantri, who really pushed me to do this, because everybody is seeing many cases. So without wasting time, I'll end my short introduction and I will hand it over to you back. So
and we wish to look forward to organizing many more joint events,
more meetings together, surely.
Thank you, Ajay and Dr. Virendra, for setting the context. It's my pleasure and privilege to invite Dr. Bhumkar here. He is a very renowned ENT surgeon from Thane. He is passionate about the otology, stapes surgery in particular, and reconstruction. He is largely instrumental in involving and inviting Dr. Shrikant Shinde, who is the Member of Parliament from Kalyan, and Dr. Charudat Shinde, who is the CMO of Thane Municipal Corporation. Over to you, sir.
Yeah. Hi. This whole pandemic, these both guys are going to be a little bit late. Charudat is in a meeting. He'll join only at 5:15. We can't. Whenever they join, I will suitably introduce them at an appropriate time. But the reason to get these people is this pandemic is all about an administrative challenge. Among themselves, I think taking it to the public and the policy level is where we need an interaction with these people. And in Thane, we are distinctly lucky that we have two highly qualified doctors, medical doctors. They are both orthopedic surgeons. Charu is actually MCH Artho, who's now the CMO of Thane. So specifically for Mucor, if I can get some pilot study done, and we are going to see Satish's help on that, of how to catch them at the earliest, what sort of directives to give to the task force and through the task force about the judicious use of steroids and things like that, which will probably prevent and even hopefully catch the disease very, very early on. And Satish is going to allude to that. In fact, I had requested both of them to listen to Satish's talk, but nonetheless, if they miss it, we'll send them the YouTube link later. And for sure, we'll evolve this thing.
Yes, Ashish.
Nothing more to be said. He has actually done over 300 cases of Mucor in the last 6 to 7 months already. Today, last night when I spoke to him, he had 10 cases. They have become 13. I don't know, by the time he starts finishing his 3, there may be 3 more added. But we will decide on the censorship timeline, maybe midnight. I don't know, he'll go on through the night. For the record, Satish has not stopped work for a single day in the entire COVID pandemic. He is an addict of surgery. He has to see blood. We call him the Dracula, the vampire. Unless he sees blood every day, he cannot sleep. So he's been doing good. He's been brave. I bring this point only for people like me and many like me who were a little scared or skeptical about going out there and performing all the surgeries in the routine way. Here is the man who, of course, we saw doing so many webinars, but at other times also, he's doing routine surgery. This is to inspire a sense of confidence and destroy the fear that we have. We know that if we wear the mask right in the nose, I think we are well. Beyond that, there is nothing to this pandemic. Thank you, Arpit. When they come, I will introduce them. I don't mind. Will not interrupt any of the academic thing. When we get a free time, we will. Thank you.
Thank you so much, sir. So I think we will just move on to the academics now. So I will invite Dr. Satish Jain, Director of Jain ENT Hospital at Jaipur. Sir, you don't need any introduction. You are the most prolific surgeon in India as of now. And over to you, sir.
Thank you, Arpit. And indeed, I am grateful to the organizing team. Special thanks to Virendra Gaisas for this innovative idea and Dr. Ajay Devfode. And obviously, Ashish Bhumkar has been instrumental in all these events. And he had a lot of things in his mind to formulate some guidelines from ENT point of view. And this was one of them, because this is a hot topic about a proper management of this condition. And before we start, let me introduce some special guests today who are going to enlighten us from the ophthalmology side, because this disease is a dreaded disease and it involves eye early in the course. And let me introduce my dear friend from Jaipur, Dr. Harshul Tak, who is a prolific ophthalmic surgeon, highly academic oriented. Of course, he is a very important cricket player in my team. We are playing together for last 25 years. And we call him troubleshooter in our cricket team. When we all get out, he is the one who would carry forward. So Harshul, you are welcome. And let me have the pleasure to introduce someone. I call her the most powerful lady in the ophthalmic field, Dr. Namrata Sharma, who is here with us, who is a senior professor in Rajendra Prasad Ophthalmic Institute in New Delhi, who has more than 500 publications in the best of the ophthalmic journals in the world, who is a highly experienced, you can imagine, and she is here to enlighten us some ophthalmic aspects about this dreaded disease. And any of the questions coming to us with ophthalmic regard to the ophthalmic issues, she is here to answer. Thank you very much, madam, for being with us. So before our guests come, like Ashish says, to start with,
Satish,
yes,
we have few moderators from our side for this
yes,
lecture.
yes,
And then we have Dr. Ramesh Murthy with us. He's
yes.
the
Welcome, sir.
extraocular ophthalmologist from Pune.
Yes.
And he's also done a great job of Mucor in Pune. And
I can see Kirtner sir on screen. Kirtner sir is our father figure for
yes.
I can see him on the screen. Thank you, sir, for being with us. Your blessings are always important. Thank you.
So we will have a multidisciplinary kind of interactive session also. And apart from the ophthalmologist, infectious disease specialist at Hinduja Hospital, Dr. Aisha Sonawala, she'll be also joining us for a brief period to give some good take-home messages.
Right. And Ramesh is already with us. So great.
Dr. Shrikant Shinde, our Member of Parliament, he's joined. Shrikant, hi, welcome. Shrikant.
Yeah, hello, Dr. Bunkar.
Hi, Shrikant.
Yeah, hi.
Thank you. Thank you for joining. And Dr. Satish Jain is there, and our senior godfather, Dr. Kirtane, and many of our friends from the ENT. Thank you, Shrikant, for being here today and being at the scheduled time. I was telling before you joined that we are distinctly lucky in Thane that we have such an expert. Shrikant was known for his orthopedic prowess, his cerebral brilliance, and also a gifted surgical hand. But now he's a two-time MP, and I think he only partially goes to the hospital once in a while. But he's a fantastic and a fair conduit for all the issues that doctors face. And he's not just pro-doctors, but he's just very fair. He, as IMA or anybody in Thane is going wrong, he will point that thing wrong, where last time it came on PPEs and, the other billing parts and other things. Shrikant is there to give a fair sense of justice, and he helps us to get Thane on the right track in the medical space, besides, of course, doing the other things. Specifically, Shrikant, because as you know, and I share with you, Mucor is also becoming a sort of a mini epidemic, especially in India. And Satish is going to start this. If you wish to say a few words, through you, at least in Thane or Thane district and Kalyan Dombivli, we would like to set up a pilot study of a Mucor management protocol, maybe a small task force where ENTs can play a big role in probably minimizing. And one thing I forgot in the previous introduction, why I have to compliment Ajay and Viren for this. There apparently have been many talk shows that are happening on Mucor. This surgical exercise, this surgical thing is the first of its kind in the country. And this actually is the key thing. Doing a complete debridement, just removing some Mucor is no good. Even if you leave 1 square millimeter or 5 square millimeters of Mucor behind, you have lost the game. If you undertake surgery, it has to be a complete radical, and that Satish will highlight that point, how a radical removal of the entire debris of the necrotic tissue will actually give amphotericin the chance to work, or then give it the curative edge. This, I think, is the soul of today, because many incomplete surgeries, I think Satish is doing at least 30% revision surgeries. Correct, Satish?
Yes.
More than 30% are revision because somebody had just done some minor debridement here and there. And we are going to see a case of a 35-year-old bilateral blind lady and skull-based osteomyelitis. So one has to be a very aggressive surgeon and go behind this Mucor in a very aggressive way. Therefore, this surgical workshop, I think, is going to be the key. Shrikant, for your knowledge, already 3,000 ENTs from India and around are already logged in. And this will swell up in an hour's time to about 10 to 15,000 people from all across the region and the world. So if you want to say a few words, Shrikant.
Thank you, Dr. Bunkar, for inviting me for this session. And I think this session will be very much useful and helpful as a doctor also and as a public representative also, because this Mucor thing, mucormycosis, is becoming common now. I have also seen many number of cases in Thane region post-COVID. So I think the protocol management for the COVID and post-COVID management as we were earlier planning in breathing exercises in for post-COVID. Now we have planned for this mucormycosis thing also, which has become prevalent in diabetic patients, and because of the excessive use of steroids also during COVID treatment. So it will be very much useful for us as a public representative, and also to devise a protocol so that this mucormycosis can be prevented before it happens. And thank you, Dr. Satish Jain ji. Special thanks to him because he is the main.
He is the master surgeon.
Master surgeon here would be demonstrating, talking about mucormycosis, and looking forward to learn more thing about mucormycosis so that we can help in prevention of this and also cure of mucormycosis.
The amphotericin cost per day goes to almost 25 to 30,000, and you have to take it per day. When now this is going to be an additional burden. So you have to work. Already the stocks are getting, this becoming like remdesivir and tocilizumab.
But we have to see that if we can prevent this mucormycosis also, that will be much better, because I think people are diabetic here, most of the people, and also the use of steroid here. Yes. Because every patient admitted for COVID has been given steroid. So this protocol has to be, I think,
your next headache is amphotericin, just like now tocilizumab and remdesivir. The next headache for you people is going to be amphotericin B.
Right, very much. Yeah. So we can start the session, I think.
Yeah. Okay, Satish.
Thank you, Shrikant sir, for your kind words and your insight. We can make out so deeply involved you are. Thank you so much. So coming to the topic, before we start the live session, we have a number of cases lined up. We'll start with the basics to some more advanced and revision cases, like we always do in our webinars, so that we can get oriented from beginning. So the question today, why we are gathered, is why mucormycosis surge is there right now in this COVID-19 pandemic. This is what we have been seeing for last almost a year now, and there have been a lot of efforts, giving indications why COVID-19 is responsible for this surge of mucormycosis. Though there are a lot of indirect evidences now are available in hand to associate COVID-19 with the mucormycosis. Mucormycosis, we all know, is a disease we know for years and decades, which involves an immunocompromised individual. This is a fungus which invades immunocompromised individuals, particularly the diabetic mellitus, which is the most common immunocompromised condition. Besides this, a lot of other conditions affecting the immunity, like transplantees, organ transplantees, neutropenic patients, other malignant hematological disorders, and other things which can invite the mucormycosis. But why particularly? This has been going on for years. But why this sudden surge in COVID-19 pandemic is important to know and understand. Why this is not moving? Yeah. So COVID-19, we all know, targets immunity. It has association with immunosuppression due to several reasons. We all know in all COVID-19 patients, it targets the T lymphocytes and results in lymphopenia, which is an important part of our innate immunity system. Reduced CD4 and CD8 counts are seen in more than 80% patients of the COVID-19 affected patients. And this is one of the strong reasons to suppress the immunity of these individuals. This is not the only reason. With COVID-19, especially diabetic patient with added immunosuppression, along with corticosteroid therapy, adding on to the immunosuppression, result in this overall, infestation of this dreaded fungus mucormycosis. So COVID-19 itself, by means of several ways, leads to reduction in immunity, and lymphopenia is one of them. It leads to inflammatory cytokine surge, particularly interleukin-6, which leads to surge of ferritin. Ferritin is a very, very important molecule here when we are discussing mucormycosis, because mucor is the fungus which requires iron to grow. For its survival, it needs a lot of iron. Interleukin-6 surge leads to hyperferritinemia, and which leads to a lot of intracellular accumulation of iron, and that free radical surge leads to iron in the free iron in the serum. There is usually no free iron in our serum, and the mucor, even if it goes in the serum, doesn't survive without iron. With this surge in hyperferritinemia patient, there is huge amount of iron for the mucor to grow, and this is one of the strong regions. That's why you see a lot of physicians after the cytokine surge getting ferritin levels, and those are the patients which are susceptible to mucor particularly if they are diabetic and if they are taking steroids and other things. So it's a complex interplay of so many things. COVID has known to induce endotheliolitis. Endotheliolitis means direct attack by the viral load on the endothelium cell, leading to raw endothelium, inducing prothrombotic state because of the raw endothelium inviting thrombogenicity, inviting thromboembolic events, and that leads to a lot of de novo cases without even mucormycosis. There are lots of publications showing lots of thromboembolic event leading to morbidities, like Madam Namrata is here. A lot of reports of central retinal artery occlusion because of the COVID-19 thrombogenicity, thromboembolic events. So such events have been published. They do happen because this induces a prothrombotic state. And in the mucor also, mucor has a angio invasion capacity. It preferentially invades the vessel, and that leads to fibrin plaques, blocks the vessel and the blood supply of that particular area, and leads to necrotic eschars. So this prothrombotic state is already induced by COVID-19, with further corticosteroid and diabetic results into this mucormycosis infection. And this COVID also, it has an effect on the beta cells of the pancreas, and has recently been reported, leading to insulin resistance and inducing a pro-diabetogenic state. A lot of patients not being chronically diabetic develop diabetes after the COVID-19, added with the corticosteroid therapy, and ultimately develop mucormycosis. So this is something which cannot be ignored. So COVID is indirectly, along with the corticosteroid and the diabetes, mostly in the diabetic patient, is responsible for this kind of mucormycosis surge, which we have been knowing and seeing for the last couple of months. Now, how the diabetes affects? Diabetes, we all know, is in itself is a pandemic. It's a global pandemic, and diabetes affects the immunity by several means. The most important, which is relevant to the mucormycosis, is the impaired neutrophilic function. This mucor is ubiquitous in the air. It is a normal commensal in our nose as well, but it doesn't invade the tissues as the immunity is normally good. But when the this immunity is served by the neutrophils. Whatever this mucor spores coming to the nose, whatever we inhale, are taken up by the phagocytes, neutrophils, and expelled. When the immunity is at stake, when the neutrophilic function is impaired by means of diabetes, by means of further corticosteroid therapy, by means of COVID-19, the added immunity suppression, this impaired neutrophilic function allows this mucor spores to germinate into hyphae, and which are invasive. That's how it invades the nasal tissues first. This nasal and pulmonary, mucormycosis starts with the nose first, because it is due to inhalation of the mucormycosis spores. And that's how the impure neutrophilic activity allows them to germinate into hyphae and invade the tissues. So diabetes is the core thing, and majority, more than 95% of the mucormycosis presently are in diabetic patients because of this sole reason. Along with this, diabetes results into certain other regions leading to the mucormycosis. As I mentioned about the iron, ferritin level. In diabetic patients, when there is particularly ketoacidosis, the transferrin, as I mentioned, the iron is nowhere in the serum free. It is bound to the proteins like transferrin, lactoferrin, ferritin. This diabetic ketoacidosis doesn't allow the binding of transferrin to the iron. The free iron is there in the bloodstream, which is important for the survival and growth for the mucor, and that's how it promotes the growth of the mucor by means of preventing the binding of iron to the transferrin. This is one of the reasons. Another reason why mucor preferentially invades the vessel, that is simply because of the increased glucose regulated protein 78. This is found in the endothelial vessels, and this mucor has a receptor of this protein to invade the endothelium vessel. It enters the elastic lamina of the vessel, induces the fibrin plug, and ultimately blocks the vessel, clogs the vessel, and the further blood supply of that vessel is blocked, resulting into necrotic coagulative necrosis in the necrotic areas, which are required to be, removed by the surgical means, because all those necrotic area loaded with the fungus, there is no penetration of antifungal drug, for which surgery has a main role. That's why we are here, to know the fine nuances of the surgery, to discuss in detail. So there are so many reasons why diabetes is so important and induces this this mucormycosis during this COVID-19 immunosuppression pandemic. And most important, added on to this, like Dr. Shrikant Shinde mentioned, the judicious use of steroids. That is the key factor now, number one factor now, inducing mucormycosis. We all know steroid is an important tool in the COVID-19 management to curb the inflammation induced by the cytokine surge due to COVID-19. See, steroid doesn't kill the COVID-19. It curbs the inflammation induced by the COVID-19 related cytokine storm. Now, what is happening everywhere in the country, or maybe everywhere, the moment the patient is diagnosed with the COVID-19, the fear factor is so much. There is no direct drug to combat the COVID-19. And many a time the physician give a cocktail therapy. Cocktail means as an antiviral, there is a broad spectrum antibiotic, there is a steroid, there is an anticoagulant, and number of drugs are listed in the prescription for a disease which has no treatment so far. And what is happening with the broad spectrum antibiotic, antiviral, and particularly steroids, all ultimately attacking on the immunity. And steroids have a huge impact on the function of neutrophil, for their chemotaxis, for their migration, for their toxins release, and everything is related to the neutrophils, and everything is suppressed by the steroids. So COVID-19, diabetes, and added steroids, this triad of these three is leading to this surge of mucormycosis cases. This is what we have understood so far. So steroid is an important drug, but should be judiciously used. Like Ashish said, to formulate some guideline to some suggestions to the government, steroid should not be given in the early course of COVID-19 disease. Steroid should not be given for the mild cases of COVID-19. Steroid should be reserved when there is cytokine surge on day 5, day 6, when the viral replication has happened and the cytokines are inducing the inflammation involving the chest. At that time, there are guidelines from the Indian, society to give a particular dose of methylprednisolone or dexamethasone every day for 3 to 5 days. But what is happening by and large, the patients have been advised steroid from day 1 to day 10, day 15 for the fear of, because there is no drug, at least the steroid is working without knowing the future consequences. So steroid should be judiciously used during the COVID-19 course of the treatment. And then post-treatment, that is a very, very important time where the otolaryngologist should pitch in. Rather, I would recommend all cases, particularly diabetic patients, particularly those patients who had cytokine storm, who had huge, lung disease, who had undergone ventilation and other major treatments, must be followed periodically to the otolaryngologist to look for any possibility of early mucormycosis developing. That is why we have gathered here. Like Dr. Shrikant Shinde already mentioned, the early diagnosis of the disease is the key. Because this disease is known to catch the nose first. The earliest symptom come to the nose. Then, if it is not diagnosed, not treated, it spreads to the maxilla, the surrounding bones, and then to the orbit very quickly. We have seen so many patients coming with a blindness, unilateral, bilateral, simply because of mucormycosis, undiagnosed mucormycosis. Those patients who have been treated for the COVID extensively with the steroids, without proper glycemic control, without proper blood sugar control, that is the key to the entire management. And that is how this huge surge of mucormycosis cases we are witnessing. So we need to be very careful during the treatment of the COVID-19 patient and keep an eye, particularly on those high-risk situations. Like these are listed high-risk situations. These cases should be kept under close observation even after the post-treatment. Even after the patients have been free from the COVID-19 treatment, like patients having neutropenia, patients who had earlier high interleukin-6 and ferritin level, who had been treated with a steroid for long, who had undergone this tocilizumab treatment as a tool for cytokine surge, which has not been proven so far. But let me say, no single drug has been known so far to work on COVID-19. In spite of that, so many treatments are going on, and without knowing the fact that that may have some adverse consequences on the patient later on. And that is what we are discussing, the sequelae of COVID-19 here today. And one of them is mucormycosis. So all these patients are high-risk patients, should be followed post-COVID treatment to the otolaryngologist on a periodical basis. The reason being, these patients, the best treatment for these patients are reserved when they are picked up in the early course in the nasal phase. When the mucor invades the nose is the earliest phase which can be treated easily without needing of too much of treatment, too much of surgical debridement, and too much of antifungal treatment. And how you can pick up? We have to make some sort of awareness to these patients. Any diabetic patient, post-COVID particularly, having complaint of excessive dryness in the nose, excessive crusting in the nose, any sort of, paresthesia, anesthesia on the nose, on the face, and the teeth or surrounding region, anywhere, slightest of these symptoms are pointing to the mucor inflammation, mucor infestation. And the otolaryngologist, if he is following with the endoscopy, the earliest sign to pick up the mucor is the excessive crusting in the nose. That should raise the suspicion of the mucor. We should have a low threshold in diagnosing the mucor in such situation on endoscopy. And once you have any slightest suspicion, the next investigation to order is a gadolinium enhanced MRI. That is the need of the time to diagnose this disease earliest in the course. A lot of people having this kind of finding or suspecting the mucormycosis order the CT scan. Believe me, CT scan has big zero role, no role in the diagnosis of mucormycosis at all. The reason why I'm saying is the treatment of mucormycosis involves debridement of the necrotic or devitalized tissue so that you make the situation permeable to the amphotericin or the medical treatment. Because this disease, the mucormycosis, preferentially invades the vessel. It blocks the vessel, blocks the blood supply, and that blood supply going to that particular region, area, the mucosa, bone, nerve, lymphatic tissue, whatever it is, gets necrosed. And a necrosed tissue without having any blood supply is not going to be treated by any amphotericin or anything. Nothing is going to work. So there comes the role of surgery. So before surgery, the workup is so important. The reason being, like Ashish has already mentioned, the goal of surgery, if you see carefully, the goal of surgery is the removal of the devitalized tissue so that you can improve the penetrance of amphotericin to the rest of the area. The second goal of the surgery is whatever involved tissue, whatever maximum you can remove safely. It doesn't mean the radical removal of an enhancing area. And obviously to establish the histopathology. So the goal in the treatment, the first goal and the important goal in the treatment is to ascertain the areas which need to be debrided. And how can you ascertain? One and only means the MRI. Let me tell you, MRI is life-saving to these patients. Because MRI, once you get a gadolinium enhanced MRI, the gadolinium will reach only to those areas where the blood supply is on. Those necrotic areas, which is blocked by the mucor thrombus, those areas are the areas where the gadolinium is not going to reach. So, how can you pick up easily what areas need to be debrided? Get a gadolinium enhanced MRI. Those areas not showing contrast enhancement or showing lack of contrast enhancement are the areas need to be debrided. As simple as that. And if you are able to do that, rest of the areas which are enhancing need not to be unnecessarily debrided. those areas which are enhancing on gadolinium, where the gadolinium is reaching, that your amphotericin will also reach. Why to unnecessarily debride and give morbidity to the patient? That is the role of MRI, which cannot be served by a CT scan, as MRI gives a lot of soft tissue details, which I am going to share with you where the first case starts. So the goal in the workup is to have a complete idea that what need to be debrided. We are not supposed to unnecessarily debride every enhancing area because the gadolinium is reaching or amphotericin will also reach, and that has an important role in the treatment. Post-surgery, in a full dosage when you give amphotericin, actually this is a medical disease for the which the treatment, the gold standard treatment is antifungal, that is amphotericin, the most potent one. Surgery is not the answer to this problem. The role of surgery is just to facilitate medical treatment by means of removing only devitalized area. Like we are dealing with the gangrene. Just simply we are dealing with the gangrene. The drug is not going to reach. That is the source of infection for the propagation of the infection. Because this infection is so dreaded, in no time it reaches eye. It can involve the eye by contiguous involvement. Without contiguous involvement, even it affects the eye, it can lead to blindness by means of fungal emboli and reaching to the central retinal artery. A lot of cases we have seen, we have so many patients admitted with the blindness with no contiguous fungus in the orbit. So, and further from the orbit through the orbital apex and by perineural and perivascular area, it can easily go to the brain. We have patients which has already given, this mucor has already given infarction. So the goal of the entire workup, to understand this disease, we have to understand this triad of mucor, this triad of COVID, corticosteroid and diabetes is responsible for this mucormycosis surge. And the goal of treatment, the first role is surgery to remove the devitalized tissue, and that is decided by the MRI. If after surgery or in surgery you are not able to remove the complete devitalized tissue, you are back to square. That load of fungus will remain inside the devitalized tissue and it will keep on propagating the fungal infection further very fast. Like Ashish earlier mentioned, you have to be very, very careful while executing your surgical process so that you completely remove the devitalized tissue, and then amphotericin work like some magic. So if you see the literature, the mortality rate of mucor varies from 30 to 80%. And majority of those publications, if you see, they've never ever considered the MRI as a tool to diagnose what area need to be debrided. That's why the high mortality rates have been described. In our hands, in last 1 year, we have dealt with more than 300 cases now with mortality rate less than 1%. Believe me, the single reason behind that is the extensive debridement of the necrotic tissue. We have debrided so extensively the skull base bones, both maxilla, entire cribriform plate, entire frontal bone, entire cribriform plate, everything soft tissue hanging, the eyeballs, brain, everything hanging and reconstructed with the soft tissue. But the success was simply due to removal of the all non-enhancing areas according to or guided by the MRI. That is the key to the success of the surgery, to have a good MRI, to get a complete information about what need to be debrided, what need not to be debrided. Like for an example, this in this first patient. This patient is a 55-year-old lady, the diabetic, had COVID a month back, had been given steroid, had ketoacidosis. Develop ketoacidosis because many of these patients from day one were given steroids as a home treatment and on OPD basis, and they were given steroid without proper monitoring of the blood sugar. Most of the time without proper monitoring of the blood sugar, and that is the result how the immunity is targeted by the steroid. So she developed this disease and presented to us with facial swelling, pain, excessive nose block, crusting and all those. This is the first case, the basic one, without involvement of the vision. The vision is still intact. Next, the cases coming up are all having vision loss. One of the cases had extension to the cranial cavity, all those in the order. So now you see, this is a contrast MRI. Let me show you separately. This is a contrast MRI. What I want to show, See this? Can you see this black areas? Compare with the opposite side. Ashish, can you see?
Yes, Satish, very well.
See the opposite turbinate.
Yes.
Turbinate has a good blood supply, and see how it is enhancing with the gadolinium. Can you see? And now see on this side what is happening to this turbinate? Completely black. This is classical black turbinate sign because the turbinates are the earliest structure which are affected by the mucor. You put your endoscope in the nasal cavity, the first structure you will see in the lateral wall, the turbinate affected by the mucor, loss of blood supply turning jet black. And that is what you see on the gadolinium enhanced MRI. And see here, the entire turbinate has gone black. This non-enhancing tissue in the maxilla and the classical feature as compared to the routine sinusitis, what you can pick up on MRI. See, our all patients are diagnosed on the radiological basis, not histology. Histology we'll take now intraoperatively. There are certain characteristics by means of which you can pick up the mucor so easily. Number one, this black turbinate, the black area loss of contrast enhancement as compared to the opposite side. Number two, perisinus inflammation. See this inflammation extending beyond the sinus. That is classical, which is never something you will see in a routine chronic sinusitis where it is limited by the bony blocks all around. That is classical of this. And third is, it has a preferential, involvement of the certain areas. We have seen in last 1 year, the variety of situation. It has this we'll show today in the couple of cases. This mucor preferentially affects certain areas. It preferentially affects the maxilla, the upper alveolus particularly, behind the maxilla, the sphenoid bone, which is most commonly affected after that. And in the sphenoid, the most important area is the pterygoid process. This pterygoid process, floor of the sphenoid, and the greater wing of the sphenoid is one of the most commonly affected area by this COVID, leading to the osteomyelitis of this bone. And if during surgery, if you are not able to remove that dead bone, osteomyelitic bone, you are back to square. We'll show a couple of cases, revisions today. We have been operated and the patient is still experiencing complications. One of the patient was operated 2 days before and somewhere, and yesterday presented with a vision loss after that. And we got the MRI done and the huge non-enhancing area at the skull base, which was not addressed earlier, as the patient was operated on the basis of the CT scan, not MRI. So there are certain facts we need to understand to treat this problem properly, to improve our results, to understand the science, to understand the need of MRI, and then to address adequately by the surgical means, and then followed with the medical threpy. So before we move on to the first case, we can take question, discussion, or anything.
Satish, 2-3 points. I think you say when you do complete debridement, the need for amphotericin is for less number of days.
Yes, obviously. Yes, Rashi is a good question. See, I've seen patients being treated in the medical units with amphotericin for 1 month, 1.5 months. Not exactly. This is not needed. We have treated hundreds of mucor patients now with amphotericin for maximum 7 days. The reason being the adequate debridement of the devitalized tissue, adequate debridement of the enhancing areas, which can be safely debrided without adding on to the morbidity to reduce the bulk of the fungus, so the fungus, the antifungals can work better. We have been able to stop amphotericin in 5 to 7 days and then switch over to the step down therapy of posaconazole. That is how, and we always monitor it with our, parameters, inflammatory parameters like CRP and ESR to see the results, and then we stop the amphotericin. So, if you do an adequate debridement, the need of amphotericin is much, much reduced rather than unnecessarily giving the amphotericin for months together, which is not warranted. That is deadly.
Any role for preventive posaconazole?
Yes. Oh, great, man. See, there are certain areas, difficult patients, I would say, and I will mention that subset of patients. If you keep a close eye on those patients, that is the need of the time. What Shrikant sir said in the morning to prevent this mucormycosis, and we have time to understand and learn this fact to work on it. Those diabetic patients, uncontrolled diabetic, immunocompromised, neutropenic, particularly having, high cytokine levels, interleukin 6, ferritin, whatever. So the high risk category patients who have huge, CT score, lung involvement, need of mechanical ventilation, sometime other treatment. So all those high risk patients, it is better to start giving a prophylaxis of posaconazole. It has been mentioned in the European guidelines recently published in Lancet that we should start posaconazole 200 milligram 3 times a day at least to prevent this fungus development. So that is a good strategy, I would say, to think of prevention in those high risk category patients, only for those patients.
There is a gel, amphotericin gel, Satish, that is available for 200 rupees. Any role for that?
What is that? Gel?
Can we start my video, please, Dinesh? There's actually an amphotericin gel which comes with a syringe. Dinesh, can you start my video, please? I want to show the gel.
Okay, let's see. Gel means a sort of ointment or something.
Ointment, yeah. It's an ointment in a tube with a syringe to be applied.
Local application.
For local application, yeah.
Yes. So, Ashish, we do local application post-surgery, not gel, which I'm seeing for the first time. Yeah. But what we do, we pack the cavity with a simple amphotericin deoxychelate solution, which we otherwise don't use for intravenous infusion now as the liposomal is available, which is more safer. But for topical use, we pack the cavity with the amphotericin. So this gel is a good idea, which can be kept to the raw areas with the areas involved by the fungus to have an added effect.
Applicator, like this it is coming. I don't know if that's seen.
Yeah, that's a good idea. That's a good idea.
Viren here. There is one question. Yes. Why mainly the India which is affected with mucor? Because we have not seen hardly anybody from Europe who is saying mucor. It's a basic hygiene.
Indiscriminate use of steroid, number one. No guidelines being followed, unfortunately, sorry to say. And number two, not a proper glycemic control of these patients.
Okay.
Blood sugar control and judicious use of steroid is the key to prevent this disease to a major extent, I would say. It's not that it is not there in the Europe and other countries. It is there. A lot of publications coming from there, but not to that magnitude than what we are facing here. And simply because of indiscriminate use of steroid. You see, out of 100 prescriptions, 90 prescriptions carry steroid from day one when the RT-PCR turns positive.
True.
There's a real story.
So indiscriminate use of steroid combined with not a proper control of the sugar. Both.
Sugar. See, if you are prescribed steroids on an OPD basis, and visiting doctor after 5 to 7 days, who is taking care of the sugar? That part is totally overlooked, and that is the reason why we are seeing this surge of mucormycosis cases.
I think Satish will take the other questions when you are operating, because you have series of cases. So with the permission of Ajay Doifude, should I request Satish to start the case?
Satish, please, if you don't mind.
Yes.
Would you, Satish, is there the need control for those who don't have COVID yet and they are diabetics? Should the message go that they should be reaching out to their diabetologist and keeping their sugars under control?
Yes, very, very important.
It will probably minimize their getting a mucor.
Yes, obviously. And we should propagate this request to our all treating physician to advise all these diabetic patients, particularly recovered from the COVID, to visit otolaryngologists on a periodical basis and keep an eye on those early symptoms. So this disease can be, picked up in the earliest stage when it is in the nasal phase.
Satish, before you start, for a prevention, you will advise something like a neti or a saline sprays for a prevention to keep a nasal hygiene. What you are suggesting for a prevention for a nasal hygiene?
Yes, Virendra, that is good. You do a nasal, saline irrigation or whatever. But this disease is targeting the immunity. We have to work at the, level to improve the immunity, to keep an eye on the immunity for any immunocompromised condition, to bring under control. See, because the outcome of the treatment depends upon the control of the underlying cause. That's why diabetic patients enjoy the best prognosis, because once develop, you can control the diabetes. That is the easiest thing one can do. But those patients who develop mucor after organ transplantation, hematological malignancies, leukemia, lymphoma, that underlying condition cannot be reversed so easily. Or sometimes it is impossible to reverse, and those are the patients carry the worst prognosis. So diabetics are most common, and we have to focus on that to control the glycemic status. Yes, sir. Kirtane sir is saying something.
No, both Sandeep and I, we've got about 100 questions here. So when would you want us to ask you those questions? Because when you're operating, you'll be giving us,
sir.
You're going to be talking about what exactly you're doing. So we just wanted a cue as to when should Sandeep and I ask you those questions. People have sent in almost 100 questions, just for us to understand when these questions should be asked.
Yes, and sir, for everyone's information, our telecast is simultaneously running on the Global Rhinology Network as well, which is, today is a workshop, 2 days workshop there by Dr. Ashok Rokade. We are thankful to Dr. Rokade for involving us, and this entire telecast is going simultaneously to the Lions Network.
Wonderful.
So I would like to say something. Coming back to Kirtane sir's question, when do we address those queries? So I think most of the queries will be repetitive. So I think it will be the job of the moderators to kind of select the appropriate ones and place them at the appropriate surgical step, and so that we have good time management. Otherwise,
so Ajay, sorry to interrupt. I wanted to know, do you want us to ask the questions
during the surgery?
Do you want to ask us the questions at the time of surgery, after surgery? When do you want us
Or we can go on?
Sir, anytime. Feel free anytime, sir.
During surgery, sir.
During
at the time
surgery.
of surgery. Yes.
Okay. Surgery shuru kar.
Okay.
Okay, thank you, Satish sir, for such a nice comprehensive talk on mucormycosis. In the meantime, when you go to the OT, we can invite Dr. Ramesh Murthy sir.
The case induced, Satish.
Yeah, the case is induced. I can start in 5 minutes if you want.
Yeah. So by the time Satish, you scrub and start.
Yeah, we can take questions.
Yeah, Arpit will invite the moderators for the.
Okay, we can take questions meantime as well.
For the first surgical case, Dr. Milind Kirtane from Mumbai, sir, needs no introduction at all. He is Padam Shri recipient and a mentor to all of us over here. So, sir will be conducting this first surgery along with Dr. Sandeep Karmarkar, who is a senior ENT surgeon based in Pune. Dr. Karmarkar has a special interest in lateral skull-based surgery and anti-skull-based surgery. So, welcome, Dr. Kirtane, Dr. Karmarkar. In the meantime,
Thank you.
Dr. Ramesh Murthy.
Yes, sir. Tell me, sir.
Yeah, Dr. Ramesh Murthy is also here. He is a senior oculoplastic surgeon based in Pune. Sir, would you like to offer some comments?
Sir, I think Dr. Satish Jain spoke very beautifully and has highlighted the great pandemic that we are facing. So when we talk about the eyes, for the eyes, it's a very devastating condition because not only there is loss of vision many times, but also we have to remove the eyeball just to eliminate the disease. So I think, as he mentioned, early signs and symptoms are very important to understand and to pick up. So apart from the nasal signs, I think the first thing that we need to look for is, from the patient perspective, severe pain behind the eyes or one-sided headache. Then secondly, when we look at the signs, they might have subtle lid edema, lower lid and upper lid, mild ptosis. Many of my patients are presenting with mild abduction limitation, that the eye does not go completely towards the side. So maybe a slight early lateral rectus palsy. Sometimes they have other involvement of other ocular movements like limitation of adduction, abduction, elevation, depression. After which, of course, they may have some kind of blurred vision. Sometimes they will go to the advanced stage where there is complete ptosis, and sometimes a complete ophthalmoplegia, that is, the eye does not move at all. And of course, once the inflammation and the fungus starts proliferating inside the orbit, they'll have proptosis. So I think it's very important to understand the high risk group who will be actually at high risk, who may get the disease, So we need to watch out for those cases. And we also need to understand the early eye signs to prevent any kind of infection. So what we have been doing is, instead of doing exenteration or removal of the eyeball and contents for all the cases, we have been doing limited debridement or just trying to work on the focus areas where there is excess proliferation of the fungus, like the inferior orbit or the medial orbit. So we go ahead, do a limited orbitotomy, remove the fungus and remove the diseased bone. And we use an amphotericin gel inside in that region locally before we close the tissues. So this has helped us in improving many of the cases. In all the cases, we try to do a medial orbital wall decompression. Now, how this helps is this will relieve the pressure on the optic nerve. So because there is inflammation inside the orbit, what will happen is that the optic nerve will get compressed, and this will get relieved if you do a medial orbital decompression. So my video cannot be started, sir. I think you've blocked my video. So if you can start the video,
can you please... Are you getting this picture, surgical picture?
Yes, I can get the picture. Yes, sir. Yes, sir.
Dinesh, can you please start Dr. Murthy's video? Sir, a quick question to Dr. Ramesh Murthy. Sir, do you use local injection of amphotericin pre-debridement or post-debridement?
Sir, in my experience, about 69 or 70 cases of orbital mucormycosis, I tried initially, maybe 1.5 months ago, giving intraorbital amphotericin B on a daily basis to about 9 patients. Unfortunately, it has not worked at all in these cases.
Thank you.
And there was increase in the proptosis and chemosis and the disease over time. So somehow, as Dr. Satish Jain mentioned, the immunity is so bad in these cases that this intraorbital amphotericin B does not seem to work.
Okay.
In these
sir,
cases.
one more question. As Dr.
Arvind, can I just ask Dr. Murthy a question?
Sure, sir. Please go ahead.
What happens is you have orbital involvement, ophthalmoplegia, but the eye vision is not gone. So the decision when to exenterate, when not to exenterate, can you give us a little guideline on that? Because that seems to be a big problem to take the decision. If the muscles are involved and the eye is immobile, but the vision is present. Because with the ophthalmoplegia, diplopia comes in, and very often you have to shield the eye. So there's a lot of confusion on when to and when not to exenterate. So any thoughts on that?
Sir, in my series of about 70 bad cases of rhino-orbital mucormycosis, I have done exenteration for 19 cases, which is like 25 to 30% of the cases. So most of the cases have ptosis, they have ophthalmoplegia. There is no loss of vision in most of these cases. So if that is the situation, then we don't want them to lose the organ. We go ahead with limited debridement and we try to save the globe if possible. And of course, medial orbital wall, we remove it completely.
No, if the eyeball is not moving at all, then the double vision is what is bothering them. So very often then you need to shield that eye. So it's not something that we are very clear about. So from your point of view, if there is vision, but the eye is immobile, you would still save the eye.
Yes, if the vision is if the eye is immobile, I'll still try to save the eye. One of the things that you can do is to give them prismatic glasses if it helps them in any way for a particular distance, like for near or for distance. But many times, the trauma of losing the organ or the eye itself is so psychologically devastating for the patient that we have to think twice before we go ahead and remove the eye. Of course,
my problem is this patient has got severe diplopia. So if you keep that eye, he's not, because of the diplopia, he's uncomfortable. So what do you do in these cases?
So in such cases, I would not remove the eye. I would rather give them some kind of occlusion on their spectacles. That is a very good option for them to continue with their daily activities. So if your central vision is blocked and if they have their peripheral vision, then they can do all their activities reasonably well because the other eye field of vision is good enough to help them do the work. Of course, they will have loss of depth perception, loss of stereopsis, but then they will get adjusted to that over time. So I give them occluded glasses for the time being. We have other options also like occlusive contact lens, but again, that is difficult to manage. I would not remove the eye in these cases, sir.
Hello?
Yes, sir.
Are you getting the picture, sir? Endoscopic picture? Hello?
Yes, sir.
Yes, sir. We are getting.
Yeah, Dr. Satish.
Yeah, Satish, we have the endoscopic picture. We saw you cauterizing those slight bleeding areas on the septum.
Great.
Okay, we've got
So
you.
now, what we see here, we saw the MRI. We saw the turbinate necrosis on this side. Can you see this black turbinate?
Yes.
Yeah,
This is the middle turbinate, which is most commonly affected. See the black turbinate. Now the surgical strategy, like we have several times mentioned, this radical debridement means you need to remove all those necrotic areas under vision. You're not supposed to leave even a square millimeter of the centimeter of the necrotic area for the disease to propagate further. And number two, to keep an eye post-op for any need of further debridement. So you need to have your cavity under vision so that you can monitor post-op as well. And third is to apply topical amphotericin or anything, but that is all possible only when you can monitor the cavity. You have a cavity in front of you. And the biggest obstacle is the medial wall of the maxilla. Here the indication for removal of the medial wall of the maxilla is different. It is not for any tumor removal like we do Denkers for many other regions. Here the role of this excess is to remove the entire necrotic bones, osteomyelitic bone, necrotic tissue under vision so we don't leave anything behind. And number two, to keep surveillance.
Acidity क्या असं काय झालं नाही ना?
Keep an eye, surveillance post-operatively so that you can tackle the situation further in case need arises. Okay?
Yeah, so Satish, the first question that comes is related to this.
Yes.
Do you remove only the affected area or would you remove the surrounding areas to have better access for post-op? For example, if you have a sphenoid involvement but the onodi cell is not involved, would you clear the ethmoids to give better access? That means, are you going to open up unaffected areas? That is the question now.
Yes. In case is coming in the way to, impede my post-operative surveillance, it is better to remove. And that is what I have started here. See, I am removing this medial wall. It is not affected by the mucor, but the tissue behind is affected by the mucor. And if I don't remove this, I can't see that tissue, that area head on. I can't see that area head on, I cannot ensure an adequate clearance and an adequate surveillance post-operatively. And see what I am doing with my this cobblator. I am removing the medial wall of the maxilla.
Yeah, so that was a question from Dr. Ponkia. So I have Dr. Ponkia, your question is answered.
See, the access is important not only for the surgical clearance, but for the post-operative surveillance as well. As if you have a good surveillance, you don't need to repeat your radiological investigation again and again. And that is the key.
Yeah, so the next question is, after your debridement, when do you do imaging again to see if something is left behind? That's the next question.
Yeah, that's a very important question. After the debridement, if some symptoms persist, if your inflammatory markers do not come down in spite of the proper amphotericin B treatment, like my CRP is still rising, my ESR is still rising, that means I have missed somewhere the disease, which I need to look back, and for that we need a radiology then. If you are not able to see endoscopically, you need a radiology then.
You would not do it as a routine after debridement?
No. See, our monitoring post-operatively, picture of the inflammation going on. And it's a very cost-effective, you can get it done every day. It doesn't cost more than 20 rupees anywhere. And it gives a very good idea, the true picture of the inflammation going on, the state of the inflammation.
Okay, and Dr. Apurva wants to know, in the post-operative period, you said for about 7 days you give amphotericin. How do you determine the dosage?
Yeah, sir, can you repeat your question again?
Yeah, Dr. Apurva wants to know your dosage schedule in the post-operative amphotericin that you give.
Yeah, my schedule for the amphotericin is roughly 5 to 7 days. And until then, the regular monitoring of the cavity to see all vital tissues under vision, to irrigate the cavity with the solution, and to keep an eye with the CRP and ESR both. And if everything is going good, we can switch over to the, posaconazole as a step-down therapy after 5 to 7 days.
And how long will that be given?
Yeah, that is again monitored by the same endoscopic picture, by the CRP and ESR and the symptomatology, clinical scenario of the patient, but roughly 2 to 3 months minimum.
Okay.
Until the CRP and the ESR comes back to normal.
Dr. Satish, and how much roughly is the total amphotericin dose you generally give in these 7 days?
So my doses are different according to the picture. Like for this particular patient, my dose will be say 5 milligram per kg per day. For the extensive skull base involvement, intracranial involvement, the doses will be escalated up to 10 milligram, 8 to 10 milligram per day. For a better penetration to tackle the disease burden better. Debrider. See, this is the medial wall of the maxilla. See, once this is my obstacle. This is my obstacle to look at the area affected. The moment once I remove this wall, everything will be head on. Without removing this, we cannot work effectively to the area which is affected by the disease.
Okay, Satish, Dr. Adrian wants to know that when you see a patient of Mucor, how soon should you go ahead with the debridement? When do you decide to do the debridement?
Yes, sir. Once we establish the diagnosis radiologically, clinically, it should be done as early as possible, because some of the complications, they happen to appear all of a sudden, like vision loss. It is not the contiguous involvement leads to the vision loss always. It is the thromboembolic events leading to the vision loss more often. So it should not be, I would say it should be done as early as possible the moment the patient is diagnosed.
You would treat it as an emergency.
Yeah, emergency means in our center, like patient we are getting, it takes almost a day, 24 hours for the workup, so many things. These patients requires a thorough medical workup, anesthesia workup, and many of these patients have a lot of comorbidities. Their kidney condition, their glycemic control, the cardiac condition, so many things need to be thoroughly assessed for the anesthesia point of view and all. So it takes almost 24 hours by and large for us to bring the patient to the theater. In general.
Dr. Indu wants to know, in all these 100 cases that you've had, have you had patients without diabetes post-COVID, without diabetes who had Mucor?
How many patients?
Have you had patients without diabetes who developed Mucor?
Yes. The patient had a transient diabetes.
Okay.
Section no.
Sir, we have got Dr. Ayesha Sunawala also joining in.
Yeah.
She is a consultant infectious disease expert at Hinduja Hospital. We can direct few of our queries regarding the antifungal medications to her as well.
Welcome, Ayesha. Thank you very much for joining.
Hello.
Yeah, hi. Now, while Satish is proceeding with the surgery, few questions to you. There have been question from Dr. Ravi. Any prophylaxis drug that you can use to prevent Mucor from happening?
Yeah, I have already mentioned.
Satish, Ayesha is there, our infection disease expert.
Okay.
Yes, a few questions to her. Yes, you can carry on, but we would love your comments as well. Yes, please.
Okay. So before the COVID pandemic, for patients who were at high risk, and by that I mean hematological malignancy patients, transplant patients, we used to put them on posaconazole prophylaxis as a mold active prophylaxis for all fungal infections, including Mucor. However, this is a point of debate, and I was just in conversation with ID physicians across the country raising exactly this point, that have we come to the point where we should be considering giving posaconazole as prophylaxis in a high-risk COVID patient? Unfortunately, there isn't any consensus yet on this. There are very few centers where the burden of mucormycosis is extremely high, where they have started giving it. I know of one such center in Ahmedabad. We haven't done it yet at our place in Hinduja Hospital. And that is predominantly because we have not seen a single case treated at Hinduja Hospital who has gone on to develop Mucor. All the cases that we are seeing are coming in to us as tertiary referrals.
And any thoughts on why they seem to be coming from one particular area, one city? We have so many cases coming from Jalgaon, for example. So what could be the possible cause?
So we've sort of, discussed various possibilities. One, of course, that there may be particularly poor practice in terms of steroid misuse. The second being that we have even considered that there may be some kind of contamination of oxygen supplies, some kind of contamination of humidifiers or, nebulizers or anything that is being used in the COVID treatment. One such center actually even did a study and tried to culture the oxygen, put it onto a petri dish and see what was growing. And there were all sorts of things that were coming out of it. But really nothing concrete, nothing that is... and nothing that can be applied across the board.
Okay,
Again,
you bubble you bubble the oxygen through water. Would you recommend that instead of using simple tap water, they should have sterile water or distilled water? Or is there somebody was talking about putting methylene blue? Any role for that?
I have no idea about. Sorry, I have no idea about methylene blue. But yes, we don't use tap water in our humidifiers.
So if you were to, the question from Dr. Mehta, what guidelines would you tell people to have to prevent this from happening? What would you tell people when you are treating these patients? What measures would you take to prevent?
I think given that we have seen mucormycosis developing even in patients with mild COVID, in fact, predominantly with mild to moderate COVID, the severe COVIDs who are in ICU, who are on a ventilator, have a propensity to develop COVID-associated pulmonary aspergillosis. But the ones who are coming to us with the, COVID-associated mucor, again, I say, are mild to moderate COVID. Most of them have received a very small sort of duration of oxygenation. Some have not received any oxygen at all, but practically each and every one of them has received an unusually high and prolonged course of steroids. And I think that is something that we really need to wake up to, that we're taking this recovery trials, result way beyond what the interpretation of it is. And even if we are using steroids, we need to control the dose and duration. B, there has to be glycemic control. A lot of these patients didn't know they were diabetic and their sugars were never checked during hospitalization and even after. So I think those would be the two most important things. Then we could start looking at oxygen supplies and other things.
Okay, Satish, while we are questioning, you've been going at a rapid speed. So tell us what you've done so far.
Yeah, see, I've done nothing, just remove the medial and a part of the entry wall of the maxilla to enter head on into the maxillary sinus, you can see. You can see the maxillary sinus.
Very
Some
clearly.
polypoid tissue I removed. I have not done anything to the disease so far. This is all done for the excess so far. And I will tell you the reason why I am doing this for the excess. Because our disease focus is behind. And this excess is important not only for the intraoperative removal under vision, but for my post-operative surveillance that is equally important.
What do you do to the nasolacrimal duct when you're doing it from medial wall to anterior wall? How do you?
Yeah, same like we always do in the dankers. I will cut it sharp at the level of the orbital floor.
Okay.
I will see this is the nasolacrimal duct, you can see. And I will cut it sharp drill so that it doesn't lead to epiphora later on. So the best is not to cut this hanging nasolacrimal duct in the middle of the course. Otherwise, it may get into fibrosis later on. Don't allow it to hang in future. So, first of all, drill close to the floor of the orbit. And then cut it flush to the floor of the orbit. So it doesn't hang anymore down in the cavity. That is very, very important to prevent epiphora later on.
Dr. Satish?
Yes?
Yeah, so Dr. Namrata Sharma has to leave early. Can we just take her comments before she leaves?
Yes, madam, please.
Dr. Namrata, please.
Hello, madam.
Hello. Yes.
Yeah, so by the time she comes online, I have a question for Dr. Aisha.
Aisha?
Yes, I'm here.
Yeah. How long do you recommend amphotericin B, and how does one monitor the nephrotoxicity part?
Okay. So generally we start liposomal amphotericin B, all right? That is the current recommendation. The oxycolate has, I understand that in resource limited settings we have to go to it, but liposomal is the way to go in terms of guidance, in terms of international guidance, and all the best results and everything. So we don't start with an escalating dose ever. We start directly at 5 milligrams per kilogram for patients who don't have intracranial involvement, and for those who do have intracranial involvement, we start at 10 milligrams per kilogram. All right. We would do creatinine and an electrolyte along with a magnesium on a daily or a 48-hourly basis. And on days when we actually find that the creat is going up, of course, potassium correction goes on regardless. But if we find that creat is sort of jumping up, then we give drug holidays in between. If we find a patient is particularly intolerant and we are not able to keep the creatinine under control, we actually start something like posaconazole by and by to bridge the therapy, because we understand that this patient is not going to tolerate amphotericin B for as long as we'd like to give it. What is the total duration of amphotericin B? I would say at least 14 days at a minimum, and longer in patients in whom debridement has been incomplete for whatever reason, disease is disseminated, patient has ongoing risk factors which cannot be controlled, and patients in whom there is progressive illness in terms of what you see on repeat scans and things like that. So in those patients, yes.
So,
sorry,
Aisha, just hold on for a few minutes. Dr. Namrata Sharma is there with us. She is the General Secretary of All India Ophthalmic Society. Madam would like to offer her views regarding this. Please, madam.
I think I would like to congratulate AIOA Pune and Mumbai both for such an excellent session. Dr. Satish for giving a brilliant lecture and excellent surgery. And we also learned so much, being ophthalmologists. And I also would like to thank Dr. Harshul Tak for, for making us aware about this and for sending messages to 21,000 ophthalmologists who are our members. And I would like to propose, with the help of Dr. Harshul Tak and Dr. Satish and Arpit and the AIOA Pune and Mumbai, to have a joint session with the All India Ophthalmological Society on mucormycosis, which has become so important in today's scenario.
Yes, madam, for sure. These are important questions. What are your indications for orbital exenterations?
So I think Dr. Murthy is a better person to answer, and Dr. Mukesh Sharma is here, who's the he's the secretary of the Oculoplasty Association of India. Dr. Mukesh, are you there?
Yeah.
So Dr. Mukesh, can you take that question, please?
Yeah. First of all, good evening, everyone. And I must compliment here all the organizers and also Dr. Satish Jain for wonderful.
Welcome, sir. Welcome.
Yeah. So wonderful surgery, Satish. Keep
Thank
doing
you.
good work in such a difficult time. And I think we must compliment Satish for doing a dual thing in this scenario where everyone is avoiding these COVID patients. He is taking on these cases. This is really great. He is serving humanity, I must say.
And see, now I am reaching the disease now. So far was my exposure. See, now I have a head-on exposure to the area of interest. This is the turbinate which is affected. This is a part of the maxilla. See this? All affected with the mucor. Can you see all this necrotic bone? And
yes, very clearly seen.
So in order to reach there, not only reach, but for the future surveillance, this kind of access is tremendously important. If I go without dankers with a narrow access, I will end up compromising my surgical work. and the post-operative follow-up will be equally difficult. See this? Now everything to me is head-on. Now, before I go ahead, let me introduce Dr. Mukesh Sharma, sir. He's a pride of our Jaipur. He's a India fame oculoplastic surgeon, and we are pleased to have him today with us. Thank you, sir, for coming with us.
Yeah. So the question was that what are other indications, ophthalmic indications for exenteration? So the main indication for ophthalmologist is the malignancy. We do exenteration in intraocular tumors which has gone beyond the eyeball, like tumors with extraocular extension, and also for adnexal or adnexal tumors which cannot be localized and which cannot be locally resected. So these are few of the indications. By and large, we are doing exenteration less and less with the advent of good chemotherapy, localized radiotherapy, and good resection. And the other, of course, important indication which we are seeing right now is the mucormycosis. So we do get cases of mucormycosis where we need to do exenteration in conjunction with the you people. Primary surgery is done by the otolaryngologist mainly, and we do exenteration. Along in few of the cases, we give local amphotericin B also, but that is not.
Sir, most of the time, we are able to clear the orbital involvement endoscopically. We call it orbital clearance.
Correct.
Rather than using this terminology of exenteration, which is required in very few number of cases.
Very few cases. Correct. Correct.
Now, this is the turbinate which is affected, which is, necrose because of the vascularity. And we have come to this level only after this exposure. Here's a slight DNS as well, which is limiting our access. Now, what I'm going to do is, I am going to remove this turbinate. See, this is already necrose.
Yes.
See, this is all full of mucor.
Kirtana sir?
Yeah.
Any more questions for Ayesha? Otherwise, she has a next meeting lined up.
Yeah. One question for Ayesha. Your views on local application of amphotericin and local injection, intralesional injection of amphotericin. And somebody just mentioned about a gel that is available. Any thoughts on that?
Yeah, and also...
Sorry.
Yeah, and also role of inhaled nebulized amphotericin B in prevention.
In prevention.
Yes.
Yeah. So we
There's
have
a question,
used. Yeah. We have used we've used inhaled amphotericin B for prevention in other risk groups like hematological malignancy patients and those who we cannot give IV amphotericin B to. We have done it in the past. Again, I'll stress that we haven't yet come to the point when we have universally considered prophylaxis for mucormycosis in all institutes for COVID patients. So I don't have any experience in the COVID population with inhaled amphotericin B.
Hello.
Yes.
Hello, can you hear me?
Yes.
Yes, Satish, we can hear you.
See this, the sphenopalatine artery.
Yeah.
See, this tissue is completely gone.
Yeah.
This is all affected. And here is the role of endoscopic surgery where you can do everything under vision. What need to be removed, what need to be spared. Absolutely under vision. So that you don't ultimately at the end of the surgery leave any necrotic tissue behind, because if you leave the necrotic areas, your drug will not penetrate. See, this is the pterygoid bone, which is commonly affected. This is the pterygoid bone. I will show you how it is affected, like you see in the JNAs, angiofibromas.
Yes.
The commonest side of so-called recurrence, so-called residual disease is the pterygoid. And here I will show you. I showed you on the scan. I told you before how the pterygoids are harboring this mucor, which is easily overlooked. Let me open this pterygoid and show you something interesting.
So there is a question from Dr. Neha from Dombivli.
See this.
Do you do pterygopalatine fossa clearance in all cases?
Yes, see this. This is all bad bone. This is the simplest of all cases to begin with.
Yeah.
We'll show you the extensive osteomyelitis in the rest of the cases today involving the skull base. But here, see whatever I am able to do right now is simply because of my axis. See my head-on axis.
Yes.
Everything I can see, this would not have been possible without dankers. So a lot of people can raise question, why unnecessarily dankers? Danker is not to, remove any tumor or anything, but to give you a perfect access, 40 there, so that you don't miss any area which need to be removed, and for future you can keep an eye for the surveillance and for the topical application of the drugs.
Dr. Satish?
Yeah?
Dr. Sujata from Mumbai.
Yes, madam.
Would you consider removing the middle turbinate right at the outset or maybe later on? Because once we remove the turbinate, you tend to get a little bit disoriented between the medial and the lateral part. And we know going medial to the turbinate would jeopardize the cribriform plate.
Yeah, that can happen, madam, if you go up. Fortunately, I mentioned earlier, this disease has a preferential involvement of certain areas, and the roof of the nasal cavity, the ethmoidal roof, is unlikely to be involved in the early course of the disease or in most of the cases. So we don't have to go high up to the roof of the ethmoid to damage anything there, to give a CSF leak or anything, unless the disease, involves that area. We have seen a couple of cases involving the ethmoidal roof and going to the frontal lobe of the brain. You have seen, but very, very unlikely. So what I'm doing, I'm using the 0 degree and working in the inferior part of the ethmoid only.
All right.
Yeah, Dr. Satish, have you come across cases of only palatine involvement? Only palate involvement? Have you come across cases with purely palate involvement?
Purely palate?
Yeah, just
many cases.
blackening on the palate and
many patients will show today as well.
Mm-hmm.
Today also I'll show you the case where the palate is affected and need to be debrided.
Yes.
So palate is, I would say, commonly affected.
No, purely palate. I mean, we recently had cases where only the floor of nostrils
palate is preferentially affected.
Yeah.
The area you have to be careful is the pterygoids, the base of the sphenoid bone, which is most important.
So there's a question for Dr. Aisha. Yeah. Aisha, you're there? Aisha?
Yes, I'm here.
One is the question regarding what is the role of new kid on the block isovuconazole and other antifungals like capsofungin, especially in mucormycosis.
Okay, so I'll start with isavuconazole. Isavuconazole is the latest azole antifungal on the block, which has been found in very small studies. The study is called the VITAL study, to be effective for mucormycosis. However, the guideline published, the international guideline published in 2019, which was a world involved people from all across the world, including Dr. Arunalok Chakrabarti from PGI Chandigarh and Dr. Rajiv Soman, who was with us at Hinduja and my mentor. The current recommendation is for liposomal amphotericin B upfront, isavuconazole for salvage in cases where patients cannot tolerate amphotericin B or it cannot be used for some reason, or as a step down. So that's the position of isavuconazole at the moment. Again, I say very small studies showing efficacy, but in vitro data which is encouraging. Apart from yes.
Madam, just adding on to your point, what you're saying, we have used isovuconazole Cresemba in a couple of cases who was severely renal compromised.
Right.
Because isovuconazole can be safely given to the kidney patients.
Absolutely. Yeah.
Those patients having creatinine, we had patients having creatinine about 9, and we use isovuconazole in that. We know the efficacy is not as compared to the amphotericin, but relatively good, but it is very, very safe for the kidney. The only limiting factor is the cost.
Yeah, very
Cost
expensive.
of isovuconazole per day therapy is almost, say, 90,000 per day for 2 days, first 2 days, and then 30,000 a day for the rest of the time.
Right.
Cost is a limiting factor.
Right. If you were to compare it to lamb, which is liposomal, and if you were to give a full 5 to 10 milligrams per kilogram, even with all the best price and everything, you're still spending somewhere between 20 to 50,000 rupees a day.
Yes.
Right?
Yes,
Isavuconazole tablet. So what the recommendation is to start with the loading dose of IV. So yes, those 2 days are horribly expensive, but the tablet that follows later with the pharma rates and everything comes to approximately 7 to 8,000 rupees a day when you give it at 200 milligrams once a day. And Pfizer has come out with a recent program. You can get in touch with your Pfizer representative where they're going to give 1 strip free for every 2 strips or something like that. But that'll help the patients to some extent. It brings the cost down to between 4 and 5,000 rupees a day.
Aisha, that still remains the question. Yeah.
Are you watching where I am now?
Yes, you're removing the posterior wall, you're opening the pterygopalatine fossa.
I am in the pterygopalatine fossa to show you something.
Yeah.
See, the bone or the posterior wall of the maxilla was looking good. Could you see?
Yeah.
The bone was looking quite good.
Yeah.
And see what is there behind.
Yes.
How could we make out? By means of MRI.
MRI, okay.
See this?
Yes.
All necrotic in the box of bone. Seemingly normal from outside. Can you see all this?
Yes, absolutely.
This, see the vessel sphenopalatine.
Yes.
Looking like thrombosed. Can you see?
Yes.
And see all this dead tissue. All this is mucor. This is all dead tissue. If we don't remove this, this is as good as useless gallbladder.
Yeah, Satish, I think just a minute. Aisha has to leave. So Aisha, one question from Dr. Garima and one from Dr. Neha. Garima wants to know the amphotericin ointment pack. And Neha is asking whether intraorbitally injections of amphotericin will help. So your opinion on that?
Again, we have very little experience with intraorbital injections. We haven't used it significantly in the past. But I must just raise one word of caution that when we have had problems with introducing secondary bacterial infections. So that is something that we need to take a lot of care when we're doing. But yes, I believe a lot of people have started doing it, especially when they're trying to conserve the eye and, sort of prevent or defer accentration. But genuinely, not much experience with it at our center.
See now this key area. This is the key area which is often overlooked. The involvement of the pterygoid bone behind. See, I am in the infratemporal fossa here now laterally. This is my maxillary artery in the middle of my field. And this is what, see all this necrotic? Completely necrotic tissue. This has no penetration of any drug. If we don't leave this, we are back to square. See this? This bone is quite often involved and very easily overlooked by the surgeons. It looks like everything is normal. You have removed the dead tissue, terminate and all, and you can happily come out and the disease goes on. See the role of, can you appreciate the role of Denkers now?
Absolutely. Your head on straight.
This would never have been possible without that. This kind of access for the instrumentation, access for the assessment is so important.
Satish, if you can point out where you would expect the maxillary nerve to be in this.
Which nerve?
The foramen
maxillary nerve. Yeah, I will, sir.
Satish, I think you have to emphasize it more, because I have seen so many people who are saying mucor surgery is something where whenever bleeding starts, you have to stop. Then after that, everything is taken care. But what you have shown right now, the fungus behind that pterygoid, normal health.
This bone was absolutely, bone was absolutely normal looking.
So you have to emphasize this again and again. It's very important point to avoid.
I could get this only from MRI that the bone behind the maxilla is not enhancing. That's why I opened this bony window, seemingly normal bone,
Right.
went behind and found this mucormycosis there. And this can be so easily overlooked. You can imagine.
Absolutely. And that
if we
itself
leave
is
this
the-
behind, there is no fun in operating.
Yeah, and that can be the
And then
pathway
keep
spread
on
to the
giving,
intracranials.
keep on giving amphotericin for months. See this?
Yeah, we can
Now
see the
what I
artery
can
so
see,
well.
the pterygoid muscles, laterally normal muscles. Can you see?
Yeah, very well.
Very clear.
That I can leave now. Okay, lateral part.
Yeah.
But
Yes.
medially, I have a lot of work to do. This is the simplest situation, I tell you, of the mucormycosis surgery. Now, clip. Now, at this point, at the lateral end, I will prophylactically clip this vessel. Because now I don't need to go further lateral. Can you see?
Yeah, very well.
And I can easily clip with my Karl Storz clips. That's it. Come later. And I have a now, once I get this from my field away, I'll have full access to the pterygoid bone behind. This pterygoid bone is a part of sphenoid bone. In today's presentation, in all these cases, you will see the different involvement of the sphenoid bone at different levels. Maxilla and sphenoid are the two bones most frequently involved. And we all know sphenoid is the most complex bone with various parts. And we'll show you how this bone is affected by this mucor so extensively. See this? You were asking about the nerve. Can you see the nerve?
Yes, very clear.
Very well, very well.
That is the normal looking pterygoid process behind. Can you see?
Yes, absolutely.
Yes.
And this is all my diseased tissue. See this all, necrotic.
Yes.
If I don't remove it, better not to operate. Nothing is going to work.
Inferomedially, can you show us the Vedian canal as well?
Yes, yes. Exactly, sir. Can you see?
Yeah,
Yes.
very well. Excellent.
This is the minimal involvement of the pterygoid. But this necrotic tissue need to be removed. And see how important is the cobblator in this setting. Cobblator, debrider and drill. See, all this is necrotic. The key to this successful surgery is the access. I am repeating again and again.
Yeah.
If we do try to do this without dankers in the keyhole, one can never do a satisfactory work. See this all necrotic. See this completely devitalized tissue.
Yes.
See this?
Yeah.
Debrider. So once it comes to surgery, it is a complete surgical work which is most important, because your medical treatment and the overall outcome totally depends upon the surgical work, how much you are debrided. And once you're completely debrided, you'll feel like that you have won over the situation. You don't need to give amphotericin too much, and practically it is not required in most of the cases. I'll show you at the end of the surgery. And we can see post-operatively, we can follow in our OPD with a 0-degree telescope so well. That is not possible with a keyhole surgery. I will show you the revision case after 1 or 2 cases. See this. This is the Vedian canal.
Yes.
This patient had already paresthesia of the face. See this now, which is, see, this is swollen now.
Yeah.
Inflamed now, which was already involved. No point in leaving behind any disease thing. See the clearance now for the infratemporal side. This is infratemporal side.
Yes.
Absolutely healthy. This is the pterygoid. Now I will come to the floor of the sphenoid to make sure that nothing is left behind. Give me the chisel and hammer to the floor of the sphenoid. Our next case is ready after this. That is a more extensive case with multiple intracranial infarctions due to mucormycosis.
Sandeep, do you have any more questions to ask, Sandeep?
More or less done. Most of them were for Dr. Aisha, the current session. So she's answered most of them. Is Dr. Aisha still with us?
I think she had some other commitment she had said. So she was.
Yeah. So most of them are on drug therapies, the latest ones.
See the interior of the sphenoid now.
Looks normal, yeah.
The brighter straight. What I need to see, this healthy bone, this pterygoid bone is healthy bone now. You can see. Can you see? This is not osteomyelitic bone. You will, get to, used to get know how the osteomyelitic bone looks like once you see a couple of cases.
Dr. Satish.
Section. Straight. Yes.
Yeah, you have a situation where the eye is completely fixed and ophthalmoplegic, but there is no chemosis. Any difference in the approach in surgery pertaining to the medial orbital wall?
Yes. See, for the management of the eye, let me tell you from mucormycosis point of view.
Yes.
It is not that we go with a mindset of exenteration or something.
Correct.
I can lose the vision simply because of the central retinal artery shut down.
Absolutely.
By the fungus embolize without contiguous involvement of the fungus to the eye. Eye can be affected by several ways. But yes, if it involves to extend the orbital apex, then you have to think of something radical, because behind the orbital apex is the cavernous sinus, and there is a full avenue for the intracranial spread. That is something you have to be careful. Yeah, Debrider. See now what I'm looking at. Just to ensure that no necrotic area is left behind. Can you see?
Yeah, very well.
And this is what the extension from the MRI, that the disease was going behind the maxilla. I mentioned the word perisinus involvement.
Yes.
That is classical of the invasive disease. Then differentiating from the regular sinusitis, and that's why this bone or the posterior wall of the maxilla was absolutely looking normal. Looking absolutely normal, yet I opened up to see the pterygopalatine fossa to remove the necrotic tissue because it was visible on MRI.
Yes.
So your MRI is the key. CT cannot differentiate between the tissues. CT will just give opacity. It cannot differentiate whether it is inflamed, whether it is mucor or not, or whether it is simple inflammation. MRI will differentiate easily the simple inflammation from mucor, because mucor leads to vascular necrosis blocking the blood supply, and there will be no enhancement with a gadolinium. At the other hand, any regular inflammation anywhere will pick up more gadolinium. Inflamed tissue pick up more gadolinium to enhance.
Yes.
So MRI can easily differentiate the inflammation from the inflammation caused by mucor. See now, this is almost a done case. This is the simplest of all situation. You can see no other area required to be addressed. As we have seen on MRI, this is, I would say, Then adequate treatment to this particular situation.
Yeah.
This is the simplest of all the cases.
Does the orbital floor look diseased?
Yeah. No. It looks normal. See the no necrotic bone anywhere. You will see the next case. That's a massive case with blindness.
Yeah. So, Dr. Satish,
then you will realize what is
your comments, especially on patients presenting with orbital apex syndrome.
Yeah.
Do you remove the lamina? Because in quite a few cases, I've seen that the periorbita becomes very, very gangrenous, and these are the ones which invariably land up with exenteration.
See this lamina. See this lamina.
Yes.
The third case we are taking today is a bilateral blindness with huge orbital involvement. Will be requiring the orbital clearance, and we'll be doing the endoscopic orbital clearance.
Yeah.
Debridement of the orbit with the micro debrider. Pure debridement. See this?
Yes.
The periorbita and orbital tissues look healthy.
Yes.
No necrotic. See this?
Yeah.
Give me the forceps and the debrider to show you better. Just remove this bone to show you. Debrider. Yeah, 40 dana chahiye beta. See this healthy orbital fat?
Yeah.
Nothing is required to be done further.
Right.
And we know from our imaging that it is not going anywhere beyond. So imaging is your guide. For a successful surgery, what is most imperative thing is a successful assessment by means of MRI.
Dr. Satish, have you done any RT-PCR positive patients, or these patients are presenting after almost 3-4 weeks? What is
many?
Means during active COVID also they are presenting, because most of them in our institute, I mean, we have a huge number.
I have done almost 40 cases where the RT-PCR was still positive.
Yeah. Still positive, but after 17 days, I think should not really be a problem. But I mean, I was just wanting to know what is the average time of presentation of these mucors from the day of testing positive.
It is somewhere between 10 days to 40 to 50 days, any point of time.
Yes.
See now, for me, this is the end of the surgery for this particular patient.
Okay.
What we have achieved with debridement of the necrotic tissue, we have achieved the access for the future surveillance. Now, anywhere, if I find in future necrotic area coming up, I can take up for the debridement immediately. I don't need any radiology unless it warrants with some unusual symptom of intracranial spread or something. Generally, you don't need any radiology. And thirdly, for the application of the topical amphotericin for the douching and all these things, this kind of access is most important. So this is...
Satish, any comments on actual injection of amphotericin B when we have exposed this periorbita?
What?
Any injection of amphotericin B into the orbit after because we are in a good position to inject it if needed.
Yes, there are some papers pointing retrobulbar injection of amphotericin B.
Yes.
But see, there is no supporting fact to that.
Absolutely.
Number one, that is a vague idea which people tried, but scientifically, I don't see any basis to that. Number one. Number two, it is the adequate and I would say complete under vision clearance, which is the key to the success.
Absolutely.
Satish?
Now, yes.
I want to ask a question. If
Yes,
you
please.
say that the lamina papyracea is not diseased, do you still
Yes.
remove it and decompress the orbit? Would it not be opening up the planes of a healthy eye?
Not really. My periorbita was intact, number one.
Okay.
Even if periorbita is breeze, you have not left any pathology behind.
Right.
You have opened up everything for your surveillance. I don't think any chance of, giving the access for the disease to enter into the orbit further.
All right. Thank you.
Yeah, Satish, thank you very much for a lovely surgery. Before you go on to the next one, Just want to tell you that you remind me of a movie I had seen. It was called A One-Man Army. But as you are like a one-man army, Navy and Air Force put together.
Absolutely.
Fantastic. Thank you so much. It's been really pleasure watching.
Thank you, sir. Yeah, before coming to the next case, you must be getting the images. We have a question here about the post-operative amphotericin management.
Yes.
First of all, the reconstitution of the amphotericin is very, very important. A proper reconstitution. Number two, the application of infusion of the amphotericin, and then step down to the posaconazole. For everyone watching, we must reconstitute the liposomal amphotericin properly and administered under hydrated conditions. Hydrated means we must infuse at least 250 ml of saline before and after infusion of the amphotericin. Amphotericin should be reconstituted with distilled water, not with saline, to prevent agglutination. All these liposomal amphotericin are available in the powder form. That should be reconstituted with the distilled water and make a solution of roughly a milligram per ml, 1 milligram per ml, which can be infused over a time of almost 2 hours. So a 50 milligram vial, we have to make 1 milligram per ml. What we can simply do, like we are giving suppose 300 milligram of amphotericin. What we can do, 6 vials. Every vial we can mix 12.5 ml of distilled water to make it 4 milligram per ml. Every vial 4 milligram per ml after 12.5 millimeter mixture of distilled water. And then all these vials together. Further dilute 4 times by the dextrose.
Yeah.
Dilute, neutralize with the insulin and infuse over a period of 2 hours. Like 6 vials, 12.5 ml each, 6 vials, 75 ml. Mix in 300 ml of dextrose and neutralize with the respective amount of insulin, as most of these patients are diabetic, and then you can infuse over a period of 2 hours. Hydrate pre and post infusion with the normal saline properly, and this has to go on 5 to 7 days. Every day need a CRP to see the trend. A single value of CRP doesn't carry any value. It is the proper follow-up with the CRP. Serial CRP has a value which need to be, taken care of. Now, this particular patient.
Satish, one last question coming from Deepak Dalmia. Any role of hyperbaric oxygen?
Any role of hyperbaric? There are a lot of, publications also regarding hyperbaric, but no clear-cut guidelines. One of the papers rather criticized the use of hyperbaric oxygen leading to systemic complication, keeping such patients in the hyperbaric oxygen chamber. So far, no guidelines for the use of hyperbaric oxygen, and we have never tried. We tried for diabetic patient, osteomyelitis in other areas, but not for this particular purpose ever. Now, very important patient. Let me tell you something about this patient. This patient has lost vision. Right-sided vision loss. And see on the right side, this is the contrast MRI. See the loss of enhancement of the right turbinate. Can you see? Maxilla, can you see? On the contrast image?
Yes.
See this loss of contrast enhancement of the right turbinate. Maxilla, see the perisinus inflammation in the infratemporal fossa behind. And this is the infiltration of the pterygoid process. And if I convert to a coronal one, not this one, I convert to the coronal one and will show you what is happening here. See the kind of picture. Loss of contrast enhancement of the turbinate here, very clear. And the maxilla, if I go behind, this goes continue in the pterygoid process behind. Can you see this? Hello?
Definitely. Yeah.
Yeah. And how you can follow? This is the T2 weighted MRI, which shows inflammatory process as a high intensity. And what you see, what this is necrose area is hyper intense this in this T2 weighted. This is fat suppressed MRI. The fat is nowhere being hyper intense. And this MRI, as we go behind, see, as we go behind, this is the region of the pterygoid process where the hyper intensity is continuing. Can you see this? That shows the infiltration of the pterygoid. Why? How could I assess in the previous patient the pterygoid was involved? The retromaxillary tissue was involved. This was necrotic. Simply by means of MRI that you need to address this area. Need to address this area of the retromaxillary in the infratemporal fossa, and this high intensity is clearly suggestive of involvement of the retromaxillary tissue. Second important thing, in the next of the cases you will see, the next case particularly, next case has a complete blindness, bilateral with bilateral orbital clearance demanding and involvement of the entire greater wing of the sphenoid. Where is the greater wing of the sphenoid? This is the sphenoid bone. And this is the greater wing of the sphenoid forming the base of the temporal bone on both sides. The entire greater wing of the sphenoid is involved by the fungal osteomyelitis. And if you don't drill every bit of that bone, your job is not complete. So, MRI is the key to assess how much of the debridement is indicated and to get an adequate clearance to make the medical treatment effective. You don't need to give too much and too prolonged a medical treatment, intensive medical treatment, once you have done a proper clearance. Now, yes, please.
You mean to say you take all your decisions regarding the soft tissue, etc. on MRI? Don't you do CT scans at all, or there are some patients in whom you would want to do CT scans?
Most of the patients carry CT scan in hand with us, to us.
All right.
And CT scan cannot differentiate. See this MRI, the both pictures. T2 weighted showing inflammation as a hyper intense, and this contrast is showing lack of enhancement wherever the mucor is. This is what exactly we need to know.
This is the soft tissues. Soft tissues, Satish, but the bony windows for the bone erosions and your bony anatomical landmarks?
Not really. Let me show you exactly to what you are asking. See what is there in this pterygoid bone, the bones which are involved. There is a marrow tissue. Okay?
Right.
Now see, let me show you another T2 weighted MRI here. What does the marrow tissue contain? Marrow tissue contains fat.
Yes.
On MRI, the fat will appear hyper intense. Can you see this pterygoid marrow?
Yes.
This is T2 weighted normal, and this is T2 weighted fat suppress. This is T2 weighted normal. This is T2 weighted fat suppress. Now see what is happening.
Okay.
This is T2 weighted normal. Will show the hyper intense signal in the pterygoid bone. What is that? The normal marrow.
Marrow, yes.
Now what will happen if the normal marrow is replaced by the disease? The hyper intense signal is gone.
Loss of the marrow signal.
Yes, that is what you can pick up on MRI, which cannot be picked up by any other means. So now you see here, coming to this patient here. What is there? See the hyper. See that this is loss of fat. This is fat suppressed.
Loss of marrow signal.
Yeah, this is loss of marrow signal. And see at the opposite side, what is happening? What is marrow signal? What is this hyper intensity? Looking like a fat in a fat suppressed image is a disease.
Inflammation.
Yes, that is what we need to pick up. To formulate our extension of, debridement, we need to know the extension of disease by means of using all these sequences together. We can exactly get to know what is involved. What part of the orbit is involved? See, look into the orbit in this particular patient. Let me show you. See, this is normal T2 weighted with the fat is enhancing. Can you see?
Yes.
Right, because the orbit is full of fat everywhere. And the muscles and the globe is in between. So the full of fat which is hyper intense. Okay. Now see on the fat suppressed MRI. Look at the fat suppressed MRI. No enhancement into the orbit. Now whatever enhancing into the orbit, what is this?
What
is this? Yes. Can CT scan give this information?
No, Satish, I meant just for the bony landmarks, for anatomical purposes.
That is not the adequate information, madam.
Yeah, so it's a complementary MRI and CT scans.
So
we wouldn't go in without an MRI, but we do need scans.
You can go without CT scan because every information we are getting from the MRI from the debridement point of view. It is not the simple sinusitis we are dealing with where the CT scan is more important to give you the details of every cellular septa. Here you want the details of the anatomy, details of the disease involvement, and details of the relationship with the surrounding structure, orbit and skull base, which CT scan cannot give. And we operate all these Mucor cases without CT scan. There is no point in getting CT scan done. A lot of people, I mentioned in the beginning, if we are operating on a Mucor without a MRI, one cannot assess properly, one cannot give a good job. And to me, it is always, I would say, I would never recommend that. And see this, we will go into the orbit and we will witness this. With this enhancement, what is this enhancement into the orbit? What is this? Disease. Can you see very clear?
Yes.
Which is not on the other side. Can you see? What is this hyper intense signal? Now this cannot be assessed with a regular T2 weighted. This on the other side is a regular T2 weighted MRI. For the Mucor to assess, you need to compare with the T2 weighted, this T2 fat suppress. Because now it will give you the exact picture of the involvement of the orbit where the inflammatory process is on. So MRI is the key. MRI, dynamic MRI, multiplanar on DVD, giving entire information where you can put all the sequences together in the need of the time. Let me put the contrast together. This cannot be, this information. Yeah.
Can you just explain? The radiologists typically always mention intraconal and extraconal stranding of fat in the orbit. What exactly does that mean?
Yeah. See, that is not in the Mucor situation.
Correct.
That is once your orbit is affected by some tumor or something. But here, see, orbit is full of fat. This is all fat.
Yes.
Now see on both the sequence, this is contrast.
Yes.
Contrast will not give enhancement to the fat. And here it is fat suppressed. All the three sequences together now.
Yes.
Now how to differentiate which is Mucor, which is secretion, which is fat, which is disease, which is normal. All these can be differentiated on these three sequences together. Let, for example, see some secretions in the frontal sinus on T2.
Yes.
Can you see?
Yeah.
The secretions do not enhance. Got my point?
Correct.
But are hyper intense on both T2 and fat suppress.
Yes.
On the other hand, if there is Mucor, see this. If there is Mucor, see this non-enhancement, hypo intense on T2 and hyper intense on fat suppress. See the difference. All the things you can separate properly on the line that what exactly you are having by means of putting three sequences together. And what we have observed in this patient, this is the area of the pterygoid bone, and this is the disease which is extending behind. And let us see when we explore how it goes, but not very extensive. The next case is going to be the mega case with bilateral orbital clearance. So we are just going one step ahead of the past case. Okay. Revision.
Satish,
Yes.
when you decide your indications for orbital exentration and how you deal with cavernous sinus involvement.
Yes. So orbital apex involvement is indirectly indicating the cavernous sinus involvement. Number one, orbital apex is just anterior continuation of cavernous sinus. So once the orbital apex is involved, a day before we did a case with huge osteomyelitis at the complete orbital apex and cavernous sinus. That is the indication for the orbital exentration. There's nothing less than that can work in those situations where you need to be excessively radical. That is the point. Focal involvement into the orbit, you can get away with the orbital clearance. That is a different terminology orbital clearance and orbital exentration. You don't need to exentrate everything out to the globe in those situations. So let us see in the next two cases what is orbital clearance and what is orbital exentration. Probably in the next case, on one side, we may need an orbital exentration, and otherwise in both the cases, we'll be needing orbital clearance.
Just the reason I am asking this question is, suppose the cavernous sinus.
Dr. Satish, has in your series have been any situations where you have given amphotericin B before waited and then went in for debridement?
Yes. You see, when the patient is in waiting, like the patient admitted yesterday, scheduled for operation day after, you can start amphotericin at least for the prevention of, inflammation propagating. The amphotericin is not going to penetrate the necrotic areas.
Yes.
But at least in some of the areas it will penetrate, and it will halt the disease to prevent the progression of the disease, you can say. It will work to some extent good for the patient. But yes, the moment you get the mucor patient, you must start amphotericin.
Right. And do you
That
start
doesn't mean that doesn't mean that you are buying time with the amphotericin.
Correct.
You have to plan your surgery as early as possible. But the meantime, you can give.
And all of your patients are on aspirin simultaneously?
For aspirin up to 75, we don't mind stopping that. Yes, for many a time, these elderly patients are on anticoagulant, double anticoagulant, clopidogrel and all. And if required, you stop for a day or two. You can arrange SDP. If you are really, you have to rush for surgery, you can use 1 or 2 SDP and go ahead.
Yeah, and
that is what you can do.
In fact, in our cases, especially patients who are not on blood thinners, we electively start them on ecosprin and till about 75 and don't mind operating them.
Yes. So we are again ready for this next case. Meantime, we can take questions.
Satish, if suppose the cavernous sinus is also involved, then if orbital exentration helps us in the way, means it decreases the fungal load?
Yes, it decreases the fungal load. And secondly, if the cavernous sinus is involved, you have to add on another antifungal to the amphotericin right from the beginning. In those cases, we always add on posaconazole from day 1 to the amphotericin. Double antifungal in high doses. We, according to the renal function, we give 8 to 10 milligram of liposomal amphotericin per kg per day. Means sometimes 10 vials of amphotericin every day. That requires mega dose of full dose of amphotericin with double antifungal posaconazole. That is what you can do. You can't do anything beyond any debridement beyond that is not feasible.
Satish, I have a question.
Yeah.
What should be the plan for sinister looking palatal ulcers or blackish discolorations? How radical one should be, and should be the reconstruction post the disease free the patient is?
Yes, palate is very frequently involved, I would say. We'll show one of the palatal removal, and this ulcer on the palate is a manifestation of underlying osteomyelitic bone. That means the underlying palatal bone has already undergone osteomyelitis. It is not the simple superficial ulcer. In those cases, that part of the palate need to be removed. For the time being, you can give a palatal prosthesis. You can give an obturator for the patient. But once the patient recovers from everything and the patient is willing, you can think of giving some other reconstruction. But the momentary, immediately post-op, because these are diabetic patients with compromised microvascular, circulation and all that, you can't afford to plan any sort of reconstruction at the same time. Because here goal is to get rid of this dreaded disease first, to monitor the cavity, the follow up the cavity. Once everything heals up, then only you can think of other things. So meantime, you can give obturator.
But in case if you are unsure and you have put in an RT and waiting for a serial screening imaging or your blood values, inflammatory markers to go down. Till that time, is there anything which we can do apart from Ryle's tube?
Hello?
Hello? Hello?
Cool now.
Hello?
Hello?
Yeah, Satish, can you hear me?
Yeah, now I can hear you.
Yeah. So what I'm saying is, in case if you are unsure about your clearance of disease and if you are probably waiting for post-op screening imaging or your inflammatory markers to come down, and if you are put in a Ryle's tube, still the plan remains the same, or you have to alter your plan?
For the palatal reconstruction?
Yeah.
Same. Why to change?
Okay.
Yeah, can you
let's get along with this case, and he has other cases related to the palate, so we can discuss those later. Let's start with this one.
Yeah. Are you getting
yes,
the
Satish,
endoscopic
we are
picture?
with you. Yes, we've got the endoscopic picture.
Now see from the beginning.
I'd like to invite Dr. Abhijit Mantri also, who will co-moderate this second surgery with you.
Yes, sure.
Dr. Mantri.
Yeah, I'm online.
Okay.
Very much
Thank you
online.
so much, sir. Yeah.
Thank you.
Can you see the picture, the first endoscopic picture?
Yes.
Yes.
See the palate. Yeah, see the septum. Can you see?
Yeah.
See the septum is affected?
Yes.
Necros. See the lateral wall, lot of necrosis, the necrosis of the turbinate. The first structure to be affected is the lateral wall and then the turbinate. See this? All necrous tissue, that is classical. You don't need anything for the diagnosis, clinical diagnosis, but this picture.
Yes.
And then your radiology will complete your diagnosis.
Yes,
okay?
Very classical.
Yeah. So again, our goal will be same. Axis. This patient has a little extensive disease than the previous one. As I mentioned, we always go by that to begin with the smaller case, the basic one, and then go further. See the opposite side. See the turbinate.
Turbinate.
Yes.
See, turbinate is the structure which is initially involved in the course of the disease. And this is classical black turbinate sign on MRI. Go. Bilateral leni next. So next case will be bilateral one. Now see, you have the tattoo. See, this is all necrotic. This is all necrotic. But I will address that later. First, I will access my lateral areas. I will remove this wall to get on to the area of interest head on.
So Satish, we've seen a few cases with unilateral facial pain and a normal endoscopy. So how do you go about with such a patient?
Yeah, facial pain and swelling is a common finding in these patients once the infection goes beyond the sinuses, you know?
Yes.
That is a manifestation of peri-sinus involvement. Facial pain, edema, numbness is the involvement of the V2.
Right.
Like in the last patient, you saw the V2.
Yes.
See, this is the pyriform aperture.
Yeah.
I'm sure this what I'm doing is everyone accustomed to. This Denker, that's a common approach. We have shown in last our previous webinars couple of times. This will open up the gateway, open up the access to work in depth with comfort, visualization, everything. The moment this bone is out, and cobblator is the tool. Section See, goal is to get rid of this bone divider, straight divider. How's the picture overall?
Yeah, it's
very good.
Very good.
Great. Thanks to Mr. Dinesh for giving this audio visual. I will divide this septum later once I get full access, so I can assess till the posterior part. See this middle turbinate?
Yeah.
Yes.
The cobblator. Right. Drill. I'll be using a drill to ensure the level of entry into the maxilla. Because what I want to ascertain here is that I should not be going up, breaching the roof of the maxilla or breaching the floor of the orbit. And I should know the level of the roof of the maxilla to complete my transaction of the nasolacrimal duct flush to it. That's why this opening is important. This part one can do quickly. The only vital structure in this region is the nasolacrimal duct.
Nasolacrimal duct, yeah.
See this?
Yes.
Necrotic tissues in the maxilla.
Yes, yes.
See this? Lot of bad tissue inside.
Would you be sending this material for biopsy and culture?
Yeah. We always send for frozen also. Last case frozen, are you?
So how frequently do you get a mixed infection, mucor with aspergillosis?
Mucor with?
Aspergillosis.
Not really. And I tell you one interesting thing.
Yeah.
A lot of people, while choosing the antifungal, sometimes considering the aspergillosis, you start voriconazole.
Correct.
Right.
If you start giving voriconazole to the mucor patient, the mucor will become more virulent.
Why is that so, Satish? What would be the reason of that? For that?
The reason is that will suppress the other commensal fungus and allow the mucor to grow more virulent.
Okay.
And it is proven. So never ever give amphotericus, this thing, voriconazole, to the mucor patients. It will make it more virulent.
Okay.
See, this is my maxilla.
Yes.
Voriconazole is the drug of choice for the aspergillosis.
Yeah, but you haven't seen any mixed infections, have you?
Magic drug for the aspergillosis. See this, you can remove it under vision after thinning this bone.
Yes.
And what you see there behind is your nasolacrimal duct. See this? Yes.
Clearly see.
Here is your duct.
Yes.
Now what I wish to do here is flush with the floor of the orbit. Drill. We are not supposed to leave it hanging in the cavity. इसको retract कर, इसको retract. अंदर करना है, suction अंदर कर, हाँ.
Satish, you've said you've operated on RT-PCR positive patients also. So
Yes.
have you used these powered instruments in them too?
Yes.
Okay.
The same manner.
Okay.
And suppose if any patients, you said that it may occur after 10 days also, then if you want to operate at 10 days, then
10 days post detection.
yes, post RT-PCR positive. Suppose if you are operating,
Yeah.
then you wait for 15 days or you operate.
See, if it is a mucor,
Yes.
if it is a mucor, I would never prefer to wait. The reason being, if you diagnose this in the early situation, that is the best time to deal with this.
So any precautions you take at 10 days if you operate?
Satish, but
Yeah,
what's
you
about
have to
your
take,
safety?
You have to take level 2 PPE protection, and you can do it.
Any blood test in diagnosing early stage fungal infection or mucormycosis?
Any
Blood tests?
blood test?
Yes.
Let me tell you, for the mucor, there is no blood test. For the aspergillosis, chronic invasive aspergillosis, yes. Okay. The reason is the aspergillus and other fungus have galactomannan and beta-2-glucan in their wall.
Okay.
But mucor doesn't. So no blood test will be able to detect the mucor for that matter.
In fact, it is said that negative galactomannan and D-glucan levels could be taken as suspected mucor.
Yes.
That's what
because in the mucor wall, fungal wall, there is no galactomannan and no beta-2-glucan.
Absolutely.
And that is a good test when you suspect aspergillosis.
Yes.
Means,
We do many a times.
why I am asking these questions means before the clinical presentation, can we make the diagnosis early stage?
Mostly.
Satish, which is this area you are in right now? Please orient us.
Yeah, see, this is the floor of the orbit here. That is the floor of the orbit. This is my nasolacrimal duct. Rising up to the orbit.
All right.
Can you see?
Yes.
Why I have removed this bone so that I can cut it flush with the orbit.
Yes.
Right. Okay.
Can you see?
Yeah.
Yes.
So I don't want to leave it hanging in the middle.
Cavity, yeah.
See the nasolacrimal duct very clear now?
Yeah, very nice.
And what you need to do now is see this clutch flush. That's it. See that?
As high as possible, always.
Yes, flush to the orbital floor.
Yeah.
Still, I am not doing anything to the disease so far. This is for the excess. See, this part of the even the lateral wall is affected. See this all rotten.
Yes.
Yes, it's all necrotic.
Yes, all necrotic, debrider. Hold. And see my posterior wall of the maxilla and see a lot of necrotic tissue in the maxilla.
Yes, all this yellow stuff laterally
Yes,
also.
it is all avascular. You know. See, all this is bad tissue.
Yes.
As I'm exposing, this is the turbinate. Now here are the ethmoids. You saw on the MRI, the ethmoids were secondarily affected. See that?
Yeah.
Yes.
This is not mucor, but this is obstruction.
Oh yeah, we can see that there is a difference in this mucosa vis-a-vis the mucosa in the maxillary sinus.
Absolutely. That's the point. See now, I have excentrated the ethmoids quickly.
Right.
That's too quick, yeah, Satish.
All this, you can go. This is the safe zone. And see, this is all ethmoidectomy done. Now, can you see the ethmoidal artery?
Yes, we can see it.
What is there? No blood
is it
flow.
lying bare?
Thrombus.
Thrombus, no blood flow.
Absolutely.
White, can you see?
Yeah.
Yes.
You can imagine the state of the orbit inside.
Yes.
This is my turbinate, which I have not removed yet. See this?
Yeah.
Yes. All.
Watch कर दिया अगर
मेरा वीडियो ऐसा भी नहीं चल
See my limits I am defining everywhere.
Yeah.
Now this is the part of the septum.
Yeah.
See, all this is devitalized.
Yes. Yeah, it's all necrotic bone.
Everything. See this turbinate. See this septal mucosa.
Yes.
See, I did not remove this septum because until I do my Danker so that I get a wide access to assess till behind. See, once you are radical, you have to stay radical. Here's the need of the time.
Pathology deems that.
Yes. I will show this with a 70-degree later. See the turbinate almost debrided. Everything gone.
So how high do you go while debriding this middle turbinate?
How?
High. How much superior do you go?
Yeah, wherever until skull base if it warrants.
Right.
See, if the skull base is involved, you have to debride the skull base also. See my anterethmoidal artery. I am debriding. There is no blood flow. Can you see?
Yeah.
I have debrided. Now, improving my access to this region is all rotten turbinate. All this tissue is rotten. See this necros cabinet.
Yeah.
Sent for frozen. Now I have amazing access to deal the things behind. You can see what an access now. Yeah. Now coming to this maxilla, see this? All necrotic. Inside the maxilla now.
Yes.
What I will do, I will open up this region. As I mentioned already, the next case is the orbital clearance.
Yes.
Induce करिए next. Anupam. Induce or not? No, drill. Give me first cover this thing.
भाई पहले ये तो खत्म कर लो. Next induce भी.
Almost it takes half an hour in the preparation.
That's right.
Suppose if the anterolateral wall is also involved, then you drill out that.
Yeah. Sometime not only anterolateral wall. Not only anterolateral wall, this anterolateral tissue.
Yes, can come up to the skin.
Next to next case, the entire facial skin is involved. See now. Drill. Now to remove this tissue, don't go blind. Improve the access. To remove this tissue here, I will improve the access so that I don't leave anything in the floor. See now, look. Yes. Our favorite drill.
Satish, how close or how far away are you from the piriform aperture?
Yeah, we have already crossed the piriform aperture. The moment I had shown the piriform aperture, if you remember earlier.
Satish, you said suppose the soft tissue is involved, anterolateral aspect.
We will debride.
Even then you do endoscopically, not...
Yes. Until the skin is involved. If the outside skin is involved, obviously you have to remove from outside.
Okay. Means, is there any reason for doing endoscopically, not by sublabial approach? If the means anterolateral aspect is also involved, lateral that.
Yeah, you can go sublabial also, but the problem with the sublabial is in the post-operative period, we avoid unless there is a deep extension outside, because in these patients, I told you the reason for doing Danker.
Yes.
We always do the Danker, and Danker gives you enough access to reach anywhere. See, no area I cannot reach with the Dankers, which I reach with the sublabial.
Yes, correct.
So why to unnecessarily give another opening? See the floor now. Can you see the better view of the floor?
Yeah.
Yes.
Okay.
Certainly, much more.
See now?
Yeah.
I think the
this is all necros. Yes.
Carry home message today would be probably doing a Denkers for every Mucor case.
Yeah, Mucor you can't take a chance, boss.
Yeah.
See now the clearance?
Yeah.
See my alveolus looking good below?
Yes.
Many of the cases you'll see the alveolus involved, and you don't have to think twice before debriding that, removing that. See, this looks healthy. Wash. Wash everywhere. We'll go behind the maxilla, as I said earlier. We need to clear all this thoroughly.
A lot of maxillofacial surgeons are advising intraoral maxillectomy for mucors. I really don't think. I think it's an overkill.
Yeah. See, endoscopy has revolutionized all these approaches.
Absolutely. And after looking at this, I think it certainly is.
Your target is to debride the necrotic areas under vision. Now, how you can achieve is up to you.
Exactly.
With minimum morbidity. And if I don't do Dankers, if I do with sublabial or anything, you can get away by doing that with a good job. The problem is the surveillance.
Yes, exactly.
How will you do the surveillance in the closed areas then?
Correct.
So we have to think the other aspect as well. We have devised this approach after looking at all aspects in these number of patients. And we are following these patients like we follow our first patients.
Yes. And you are giving them amphotericin B washes. Does it really help?
Yes. We'll pack with amphotericin only.
And then post-operative irrigations, you'll put some...
Yeah, few days.
Deoxycholate amphotericin.
Debrider. Straight. See, this area need to be properly assessed.
That's the bugbear every time.
Yeah. That area is where people overlook.
When you use these amphotericin washes, even for wash also you use liposomal?
No. Simple. The regular one, deoxycholate.
Yes.
314 rupees.
Yes. Liposomal formulation not only is safe to the kidney, but the penetration also is much better than the deoxycholate. Because of this lipid formulation, because it penetrates the fungal wall, which is lipid. This is sphenoid.
Yes.
One
is liposomal amphotericin B, and one is other drug is amphotericin B lipid complex. What is it?
Yeah. Lipid complex is another formulation, but again, the lipid complex is, you can say, it falls in between the liposomal and deoxycholate.
Okay.
So the gold standard is liposomal.
Yes.
There is another form these days available is the amphotericin B in saline.
Yes.
Saline and soluble form available. That is a different technology called sonification.
Is there any role of iron chelation therapy? This also
Yes. See, I've already mentioned in the beginning, a free iron is something required for the fungal survival, growth. And for a successful pathogen, there are many processes they derive. By means of that, they derive iron from the host.
Okay.
So free iron is what required for the survival of mucor.
Yes.
So if you take care of the free iron with the iron chelators, like dafipiron and others, it works by reducing the iron load and it can inhibit the growth of the fungus to some extent. But still it is, not in the guidelines to give dafipiron or anything. The other iron chelator, if you must have deferoxamine, you must have heard, commonly used, is deadly. It is counterproductive. If you give deferoxamine, the mucor will grow further.
Okay. Okay.
Because deferoxamine is a siderophore. It takes up the iron from the serum and it transfers that iron to the receptor directly to the fungus. It acts as a siderophore. So many of the patients who are undergoing hemodialysis, having excess free iron, they undergo deferoxamine therapy. They have a high chance of developing mucor.
Okay.
See the clearance from here?
Yes. Satish, when you take up these patients for surgery, what all consent do you take from these patients? What all do you tell them?
See, you have to tell upfront that this is a deadly disease and the scientific treatment to this disease is to, after the MRI, do debridement and antifungal therapy and long-term follow-up. Many a time, in spite of doing everything, the course is unpredictable. And you may have to do a repeated debridement. You may still develop, distal complication, cerebral complication, orbital complication. If suppose small focus is left behind, what you can do?
Yes.
So you have to have a proper consent for these patients.
And what is your follow-up protocol like?
Follow-up protocol like?
When do you take them up to look inside the nose again, or you just ask them to take douches post-op?
Yes, douches post-op, and every time you need to do debridement, you need to have an endoscopic assessment. Yes, it is required.
How frequently you repeat the CRP?
Every other day.
Every other day.
Because CRP is not an expensive test.
Yeah, and very important information.
Can you see something?
Yeah.
Yes. Is that the thrombospinopalatine?
Yes. That is the region of the pterygoid,
Yeah.
See this disease?
Yes.
My God. See this vessel? Give me the gobletter. That is the vessel?
Yes.
Yes.
This is the vessel anteriorly. ये लगा, ये पीछे लगा, ये लगा, इधर. Yeah.
Comparatively lesser than the previous case.
Yeah. So this area need to be thoroughly cleaned off.
Absolutely. Perfect.
Much better behind?
Yeah, much better.
Yes, yes.
See, actually, I'm just going out of context. Today is birthday of Mrs. Jain, and he is operating. This shows his commitment, and we all must congratulate Mrs. Jain.
Hey, happy birthday, Satish.
Thank you.
Mrs. Satish.
You all do, Satish.
So you're going to be operating throughout the night, huh?
So I will correct, it's your wife's birthday, right?
Yeah.
Okay.
Yeah.
Okay. So the gift is to be remain little away so that everybody is happy.
See this floor of the sphenoid
Jokes
should
apart. Yeah, Satish, I will come back to the basics again because
Yeah.
I have hardly done a Denkers twice just because
Yeah.
of you in inverted papilloma cases. Can you tell us small tips and tricks about the Denkers? Like a mastoid cavity, we have to drill down it to the floor.
Yes.
Okay, and nasolacrimal duct, we have to cut it at the orbital floor.
Floor level. Yes.
Right. Okay. And then we have to elevate the lateral skin also before it to expose the pyriform aperture.
Yes. And laterally, it is depending upon your pathology how much it warrants to go laterally.
Okay. Okay.
See now what I am doing is assessing the floor of the sphenoid. See, these are common areas which get affected. So don't
So
want to
what
take
is
it.
your landmark to get into the sphenoid?
Yeah, sphenoid you can see inside.
Yes.
There is. You can see the sphenoid behind.
Yeah, very well.
I'm opening the floor area with a chisel.
Okay.
Right. And I don't see much. Now we'll look up towards the orbit, the septum. Rest of the area is clear.
Satish, does that
Do you need
mucosa
to
look a
drill
little
down to
busy?
the floor?
Pardon?
Yeah.
Does the
The mucosa
yeah.
in the sphenoid? Yeah.
Yeah.
Yes. Yeah, that's what we wanted to know.
Yeah, correct.
Dr. Satish,
Yeah.
Dr. Pachori here.
Boss.
How are you? Doing fine, going wonderful. What you call about the renally compromised patient? Like I have one patient with single kidney and other kidney is not doing very well.
Yeah.
And
See, that's
he's
a,
having same orbital complications. Everything is there.
yeah. We have, that's a very difficult situation. And we have number of patients with a renal, compromised situation. And this is not uncommon because diabetic condition ultimately leads to subclinical nephropathy.
Yes.
And it flares up once you start, patient develop some infection, the kidneys, shows how compromised it is. Once you start amphotericin, it will show you. See the vessel?
Yeah, yes. Very well. Beautiful.
See this region? It's a branch.
You can see a sputter over there.
Yeah, it's a branch of it. But still, I will put a clip. See that?
Yeah.
That's the final answer. Simplest. Now let me debride give me the 70 degree first to look at the frontal above. Then we'll look at the orbit. See the frontal.
Excellent.
Hello. God.
Yes.
Lovely.
This was done with 0 degree only. You don't need to do much to it because this was just blockage. And it is quite healthy. Now looking at the septum, see the upper part of the septum even is necrotic.
Yeah.
And this you have to, thoroughly remove. Dead tissue, if you leave behind, dead tissue means hypoxic tissue. Hypoxic tissue with the acidic environment, that is the perfect conditions for the fungus to grow. क्या हुआ? Yes. See with my cobbleter beyond the dimensions of the necrotic areas. Can you see?
Yes.
I am removing this entire necrotic part of the septum. Radically. See that?
Yeah. Right.
Look at it. Hold it. Hold it. Yes.
Satish, Dr. Kirtan is here. Can you hear me?
Sir.
Just give us a guideline. We're looking at the mucosa and you decide this is infected, this is not infected. What are you exactly looking at?
So all this blackish mucosa is a dead tissue.
Yeah, but sometimes it doesn't appear that characteristically back. So are you sort of with the feel or you move it
So
and see whether...
if you find still it is, having blood supply, you can leave it. Because wherever the blood supply or amphotericin will do the rest of the job.
Okay. Because we are not, nowadays in this mucor, we are not always seeing that characteristic black eschar.
We are getting, sir. You saw the turbinates were black.
Yeah, turbinate, but now the mucosa that you're removing from the septum, etc., wasn't really black, but you said, you could make out that it's avascular and... So we just wanted to know how would one identify what to remove or not to remove? That was
it is the appearance which warrants you. And find out. See this unhealthy mucosa.
Yeah, but it's not blackish. You know what I'm trying to say, that it is, so you say it's unhealthy because of...
See this one is black. Sir.
It's pale. It's not blackish.
It's pale yellowish.
Right, this one is blackish, definitely.
Yeah, this one is black.
Satish, we had Abhijit Mantri had a discussion whether this little bit of a pale mucosa, whether it will revert back with some kind of a nasal sprays or for a prevention.
Why would you want to conserve it, Virendra?
And if you really conserve this, see this area is very well, monitorable. You can monitor later on with your endoscopy. If you find needs to be debrided, you can debride later on. But why to leave this inflamed area, doubtful area?
Yeah.
Once you can clear
I'm not here like a conservative thing. Just a discussion for a prevention or a small, little bit discoloration. Whether you can still go through it, with a simple amphotericin and a nasal hygiene. A start of a case, a prevention. Again, I'm coming back to prevention in between the surgery. But what are your things, Satish? Nasal hygiene. I'll come back again and again because...
Satish, this mucosa which you are debriding now, again, that's avascular, but it's not blackish, but you feel it's avascular, so you're taking it.
Yes, not classically black, but
it's inflamed.
Yes, not looking healthy to me, so I debrided.
Okay, that's what I wanted to know when you decided.
So even this bone was discolored, which he removed right now.
Yes, see the opposite turbinate.
Yeah, that is the classical black that you see there. Yeah.
Yes.
One. What is it? Wash karta rahe kuch. See now the last area to be seen is the orbit. I will go inside the orbit and show you what is going on there.
Dr. Murthy, are you still there with us?
See on this side, it is only the turbinate which is affected.
Yeah.
Not anywhere else, and I'm just removing this turbinate. See, this is necrose.
Yes.
See this with the debrider only. The turbinate is coming out.
You can see the superior turbinate now, yeah.
Yeah. So you don't need to do the entire, work there. This turbinate. See this?
Yes.
Yeah.
Through. On opposite side, on MRI, everything was normal. See, it is all healthy.
Yes.
Don't need to do anything. I can open up the maxillary sinus if you want. See the maxillary sinus?
Yeah.
Yeah, cleaner, much cleaner as compared to the opposite side.
Yes, it is all good. See this. See now the entire septum, all those unhealthy areas have been thoroughly debrided. This unhealthy area removal has an impact because ultimately you are removing the inflammatory load. So the ultimate requirement of the medical treatment will be less. Like sir was saying, it is not looking absolutely black. Yet it was inflamed, so it was just removal of the inflammatory load, which is a part of the treatment. Okay?
Yes.
Now, next, orbit.
So Satish, there's a question from the delegates. What is the indication for orbital exenteration if the disease is not progressing?
Yeah, so indication for orbital exenteration. Exenteration is an extreme operation. Involve removal of the eyeball, periorbita, retrobulbar tissue, everything.
Yes.
Right.
And that is indicated once there is orbital apex is grossly involved.
Okay.
To me, that is the only indication for that extreme procedure. Rest can be managed by, orbital clearance.
Okay. So that's what you are planning to show right now?
Yes, 70. Clear नहीं आ रही है. Clear. दूसरी टॉली लगा. Now with the 70 degree you can see. Stop the neck. Okay. Now see the orbit medial wall floor. Can you?
Yes. So.
Yes. See, I am exposing the periorbita there.
Yeah.
Satish, why are you using a 70 degrees for this area?
So that I can have I can keep an eye both on the, inferior and the inferior wall. Yes.
Okay.
The picture clear है वो change करना camera.
We are good with the picture, Satish.
It's good?
Yeah.
Yeah, we are good with the picture. Please don't change. It's going on very smoothly.
Okay, madam.
Just a
does this
little
eye have
glare,
vision?
that's all.
Sir, does this eye have vision?
No. No vision at all.
Satish, sir, what I have noticed is that in patients who have got early proptosis, early ptosis, if we do a medial wall decompression, which means we are removing the wall and also doing a few cuts on the periorbita, suddenly the ptosis will disappear and the eye will start opening up, and the proptosis also reduces tremendously. So we kind of reduce the pressure in the globe or the intraorbital pressure.
What I'm looking here, it's not about the ptosis. What I'm looking at, if any disease process inside, I should not miss. Because orbit is the area from where the next spread is to the brain.
Into the cranial cavity, yeah.
Correct.
Oh, the carison. And this eye is already blind, so I must explore this.
So you won't want to excentrate just from the cosmetic point of view?
No, it's not needed.
It's a blind eye.
It's not
With
needed.
so much disease. Okay.
No, not so much disease. That's what we are looking at. If any disease need to be removed, debrided, we will do that.
Generally, the observation is a blind eye with a very angry look on the eye, like extremely chemotic, proptotic, then definitely they'll end up with exenteration. But these ones with blindness or maybe just fixed eye without any angry look can be conserved.
Yes, because it is the amount of disease. I told you the next patient, bilateral,
Yes.
will require a clearance. That is so obvious, the pre-op. This is for exploration if something is required to be done, because I could see inflammation in the eye.
Yes.
In the cases of orbital exenteration that I have done, so what I noticed is that the disease is mainly in the orbital apex, or it is in the medial wall, or it is in the intraorbital fissure region, going into the pterygopalatine fossa.
Same, inferior and the medial wall, and towards the apex. See, this is inferior.
Yeah.
Yeah.
This is medial wall.
So there it looks like no disease. So the reason with the blindness is because of retinal artery.
Vascular.
Vascular. Okay.
Most of the time it is vascular only. Direct contiguous involvement is less common. That can lead to optic nerve inflammation and blindness.
Okay. Ramesh, Dr. Murthy, anything to prevent this retinal artery occlusion, like vascular?
Possibly aspirin has got a role.
All these COVID, that's why all these COVID patients assumed in a prothrombotic state are always given some anticoagulants from beginning. See the inside the orbit. Can you see?
Yeah.
Can you see the pus coming out?
Yes.
Can you see the pus pouring out?
Yes.
Can you see this necrotic area?
Yeah.
See why I was looking at. Had I not opened the eye, what would I have missed? See that? In a normal looking orbit, from endoscopy, see where I have reached.
Yes.
See the disease.
Yeah.
See the purulent discharge pouring out.
Yes.
Can you see this disease?
Yes.
See all necros?
Yeah.
This is healthy, this is necros. See, this is
Satish,
true.
just point out healthy necros. We would like to appreciate the difference. Just show once
and
more.
this I picked up from MRI. I showed you.
Yes.
Imagine this pus, this necrotic area, you leave behind. What would happen? No amphotericin would work in such regions, necrotic. Again, this is all inflamed. See this with a 70 degree.
Yeah. Very well.
This is the real role of microdebrider. दे भाई कोड सेक्शन ले लेगा See, this is healthy, inflamed medial rectus.
Yeah.
Yes.
And this is necrotic. See that? See what I am debriding inside the orbit?
Yeah.
Yes.
See this? See this necrosis?
Is it part of the muscle?
See the normal and the necrotic difference on endoscopy. I am debriding inside the orbit.
Orbit.
Satish, if you can just point out healthy and unhealthy tissue, just clarify so people understand.
Sir, healthy is the white necrotic tissue. I am taking away with a microdebrider, and rest pink tissue. See this? Vascular I am leaving behind.
Okay.
So with the microdebrider, with the help of endoscope, with the MRI pointing out the areas.
And somebody is retracting the orbit laterally for you?
Yes. Yes. So why to accentuate unnecessarily every eye? Once you can do this conservatively, but you need to have all these gadgets, MRI assessment.
Definitely, Satish sir, I think we should not exaggerate. We should exaggerate the least number of cases, I think. We should avoid it if possible. Because the mental trauma is too much for the patient. The loss of the eye.
Yeah, that is to me secondary. Once it is mucor, life is more important. But the issue is the need. Once there is no need, why to? See this? This is inflamed. Remember the MRI I had shown. See the necros tissue. See this?
Yeah.
See this necros. And see this part of the orbit anteriorly is all healthy.
Yes.
First. This is the disease. See, all necros. See, this is necros. Can you see?
Yeah. Very well.
Now I'm so happy this necros tissue is almost out. I'm working in the depth of the orbit, behind. See, that is the region of the orbital apex.
Yes.
See this area? Clean. इसको दबा. See now, absolute healthy. Hello.
Yeah, wonderful.
Yes. Satish, where would the optic nerve originate?
Optic nerve here in the depth. Here, if I go, block. Optic nerve passes through the middle of the orbit from all sides. Let me tell you. See how deep I went inside the orbit and debrided.
Yes.
Yes, Satyakam.
See this now, orbit, it is wide open.
Yes.
See the orbit wide open?
Yes.
All healthy muscles everywhere, but free of that necrotic tissue, which was seen on MRI.
Yeah, this that is prolapsing, you say that it's healthy fat.
Yes, this is all healthy fat.
This is all healthy fat. you
Yeah,
say.
no need to remove this. See this?
All right.
My inflamed area was here.
Yes.
Mm-hmm.
Necrotic area, no drug would reach there. And had I left that behind, this would progress to the brain for sure.
And the MRI directed you towards this area.
Yes. I will take you to the MRI after this again. If you want.
I think you'll be hard pressed for time.
Just 1 minute, I will show you.
Okay, sure. That would be great.
So you can see why in a normal looking orbit endoscopically, why I went inside and removed this. See this?
Yes.
Yeah.
Now it's pretty clear. See, the CRP is the inflammatory marker. If you leave such disease behind, believe me, CRP would never come down straight. And that will keep reminding you that you missed something inside. See my pterygopalatine fossa? Yeah, this maxillary artery. See the pterygoid process, orbit, the skull base, the septum I have removed completely. The orbit I have opened and see inside the orbit there behind.
Yes.
This is the kind of clearance this patient wanted, 0 degree. So a complete debridement, adequate debridement is the key to the success. And to to reach that adequate debridement, you should have adequate information by MRI. If your assessment is incomplete, you can't think of a good, outcome. Section. To me now, let me give it a wash and show you. Almost done. Orbit I did in the last, I told you. See now, all healthy. Remember the picture when we started.
Yes.
And this is, see again, this is the part of the orbit we entered.
Yes.
Can you see now?
Yes.
I hope it is very clear.
Very well.
It's clear. Few
Satish,
bony spicules, yeah, those if you could remove.
Yes, yes.
Satish, one
Obviously, yeah.
hypothetical question. Dr.
Yeah.
Sujay Joshi is asking from Anand.
Yes,
Is
please.
if this patient would have been with vision, any specific precaution would have you would have like
See,
take or any?
yeah, that is a very, very difficult situation. That your orbit is affected and vision is still normal.
Yes.
That is something like your facial nerve is affected with a tumor 360 and still it is normal.
Correct.
So you have to take a call, and we have, learned a lesson. I always mention in my talk. We had a patient, it was almost 3 years back, of mucormycosis, had orbital lesions, absolutely normal, this thing, vision. And it was, difficult a decision to exentrate or to do anything inside. It was quite close to the optic nerve, so we relied on the amphotericin post-operatively. Third day, he lost the vision. And then we debrided, it was all necrotic inside. But how to take a call in a patient whose eyesight is clinically normal? So your question is valid, and it is really, really a difficult decision. But you need to explain your patient life is important. You have to once you have to choose between the life and the vision on one side, obviously you have to take a call to sacrifice the vision to save the life. See the final picture?
Yes.
Wonderful.
Excellent.
Satish.
Yes, sir.
Dr. Satish, Dr. Dubey from Bhopal.
Sir, धोखा देंगे आप?
हाँ, धोखा देंगे. I supposed to be there, but I could not able to make. But I am seeing you since evening, and by doing Denkers, I have done today 3. A lot of mucormycosis are there, but you see what I saw in one patient.
Volume तो बढ़ाओ उधर.
Pupillary reaction to begin with, it was normal, but after case when we enter into the orbit, it becomes dilated. Though vision was very poor there, and I have already explained them that you are not going to get the vision because a lot of necrotic material was there. When
side vision loss.
Yeah, but Dubeji, if you have the third nerve affected also, then the pupil will dilate. Huh?
But pre-operatively, it was not dilated.
No. After you went on the orbit surgically, then even if the vision is there, you could get dilatation of the pupil with involvement of branches of the third nerve.
Okay, sir.
We move on to the now complex situation. उसको बंद कर देना, इधर चालू कर दो.
Is Dr. Murthy here with us?
इसको चालू करो, इसको. Hello.
Yes, Satish.
So now we move on to the more complex situation, wherein the young patient who has lost vision in both eyes, bilateral complete blindness. What a miserable situation one can think of, owing to the COVID sequelae. Steroid.
Oh.
And after this, I will show you the MRI of a patient. The next one is a revision one who was operated somewhere 3 days back. And the day after, patient developed blindness. And you see a lot of disease left behind. This is what a lesson we need to learn from our own mistakes, our colleagues' mistakes. And this is really something important not to be ignored. The debridement, adequate debridement. Now, this particular patient, let me show you. This one, yes. Can I? No, yaar. Kalla Devi. Na. Yes. Select folder. Yes. This patient. Yes. Yeah. This patient, look at the situation of the disease first. Can you see the maxilla?
Yes.
All non-enhancing areas, see the turbinate, bilateral.
Yes.
See bilateral and see where it is going. It is going to the orbital floor.
Apex, yeah.
See the orbital apex.
Yeah.
This is the pterygoid bone. See this? This eye has a proptosis as well. And see what is their difference. Look at the carotid and the carotid on this side. What is the difference?
Thrombus.
No contrast enhancement in the cavernous sinus.
Absolutely.
Can you compare the cavernous sinus where the carotid running on this side with this side? Can you make out?
Yes, yes.
Let me make it bigger. Can you make out or not? This area is not enhancing. Can you see?
Yes.
And this area is enhancing. This is cavernous sinus. See, this is the cella in the middle.
Yeah.
Both paracellular region where the paracellular carotid is going. And see on this side, it is enhancing on contrast. But what is happening on this side?
Yes.
That is the cavernous sinus which is involved. See the sphenoid, the level of involvement in the sphenoid. See, this is the pterygoid bone. And this is the sphenoid bone which is involved. Massive disease. See this? Infratemporal fossa, parapharyngeal space, all this disease everywhere. Massive, and it is extending to the orbital apex.
Yes.
And here in continuity from the orbital apex, it has involved the cavernous sinus. See this? This orbital apex is just anterior continuation of the cavernous sinus. Let me show in the sagittal picture. Let me bring the sagittal together. This one. Yes. Now, yes, that is the level of the cavernous sinus. See the carotid artery level?
Yeah.
And see here, this is the sphenoid which is involved. This is the disease process involving the retromaxillary tissues. That's the carotid artery. Can you see?
Yes.
And right here, up to the carotid, everything is necrose. This area is completely necrose. You will find once we explore. And that is a massive disease you can think of. So this patient, very unfortunate patient, the victim of the steroid therapy. See, let me show you the septum. Can you see the septum?
Yeah.
Showing loss of contrast enhancement completely. Can you see all the way? Hello?
Yes, we can.
See the septum, loss of contrast enhancement.
Yes.
Opposite side. And see this side massive with a proptosis with massive disease, and it is involving the orbit. So this side of the orbit, let us assess on the fat suppress image. Yeah, this one is fat suppress. See this? What is this? On fat suppress, this is all disease. See all this?
Yes.
This will require orbital clearance. See this massive disease than the previous case.
Yes.
And this is what, see the recti muscle so intense, hypertrophic because of the fungal involvement. This is huge inflammatory process going on. And this left eye will require most likely a clearance. There is a huge, massive, involvement with the fungus. This will require a straightforward debridement of the eye from inside.
Yes.
See the disease, how it is going into the orbit. Septum is gone, opposite side is gone. And this young, see this 36-year-old female, non-diabetic, Before COVID, she was non-diabetic, was given steroids for 15 days, had a CT score of 18 with the COVID. And now the mucor is taking its toll. So, any doubts? Anything you want to see on CT? Or MRI, sorry?
No, nothing. Quite clear.
It is so obvious, so clear on the left side. See this all inflammatory process. This is all on, see this.
Yes.
Satish sir, later these patients may develop thysis bulbi when we remove, posteriorly we have removed the disease.
Yeah.
Bulbi is not there, then subsequently they will require some prosthesis after 2 years, 3 years.
Not yes, once you do the exentration, obviously then it will require.
Okay.
Exentration will require.
If you do the endoscopic debrider, then I will remain with this.
Yeah. If you are keeping the globe and the optic nerve intact,
yes,
with the muscle surrounding and the periosteum, you need not to do anything. Like in the previous case, you don't need to reconstruct.
It will not shrink in years together. It will
not really. Not really. But this case patient will require massive work. Though the third case is more advanced than the second one.
Yes.
And this is a real extension of the mucor to the sphenoid bone. This will require a lot of drilling of the sphenoid. See this? This sphenoid bone will require drilling. This all enhancing muscles around will not require any removal. See, enhancement will be taken care of by amphotericin.
Yes.
Only non-enhancing areas will be removed. This side, the septum, the sphenoid bone, and see the opposite side. So this will be a massive case, bilateral.
And enhancements ascertains vascularity indirectly.
Yes. Wherever the gadolinium is reaching,
yes,
your amphotericin will also reach.
Correct.
A treatment of choice for this disease is medical. Surgery is not the treatment of choice. Again, the role of surgery is to remove the devitalized tissues, to remove the fungal load, to remove the source of further infection, to remove the hypoxic dead areas, to facilitate the medical treatment better.
Satish sir, even post-operatively, these patients, if they develop some infarct, in the cavernous sinus area or some lacunar infarct.
Yes.
Although they are on Clexane, one of the patients which I have operated 15 days before.
Yeah.
Now we have done the repeat MRI after learning from you that whether we have left some disease or not. The finding was there that there are some thrombi in the cavernous sinus and there are multiple lacunar infarcts are there in the cerebrum. Though Clexane was on all the time.
See, that is a thromboembolic phenomena. This mucor has an affinity to the vessels. And involvement of the cavernous sinus is the gateway to spread in the cranial cavity by various means. Hemorrhagic infarct, ischemic infarcts, embolic infarcts, anything can happen.
Then what should be done with these patients? We have started posaconazole.
Immediately after the surgery, like for such patient, we next day will start some anticoagulant.
Okay.
That is the need. Always cover with the last patient had some infarcts earlier, so we cover with the anti-epileptic as well.
Okay.
And you can't do anything. You have to allow it to recover on its own. You can just remove the source of disease and introduce mega dose amphotericin, double antifungal with like this patient also will be using amphotericin with posaconazole both.
How much? 300 milligram or double the dose? 600
for this patient more.
more.
Yes, this is 52 kg lady. Will be giving at least 400 or 450, whatever tolerable, depending upon the renal functions.
And what sir, renal function? How often we do the renal function for
every other day? Every other day.
Every other day. And what is the? What is the restricting factor when we stop? Reduce the amphotericin B.
See, that's why we need to know the definition of acute kidney injury, AKI.
Right.
In 48 hours, if your creatinine is raised by 0.3 milligram, that is acute kidney injury. If your creatinine is doubling time is 48 hours, AKI, and then you have to keep an eye on the urine output, nephrologist care. As long as urine output is there, you can continue amphotericin by reducing its dose. You can skip in between for a day for the kidney to recover and again reinstitute. And if no urine output, then you have to take a call of dialysis. You have to change to isobuconazole and other things. That's a complex issue. But amphotericin, the antifungal, is the need to be given to save patients. At the same time, managing the kidney parallel.
Right, sir.
But not to the antifungal not to be stopped.
Sir,
otherwise the whole purpose will be defeated.
Sir, there are so many preparation available in the market, and people may bring some preparation which need some sonification also.
Yeah, latest one.
You recommend which amphotericin B, which is very reliable because you have a vast experience.
See, 4 types of amphotericin are available.
Right.
The traditional amphotericin deoxychelate, liposomal, lipid formulation amphotericin B, and this sonification, this amphotericin B by sonification process, saline soluble amphotericin B. This is the latest one.
Yes, sir.
Though still there is a lack of evidence to support that extensively. The company supports with the evidence, but still it is not in the any level guidelines. So out of all these, the best is still the liposomal amphotericin B.
Okay.
Best in terms of penetration, best in terms of least nephrotoxic, being least nephrotoxic.
Sir, there are several brands in the market because I am dealing with these cases with your guidance. Patients sometimes say that the preparation which you are advising is very costly. We can have from the market, and there are different rate variation in the amphotericin B.
Yeah, different companies, different brands have different prices. There is no rate control in India.
Yeah, yes. And now they have increased the prices suddenly since the last 5 years.
You see the preparation which was selling, they were 5,500. Now they are 9,000. Suddenly
yes, suddenly spiked up the prices.
Which brand do rely on? It's not any commercial issue, but we just want to learn from you.
Sir,
now
in Jaipur,
very reliable.
We are fortunate in Jaipur to have Lifesaver. Lifesaver is a shop which provides life-saving drug at the cost to the patients.
Wow.
So like amphotericin, liposomal to our patient costs less than 3,000 rupees.
Oh, that's so good.
Oh, good.
And you can order and, buy anywhere in the country from Lifesaver.
Okay, we can send our patients.
Please share the number of Lifesaver. And you see what I am facing right now. I have requested you also that we ask somebody for amphotericin B. They were telling our medical people that will give on the MRP, not less than that.
Yes, it is running short nowadays.
It's running short.
You bill the patient directly, but ultimately you see it is so costly that sometimes people say that it is, prohibitively costly sometimes.
Yeah. That's why there is a significant rate in, incomplete treatment. They just drop out.
Yes.
That's a big problem we are facing.
And see, your adequate debridement will call for less duration amphotericin therapy.
Absolutely justified. Correct.
When you recommend, Satish, when you recommend reconstruction in these cases, like suppose you do take out the palate, etc. When you recommend,
we don't recommend any simultaneous reconstruction because we want surveillance.
Yes, yes. So
every other day we do endoscopy for removal of the crust, to application of topical amphotericin, to see any necrotic areas. That is key to the success. If you obliterate the areas with something, then you can't have any access to the areas for surveillance.
But I think, Satish sir, with your Danker's approach, I mean, surveillance is always very easy.
Amazing, amazing.
I have seen your last video in which one of the plastic surgeons which you rely upon was with you, and he was taking tubular graft at the same time, because you have removed very extensive disease. You have removed the half parrot and everything.
Yes,
and
sir.
last time.
Sir.
Satish, you said you have seen many post-operative cases and revision surgery you are doing. Suppose if a patient comes to you with CSF rhinorrhea who was operated for mucormycosis, then how do you deal with that?
We have seen. See, for CSF rhinorrhea everywhere, you have to, segregate the intracranial space. You have to segregate the subarachnoid space. You have to seal that. In the same way, you seal any other CSF leak, and that is the need. Obviously, on priority, you have to seal that. In the same way, like you do any other CSF leak. At the same time, your debridement should be adequate for mucor, because mucor doesn't give time.
So when we can say that our mucor case is now totally relieved, or you can say free of mucormycosis, how you diagnose it?
Yes. So like I tell you, follow up. After 5 to 7 days, we switch over to posaconazole, as every other day our CRP is drastically reducing. Okay. And that happens only once you remove the necrotic tissue, and amphotericin is killing the fungus. Deadly. Amphotericin is deadly to mucor.
Yes, yes, yes.
Like mucor is life-threatening to us, amphotericin is life-threatening to mucor. So 5 to 7 days of amphotericin, full dose after debridement, takes care of everything, and the CRP goes drastically down. Meantime, you have 3 endoscopic sessions done with cleaning, application of amphotericin, everything. Yes. And then it is your clinical decision to switch over to posaconazole.
Satish, suppose if the intracranial extension is there, too much of intracranial involvement is there, then would you like to do in 2 stage, means neurosurgeon will do in the second
same stage. We have done couple of cases. We have done the debridement of the temporal lobe on one side, debridement of the frontal base. Complete.
The neurosurgeon will go transcranially and you will do the endoscopy.
Yes. Yes. Yes.
We had one today morning,
same time.
And sir, posaconazole, which brand do you recommend?
So many, 3, 4 are there.
Posanet, so many brands.
And they are now come up with the gastro-resistant tablets, the latest one.
Yes. See, so posaconazole has 3 formulations. Let me tell you. This is an important question. The easiest for the patient, the most convenient is the suspension.
Okay.
Yes. But to maintain the serum level with the suspension is difficult. You have to tell your patient to take posaconazole syrup after high fatty meal.
Okay.
Twice a day. Otherwise, the absorption is less. So ask the patient to take posaconazole after high fatty meal both times a day. Right. Otherwise, switch over to the sustained release tablet. That is equally good. And nowadays, the injection is also available.
Yes.
The cost is again a limiting factor, because posaconazole syrup is not yes, it is
cheap either. It's also
12,000 for 105 ml.
Yes, we are getting it at 19 here.
Every ml is 40 milligram. So like you are giving every day 800 milligram. 800 milligram means 10 ml twice a day.
Yes.
20 ml a day amounts to 5 days for a syrup.
2,000 rupees per day.
And that goes for longer until your cavity completely heals up. Completely heals, completely mucosalized. Patient absolutely symptom free. If you are doing radiology, radiology free. CRP, ESR back to normal. Your underlying immunocompromised condition corrected, and then you switch off the posaconazole. So it may take months.
I mean, like you say, we say always that the nasal cavity will recover in 3 months. At least for 3 months we have to give, or
Yes.
You have to
Yes,
give.
on an average, you have to give posaconazole minimum 3 months.
3 months. I mean, cost is really prohibiting in this patient. I think.
And most of them have spent a lot for the primary COVID treatment, and they've come with this secondary complication.
Sequel.
That's a big, it's a big
Absolutely
issue.
right. Because
Primary COVID treatment, monetary and mental harassment.
Absolutely. Bad disease
And
to
this
harbor.
sequelae presenting with blindness, and then again a more expensive treatment than COVID.
Yes.
And full uncertainty about the future, whether this is going to be cured or not.
Absolutely.
This is really pathetic.
Satish sir, I just want to, you should make a statement that how to counsel a patient, such patient, because it is very important that what a statement we should give to these patients.
See, these patients, you have to tell them honestly that what is the situation and what you can contribute to it for the cure.
Okay.
You can show them a way to cure, but things are so unpredictable, you cannot promise every time. But believe me, what we have seen, I told you we have done more than 300 surgeries.
Yes, sir.
Proper debridement.
Sorry to interrupt you. Can you start with the next case, or we are waiting for something?
Already gone for the wash-up.
Okay.
In a minute's time.
Dr. Satish, I read your article and your interview in the Dainik Bhaskar today. I mean, you see, thanks to you and other people, because Times of India also, we read so many, things from the people from Cooper Hospital, and there is an article in the Times of India. I mean, they have already propagated that this is a life-threatening condition, and people are already convinced that something has bad happened to them. But still,
for prevention, you have to have meeting with your physicians who are treating COVID to convince them for the judicial use of steroids and proper glycemic control. Both of the things are being totally overlooked by and large.
Sir, is there any role that we should, give them guidelines empirically? Because as I am advisor to the Madhya Pradesh COVID committee.
Yes, you must give them, sir.
Then what we should give them at that, they should start antifungal also along with that, with the less steroid doses.
No.
See, guidelines are not very extensive, very clear. Not to give steroids to the mild cases.
Okay.
For moderately severe cases, steroid, the doses have been defined by the Indian guidelines as methylprednisolone 1 milligram to 2 milligram per kg per day, and this dexamethasone 0.1 to 0.2 milligram per kg per day. Only at the time of inflammatory surge, to curb the inflammation, not from the beginning, for limited period 5 to 7 days. They have kept the dose of dexamethasone at 6 milligram per day only for 7 days, not beyond that, with proper glycemic control. Right. That is the key to prevent this dreaded disease. Otherwise, the population of blind people is tremendously increasing.
Yeah. Sir, I am really afraid that I talked to Dr. Milind Navlakhe also. He told
me. Can you see
the
endoscopic picture, sir?
Yes.
Look at this patient. All necros. You put your endoscope, this necrotic tissue, you don't need anything for the diagnosis.
Yes.
This lady underwent COVID treatment. This was non-diabetic. Was given steroid, her blood sugar level reached 600.
It's very common that most of the people who are non-diabetic, they are having very high blood sugar now because of this, right?
Yeah, I think we are looking at a class of latent diabetics, pre-diabetics. So what we are doing is now at the time of diagnosing a COVID positive, we are asking all of them to do a baseline HbA1c as well. I think we have to start identifying a high-risk group.
But the HbA1c is coming 10, 9.
Yeah, exactly. All
like
of them.
This.
I mean, none of my cases of the last week, and we have done almost 27, all of them have HbA1c above 8.5. None of them have normal HbA1c.
Yeah, HbS AG above 8 is alarming to such patients.
Absolutely.
See the condition of the cavity.
Yeah, all necros.
All necros, everything. See the septum. Look at the skull base completely. Lateral wall, see the turbinates. And we have seen on the MRI how the disease has gone into the orbit everywhere. So now there's a third case is a massive one. And fourth being the revision. Same, spend 5 to 10 minutes for the exposure.
I think your Dankers is the master stroke, I must say.
That's a very important part of this entire,
yes.
strategy.
Dankers is the master stroke. And sir, it's really that post-operative care will be amazing by doing this Dankers.
Yes, 100%. Somebody was asking the pyriform aperture last time.
Yes.
Look at the pyriform aperture.
Yes. Very clearly seen. And it is, I think, little bit anterior to the inferior turbinate.
Yes.
Very little anterior to the inferior turbinate.
Yes.
And you always expose very nicely because,
you don't have to come. You don't have to come far anteriorly to prevent this injury to the lower ala.
Right, sir.
Otherwise, our rhinoplasty surgeon will pitch in. We have Dr. Virendra Gaisas here.
Yes. That is what
Master rhinoplasty surgeon.
Yes. He will raise all
President AOI Pune.
First, he has given the guidelines for COVID. Mucormycosis.
Yes.
But your interviews were very amazing. Today I read in the Dainik Bhaskar in detail.
Sir.
Satish, your interview was very informative.
Really?
Anybody can log into Dainik Bhaskar Jaipur, in which Satish has answered and he has given examples of 4 cases, including, one case of blindness also. And it's really key that most of the surgeons are doing surgery without knowing it, doing FES. Because you see, one of my physician was telling on the WhatsApp group that the ENT surgeon will do FES in this. See, Satish.
Yeah, sir.
There are a lot of misconceptions. That is why they are doing
there are.
The patient leads to these kind of complications.
Yeah. And see, this mucor treatment, overall treatment of the mucor is purely a domain of ENT surgeon. Purely.
Right.
Even with the blindness, ophthalmologists have nothing to do.
Right.
Satish, the whole idea of organizing this webinar is if we have kind of a consensus agreement or a set protocol all across the country, so that this injudicious use of steroids, and we can bring awareness in amongst our physician, intensivist colleagues.
Oh, boss, the physicians still are not ready to listen to. Physicians are still not ready to listen to.
Correct. That's going to be an uphill task, but also for our ENT colleagues, where as you said, Dankers is, and Dr. Dubey also has experienced it. It's going to be a hell lot of a difference between our surgical management of this extensive patients, our post-operative surveillance, and things like that.
You're absolutely right, Guy. What is happening, that the people are doing incomplete work, and ultimately those cases landing into the, complications. Basically, Dankers has to be popularized amongst the ENT surgeon, so that if they want to do, they should do the complete work.
But sir, nowadays, I think we have demonstrated last year a couple of times in webinars, probably every surgeon who is doing endoscopic sinus surgery is probably well versed with the Dankers now.
Because of your nasopharyngeal, you see, when I have done few surgeries, I talk to you because I have a privilege of talking to you very regularly.
Sir, it's a blessing for us.
A few cases which I have done, it's really amazing. It's really amazing. And you see today's webinar, when you show the case, at the same time, I was doing also the case. In first case, I was not there. As you told that, this is involving posterior to the maxillary posterior wall. So it was really, we have to look, and the CT, the way you, told to read the MRI, it's really eye-opener for every ENT surgeon. I think they can...
MRI is the key. Yes, sir.
It's an epidemic now. It's an epidemic. Everywhere people are getting so many cases. Not in Maharashtra, but in Madhya Pradesh also. I have seen more than 50 cases in last week.
Yeah. See, the reason is simple. Reason is simple. I told you, the diabetes and steroid.
Yes.
Tocilizumab.
Guy Fode.
See,
with the help of doctor.
Still things were not adequate, and people brought the tocilizumab, which has practically no role in the COVID management. Even the WHO and ICMR has defied several times. But see, it is a fear factor so much that there is a cytokine surge. Tocilizumab may work. It is being sold in black. So no use. Or tocilizumab has a detrimental effect on the overall immunity. But majority of the patient acquiring, COVID, many of these patients has undergone tocilizumab treatment.
And people are paying in place of 40,000, they are ready to pay for 1 lakh, 1.5 lakh.
See, for a disease which has no drug so far, and the treatment cost is in lakhs every day. No drug for this disease so far, all is symptomatic treatment. That's it. And it, resolves on its own. See the inside.
Right. Very clearly seen. I think Viren Gaisas is there. He's a president of AOI Pune. Guy Fode is there. He's a president AOI Mumbai. And I am there in Bhopal with the state government advisor. I think...
Sir, you can really bring in some guidelines.
Formulate something. Because you see, Principal Secretary of Health came to me yesterday. I am going to tell him, we'll formulate a guideline. I think Virendra already has formed some guideline from Pune. I think we will include something new in that, and with the help of Satish, we will form a guideline, and we will really recommend to the state government that they kindly follow it. In Madhya Pradesh, I can tell them to follow it very strictly.
That will be a huge boon to the mankind, sir.
Mankind, right. We'll do it.
And we'll involve our national body also, which will have more weightage rather than, just 2-3 isolated associations. So coming from the national body would be a more kind of a consensus statement.
No, we will say to Samir also, once we formulate the consensus statement with the help of Satish Jain, then we will call Samir also.
Sir, our friend Dr. Ashish Bhumkar is also working on it. He has developed a proforma also.
Very good.
I think with Samir Bhargav, he is already taking a lead. With you having contact with the government, Ashish Bhumkar, you guys can really do something. And it is the first job is to convince our physician friend
Yes.
about the steroids.
Right, sir. We have to do it very aggressively so that there should be a directive issued from the government and the health department.
Yes.
That indiscriminately, like you see, today I have
There should be a check on the steroid prescription.
Right. Because they're writing for the months together, 16 milligram Medrol for 15 days, followed by 8 milligram for 15 days, then 4 milligram. They are giving it, and people are having blood sugar and HbA1c more than.
See, majority of the patients are being treated on the OPD basis, wherein no blood sugar control is part of the management.
Right.
No blood sugar checkup even is a part of the management.
Satish?
That is, yes?
Hi, I just joined again. I was on that other one.
Yeah, Ashish, I just mentioned they are working on the...
So that Srikant Shinde has already is extremely impressed. This is very, very important. And I think he's wanting to do a VC with all the commissioners of Maharashtra with you.
He can convey our voice to the government.
Yes, no, he wrote to me a message before he sometime in the coming week he will arrange. And whatever talk you gave, something similar and a better protocol will come out with something.
See, this is 5-10 minute exercise for the access.
Right.
And this is a massive case with all dead tissue behind, everything dead. Hmm. 40. Wash.
So Ashish sir, Commissioner Chahal is different from your commissioner.
Yes.
He is of Mumbai, who has tackled COVID in a very different way.
Brilliant. He's really the hero of Mumbai.
Hero of Mumbai, because he has made some, ward warrior team.
Sir.
Yes.
See, I am removing the posterior wall mucosa.
Yes.
Right, sir.
And you can see the glimpse of the disease behind.
Yes.
Right.
Behind the intact bone. Can you see something?
Yes.
Color change, we can see the bluish.
See, I will show you simply using this periosteum elevator. See this?
Yes.
Yeah.
What is all? See this necros.
All necrotic material, yes.
Everything necrotic. See this?
Yes. You have emphasized
See
the
the-
MRI as the guiding.
See the necrotic material.
Yes.
How will this amphotericin reach to this area which has no blood supply?
Right.
And this patient will require a proper orbital clearance. I told you. There's a massive case.
Going to the cavernous sinus around the carotid.
डबल लगा देना यार उभार कर सक्शन
दिखाया था MRI दिखाया था बराबर से
क्या दिखाया था सर?
Yes sir.
MRI में sir, it is going around the carotid in cavernous sinus.
Yeah, it is reaching the cavernous sinus.
So he must be having ophthalmoplegia, loss of vision.
Yeah, complete.
Bilateral.
Yeah, complete ophthalmoplegia. This is my nasolacrimal duct.
Yeah.
Funny.
Ophthalmoplegia and loss of vision not the indication for orbital exenteration, Satish?
Yeah, orbital apex involvement, man. Let us see in this patient how the orbital apex is.
Sometimes, sir, initial patient has got all
most likely involved. most likely involved. Let us see how extensive it is.
Sir, if patient is having all the eye movements except the lateral movement, I mean LR6 was gone, then what?
See, all eye movement except
Lateral movement.
lateral movement means your lateral rectus is working. You mean to say?
Lateral movement is restricted here. LR6 na palsy.
6 nerve palsy.
Yes, even I have seen one isolated 6 nerve palsy case, and
Because you see, patient was having something there, but not exact ophthalmoplegia, but he is having only one gauge paralysis there, lateral gauge.
patient presented with
See the level of transaction of the
Yes, yes, it is very
NLD.
Yes, yes.
Flushed. That's it.
So again, I'm asking what we'll do for that single kidney case and with the renal compromised patient, because with the mucor, what you will advise, what you will do, you will do surgery and then no computers will be for these cases.
For which cases?
Like renally compromised patient, like single kidney.
Yeah, see, the treatment is going to be same. Only thing that will require additional parallel treatment for the kidney. Now, how much it will allow us to give amphotericin is a matter of creatinine levels.
I think what are the criteria for acute kidney, the term which you have used?
Acute?
Acute, I mean the criteria, the term which you have used previously.
Yeah.
Acute kidney insult, how much
Yes.
creatinine low?
Yeah, in that situation, your creatinine doubling time.
Yes.
In 48 hours, if it goes to double, see this.
Yes.
All this bone has to go, and behind is all disease. I can see our
doubling time is 48 hours then.
That means your acute kidney injury, you have to do something. Debrider, see this all involved.
Right. Then we have to step down the amphotericin B or hold the amphotericin B.
Hold amphotericin for time being. Reduce amphotericin. Take your nephrologist opinion. See now.
Even go for dialysis.
See the.
Yes.
See, I am in the orbit.
Yes.
Right.
And see, all this is necrotic. See this?
Yes, very nicely said.
The orbit is full of necrosis.
I think Satish, you must have done more Denker's approaches than Denker himself, I think.
Denker is our feature of everyday theater.
And I think since last 8 months or 9 months, India is, I think, most of the people are doing Denkers now.
Yeah.
Since the last webinars.
I think we should call it the Jain approach only.
JNAs, Denkers.
Yeah.
See the difference in the keenness. Sir was asking the difference in the necrotic tissue and normal tissue. See, this is normal fat.
Yes, you can see.
Yes.
And this is necrotic.
Not bleeding at all. Yeah.
I can see my vessel here. Here, below. This one. See the maxillary.
Yes. And all necrosis around it also.
Right.
At least the picture is so clear that we can appreciate the tissue differentiation, the color changes, and every critical structure we can identify.
That's the beauty of the endoscope. See now, I am close to the vessel.
And the audio.
See what I have defined, my lateral limit, the healthy muscles.
Yes, we can see.
This is also, Satish, better disease to understand the anatomy, instead of your JNS. Because there's necrotic which you are taking away.
Yeah, because there is no bleeding at all.
Yeah. So the orientation is so much better. The first case, maxillary and median.
Definitely.
Straight there. See this turbinates, all rotten.
Oh, yeah. I meant to ask, and this is for the general. I've asked you this question in personal. But
See this, all.
Even if there is a
Yes.
very small crust on the middle turbinate, even that should be debrided, no, you said?
Yes. See, if such patient, suppose post-COVID, had this patient been coming to you, you could have picked up her disease in the earliest phase. You would put your endoscope and find some excessive crusting in the nose, some blackish eschar coming, giving you the suspicion in the most early stage. And that would have been the
Next step would be to do an
best.
MR.
Yes, next step would be the MR. Stop getting CT scan done for this.
Yeah.
No point.
MR with contrast,
Yes.
gadolinium.
See this, all necrotic.
Yes, yes.
See this, all jet black. See this?
Yeah.
Wash करता रहा कर. सोई मत रही.
Are we still, the lion thing is on still, or now we are off that?
Lions is connected.
Still connected? Okay.
We are grateful to Dr. Ashok Rokade, who is doing great job. Yeah, this section.
I saw Richard Harvey's surgery yesterday. Probably on the same network.
Section बढ़ा ना. बुला उसको. Zero. Debrider. See the things improving, the situation, the access improving. See all necros. The septum part necros. We knew from MRI. Opposite side is also affected.
Opposite side of the septum?
No, opposite side is a bilateral disease.
Oh, okay.
And Ashish, next is the interesting case in the sense what mistake one can do warranting a revision surgery.
Okay.
Sir, amphotericin B is given 300 milligram IV, or I mean, we can give less than that dose because it causes
See, all paranasal sinuses gone. Yes, sir, amphotericin?
Amphotericin can, or it has to be given 300 only.
They don't take the value, take the milligram per kg.
Disease.
Minimum for a good kidney function, start with the 5 milligram per kg.
Okay.
A good kidney function. With massive disease, intracranial extension, you can go up to 10 milligram per kg along with additional posaconazole. See, this is the orbital floor.
Yeah. Where's the lamina?
This bone is gone. This is the medial wall of the orbit. It's all gone.
We've lost the picture.
Not the picture.
See this? See this? Just a minute. Wait. Some loose connection. रुकना. Section करा, double करा देना. बाकी सारे बंद करा.
Hello. Hi. Bolo.
Thank you so much, yaar. Me,
Kya?
Dr. R, thanks a lot from across the India to you.
For what?
For the, organization.
See, Ashish, that is inside the pterygoid process. Can you see?
Yeah, Satish. Yeah.
See, full everything rotten.
Yes. Right.
See, all this necrotic bone. And now see the pterygoid process behind. This is pterygoid. See this?
Yes.
All gone. Divider. See behind. See this? Massive necrosis.
Looking like a cholesteatoma.
Right.
Oh, yeah. See now the maxillary artery. Medially the maxillary was clip.
Yes.
It was thrombosed here medially.
And laterally it's
Forceps. Clip there. Clip. And I am reaching the lateral limit. Then a clip. Hold with the forceps. Yes. See the vessel?
yeah.
And then this is the
Clip. Not to worry.
leave it. Oh, piche go raha. Vessel is hold it. Yes. The clip. See, half of the vessel is still. Dena yaar. So don't get don't bother about the maxillary.
Don't need to
We
panic.
should be able to manage maxillary by all means. Waiting for the clip. Yes. Can you see?
Yes, Satish, brilliant.
Yeah, beautiful.
Stop. Wash. यार एक जना खोलने के लिए रहो यहाँ खड़ा सिरिंज ले.
This is storage script, huh? Because
Yes, Carl Storch. It's a very reliable clip. Now see all the skull base. This is a part of the orbit, floor of the orbit. See all black. I will come to that later. See the skull. This is the V2.
Yeah.
See this inside the orbit. See inside the orbit. All this is rotten. Necros.
This will be the turning point of mucor surgery in India, I think, this webinar.
Pardon?
This will be the turning point. What people are doing, I think.
So this first time in India I think when we showed one.
And it needs to be so radical. First of all, the MRI and then now the surgical. It will change the outcomes.
See this sphenoid bone I am removing.
Yes.
Mucor has a predilection to involve the maxilla and the sphenoid bone. See what the steroid has done.
This is very common. I also observed that frontal sinus is hardly involved. Most of the cases.
Frontal sinus
is hardly involved in the many cases because I have never seen.
We have seen in a couple of cases, but not so commonly.
Satish sir, I just want to ask you.
Yes, sir.
First COVID wave, why this has not happened?
Yeah, this happened. We treated a lot in the first COVID wave as well.
You got a lot of mucormycosis in first.
Yeah, yeah. I demonstrated in last of our two cases in our webinar.
Webinar. One case.
Yeah.
This wave is more
I have seen that video.
severe, more causing more immunosuppression.
This time it is like
this virus is more virulent, definitely. But it was in the last wave as well. See this sphenoid. This is VDN now.
Yes,
this is V2.
Yes.
And above the V2 is what? This is the orbital apex. See this?
Yes.
This is carotid there. Anterior to the carotid is the superior orbital fissure.
Yes.
Completely rotten.
Yes.
That's why I told you the cavernous sinus. I will show you the cavernous sinus.
Though the HIV is also immunocompromised, but as per literature, number of mucor cases are very less in HIV cases.
You know the reason? Let me tell you. Let me tell you. Let me tell you. HIV is an immunosuppressive condition, but you will not find mucor that much. Hardly any mucor in HIV patient. The reason is very obvious. To curb the mucor penetration, the system which work in the body is neutrophils. You know? In HIV, it is the lymphocytes which are affected. See the optic now there?
Yeah.
My God.
See the optic now going there? Involved by the disease itself. See the blue optic now.
Wonderful. Look-wise wonderful, but poor.
See inside the orbit, this is true debridement of the orbit, I told you.
Yeah.
Everything being removed. See this all black. Bloodless debridement of the orbit. There is nothing. Give me 70.
Rarely seen surgery. I think this.
Bloodless debridement of the orbit. Everything rotten up. I told you this patient will require clearance. Now with a 70 degree. See this. See this all?
Yes.
No vital tissue inside.
Yeah.
What will your drug do? Amphotericin here.
Nothing.
It will not reach only. What can it do?
इसको पकड़ियो हाँ.
So very vital point you mentioned about the HIV. That
see this? I am lateral to the optic now. I am with a 70 degree.
Yes.
This is the real job of the micro debrider now. Debridement. See this? See, I am taking away the entire orbit. This part of the orbit is a good, this part of the orbit, the fat is good. Wherever is the good tissue, I will leave.
Yeah,
see this?
Yeah. It started bleeding also.
The 60 there. See? That's why I told you this is a massive case. See this, all rotten up. All rotten material. See this. See the optic now hanging in the middle.
Yes.
And this is all gone.
The incidence of mucor is related with the hyperacidity also, means reflux pharyngitis, reflux.
Pardon?
Is the incidence of this mucor is related with the hyperacidity? Or you can
hyperacidity?
Yeah, reflux.
Reflex?
Yes.
And nothing to do with reflex, boss. You can correlate reflex to anything. But see the globe anteriorly, can you see?
Yeah.
See the optic now? This is vascular tissue.
You have cleared all the, intraorbital structure.
So there are a lot of questions about the orbit. Now you can see what is happening to the orbit.
Your call is that if the optic nerve is there, there will not be any thysis bulbi. There no need for any prosthesis. So I think in place of doing total exentration, this will be a more physiological process. Patient will have less mental trauma.
I will not leave any necrotic area for that matter. That is my goal.
You recommend post-operative MRI with gadolinium?
Yes, in any doubts. Yes.
After how many days?
In case my patient is not responding.
Does the ESR and CRB monitoring?
Inflammatory parameters are not predictably coming down.
Even if everything is coming down, ESR and your inflammatory marker like CPR is coming down, then
CRP
also
is
you
the
want
key.
to do one CRP, you want to do one post-op MRI?
Yes. Yes, that's why you always tell these patients that after this debridement, we will follow with the CRP and other tests. If we find any doubt, we'll get the MRI again. See, this is all healthy tissue now behind.
Yes.
A lot of ophthalmic people are recommending that you should irrigate this cavity with amphotericin B.
At ophthalmologists may not be liking what I'm doing to the orbit.
So is there any role of using topical irrigation of this?
No.
Orbital topical irrigation?
Not really. Yeah, to the entire field. I say not only orbit, to the entire field.
Entire field. Okay.
You can use normal amphotericin B, normal non-lipid soluble also.
See the orbit now. Look at the orbit now.
Yes. I think
very healthy. Very healthy.
Yes.
What is there?
I think Pachori is making very valid point that it should not be a lyophilized amphotericin B. It should be a normal amphotericin B irrigation because it is very cheap.
3,300, 400 rupees.
Because that is locally acting, not at the.
Yes.
Not going to be excreted by the kidney.
Right. You're right. It's a good point.
See, my orbit is very clear now.
Yes.
See the bleeding tissue.
Because now the new cases are less, but we are seeing most of the complications now. Because
see now, this is skull base. This is planum sphenoidal. This is the optic now going in the optic canal.
Beautiful.
Here is the carotid artery. This is the optic, orbital apex. Clearance. Okay.
Yeah.
And now I am coming to the anterior part. See everywhere. Same story.
Yes. Sure.
Section.
Thanks to the Mumbai and Pune AOI to take this call for the mucormycosis. Wonderful. But it was a very highly needed point. Mucormycosis. And nobody knows it. And nobody knows and a lot about this thing. Because it's just like ABCD for most of the people.
Need of the hour.
Yes.
You see, I have received so many cases. I talked to Satish personally. that, Satish, what should I do? Then he sent me his old video. You go through it and do it regularly. I had done with his guidance more than 13 cases in last week, you see. And tomorrow I have to do 5 cases also. You see, a lot of cases are there because those cases, they cannot travel. I asked them to go to the Jaipur and get operated by Satish Jain. There are several.
No, sir, you can do yourself, sir. No need to
There are
send.
several issues, Satish, for traveling also. You see, people are obstructing them here and there. Then thanks to you that you have guided and we have done. And the MRI concept is really great because only doing CT scan and doing something less for these patients is of no use. It's basically they will go into revision.
Absolutely. I think that's what I said. This is going to be a path changer for.
Yes.
Going to do a lot of good. I was just speaking to Vijay. I was just speaking to Patidar.
Yeah.
Yes, I think a lot of cases there also. She would like to collaborate with you and you help her out. I think just today in the OPD.
Who? To whom you have talked?
Kusum.
Acha, Kusum Patidar. Okay.
Yeah. So
Right.
Yes, she has many cases.
Has a lot of.
There are in Indore, people are doing cases. ENT surgeons are being invited by plastic surgeon and oncosurgeons. And facial surgeons are doing a lot of things. But I think the way Satish has explained everything,
yeah,
I think we can lead in these cases and give them very perfect results.
See the situation of the opposite side.
Right.
Yeah. Through the septum, everything is gone.
I'll ask Kusum to reach out to you.
Yeah. Satish sir.
Yes, sir.
एक हमारे पीडियाट्रिशियन दोस्त हैं अभी जयपुर में, उनके ससुर जी को कोविड हो गया है। तो कल आपको मैं एड्रेस दूंगा, तो हमारा फंगिसोम आप वहां पहुंचा देना है बहुत से पेशेंटों के लिए।
ओके सर।
क्या पहुंचा देना?
अरे यार, मुझे पता होता कि मैडम का बर्थडे है तो मैं हर हाल में पहुंचता वहां पर, लेकिन आज क्या बताऊं, मेरे
I was waiting for you.
सुनो तो बहुत ही रियल फ्रेंड की डेथ हो गई यार कोविड से।
तभी तो मैंने आपको कहा ना, धोखा दे दिया आज।
नहीं, मतलब मैंने, अरे यार मैं तो खुद से बोला था ना सर आपसे। मतलब बीवी बोल रही थी कि मुझे विधवा करने का विचार है क्या, तो मैंने उसको बोला कि चाहे कुछ भी हो जाए मैं तो जाऊंगा, लेकिन सुबह उसकी डेथ हो गई तो इस चक्कर में मैं रुक गया सर। नहीं तो मैं 100% आता, टिकट बुक था मेरा, मालूम है आपको।
इसका बर्थडे
The skull base. Look at the skull base, sir.
Right.
On the opposite side, no?
Yes, through the septum. The sphenoidal skull base is involved.
If they are going there, they need not come. If they are not going, they can come.
See this?
ठीक है, let them come. Okay, sure.
See, the skull base is involved. Massive involvement. Oh. $60. And there. Over there, giraffe. Open up fast. See the state of the skull base.
Yeah.
साइड वो क्यों देते हो यार? मांगने पे साइड।
that necrotic tissue allowed?
All necrotic. Wash.
Yeah.
See this, how much?
Suppose, unfortunately, we get CSF leak at this point.
Yeah,
Would you
we'll
repair
seal
it,
it.
and then would you follow the same thing?
Yeah, same. We'll seal it immediately. Prepared for that. Oh, massive. Divider. See the necrotic nasal septum. So this was the job I wanted to do with 70 degree. And see the both side skull base has been addressed. Anterior skull base.
Yes. I think the best instrument again here is the debrider, because with the forceps it is impossible to take it out.
Yeah, the entire surgery being done by the debrider or cobblator.
Yes.
See the opposite frontal.
Yeah.
See that? No, zero. Still a lot of work at the pterygoid level left behind. Nasal septum and then opposite side. Opposite side is not that much extensive. Follow. Section. See how much inflammatory load we have taken out. Now this part is left behind. See this? Pterygoid. Some watch piece, small. See now this part of the disease is left behind. Below. See this? Drill. Now I am going to clear off the pterygoid. See the pterygoid bone?
Yeah.
Suction kare. See this pterygoid bone? Completely infiltrated. See this? Green osteomyelitic bone. I'm removing this pterygoid process now. See? Infiltrated pterygoid process. Can you see this? This is not the normal pterygoid process.
Yes, very clearly seen, Satish.
Hello?
Yeah, it's quite fragile also, no?
Yes. See, this is all. See the disease. See the disease
Yes, yes, yes. Very nicely seen.
inside.
Yeah.
See this?
Yeah.
Completely rotten, and we have to drill away this entire osteomyelitic bone. That is the key. If we don't remove this bone, as good as useless. See, this bone has to go. See this bone?
Oh God. Yeah, yeah.
My God.
Yeah.
I told you the deep skull base infiltration. See this?
Yeah. Oh God.
Debrider. See the state of the bone. Oh, so pathetic. See what is the debridement. See this? All bad tissue. Muscle looks good now.
Yeah.
No, later.
Just started bleeding.
No, drill. Give me chisel hammer first. See the sphenoid bone infiltrated. Can you see?
Yeah, very nicely seen.
Greenish osteomyelitic bone. Chisel, chisel. Section कर इधर. Yes. Look. Yes. Yes.
झालं रेडी नाही हे चालणार खूप आहे केव्हा जेव्हा डिनर यायचं सांग
रेड वाईन काढली
See the state of the sphenoid bone. See this? Now give me the divider. I have to radically clear this sphenoid bone. See, this is sphenoid bone. Only necrotic, full disease.
सतीश थोड़ा सा anatomy फिर से orient करोगे?
Yes, sir. See. Yes. Now. Yes. Sir, this is the nasopharynx.
Yeah.
Let me remove some bone pieces there. This is the nasopharynx here.
Yes.
This is the pterygoid part on the side of this, which I have completely removed. This is nasopharynx. This is pterygoid bone, which I have removed here.
Okay.
This is the maxillary sinus.
Yeah.
Behind is the infratemporal fossa, all healthy. Pterygoid process I have removed, which was infiltrated, and the bone muscles are all healthy. Above is this is the orbit where I have pegged with the gauge piece here.
Yeah, and infratemporal fossa lateral most area, do you see any blackish or it's all clear?
Yeah, all clear. I have reached until the clear area.
Okay.
See this infratemporal fossa.
Yeah.
Now what I have to achieve is clearance of this is the sphenoid sinus.
Yeah.
See the floor of the sphenoid, this bone. See this bone. See this bone, all osteomyelitic.
Yes.
See the healthy bone there behind.
Yes.
And see the bad bone. So I have to get rid. This is the key like JNA which infiltrate the eversion system of the bone. Here the mucor infiltrates. This mucor osteomyelitis is so bad. See, this is all osteomyelitic bone. Drill. Now I have to drill away this entire bad bone. You can see in front of you.
Yes, yes.
And then this side work will be complete. See what is bad bone.
Sir, if some black bone is there, then you have to drill out it. That's all.
Yeah, see what I'm doing.
Right.
शुगर लगा हुआ है टाइप को नाइफ से पीछे की तरफ लगा अंधा है वो पहले उल्टा चला ना उल्टा चला अरे इधर हाँ ये लेट मी होल्ड अभी भी see this अभी भी है see this bone
yes
sir. Yeah, very clearly.
This is leading behind to the cavernous sinus. The area of the foramen rotundum or foramen lacerum.
Foramen oval कहाँ आएगा?
Oval is lateral. See, this much bone is affected.
How far behind where you're drilling will be the carotid?
2 millimeters.
So there are so many drugs are there because amphotericin B we are not getting very easily. People are saying that capsofungin is also one of the molecules.
Capsofungin has no effect on mucor.
Even they are coming to us, they are claiming that it is less nephrotoxic and equally effective.
Zero. Capsofungin has zero effect on mucor. Can you see the nerve below?
Yes.
Which nerve is this? Median nerve. Can you see the glimpse of the carotid artery behind?
Yes.
See there?
Yeah. Very clearly.
Yeah.
Okay. See the kind of clearance required. See all flat bone, normal bone here.
A little superior to where you're drilling, is it still there? Yeah, there.
Yeah, there is a plate of bone coming now. Plate of bone. See the carotid is bare there now. I am right onto the carotid.
Yeah.
And that's why you must have heard every time in the skull base workshop, follow the median nerve and stay below it. See this?
Yeah.
You can see here. Very clear?
Yeah, absolutely.
See the bone is completely gone, the bad bone. And see my carotid.
Yes, absolutely clear.
See, this is the clearance of this sphenoid bone this side. Okay?
Amazing.
Without doing this, you cannot justify.
Satish. Absolutely amazing.
The beauty is this drill, sir.
Yeah, I was going to ask you that it's 80,000 RPM?
70,000 RPM. And I'm holding it like a pen. See, it is so sleek.
Yeah.
And see, my shaft is not coming in the way.
Yeah.
It has a, see
it's
this?
a tapering one, no shoulder.
No, it has a 15-degree angle.
Okay, fine.
So once I'm using here, see, my
you
shaft is...
You have a clear view.
Yes, my shaft is not coming in the way. That's the beauty.
Which drill is this? Which company?
A Medtronic.
Okay.
Stylus.
Yeah, stylus. You told us earlier.
Now see this osteomyelitic bone.
Yeah.
Had I shown this case earlier, nobody would see the simple cases. People got depressed. See this, cobblator. See the sphenoid skull base. See where I'm working, that's a use taken too. That's the nasopharyngeal roof periosteum. See that? Hmm. See the relationship. What a landmark this video now to the foramen lacerum carotid. There cannot be any better landmark than this. Debrider. This is the video now. This is foramen lacerum carotid. Some necrosed tissue in the nasopharynx, posterior wall, being debrided. See the inside of the sphenoid now. That's the clival recess. You can see that the sella. Hello?
Yeah.
This is clival recess. This is sella. This is the carotid on this side, carotid on this side, optic now above. This is the nasopharynx and this floor, and this is the optic median now. Give me drill.
This is your stylus drill.
Yes, sir. Problator. See the bone. Can you see the bone?
Yeah.
Yes, sir.
Have you ever drilled a clivus? It is usually such a vascular bone. Such a vascular bone usually. It's so much of venous channels. नीचे कर section. My God. See now, the end is coming.
Okay.
The marrow bone is ending. See that?
Yeah, very clear. Beautiful.
Normally, drilling a clivus requires amazing efforts to deal with the bleeding.
Bleeding, yeah.
And here it is avascular because it is osteomyelitis. Imagine if you leave this thing during debridement, what are you going to achieve? And when we say the mucor has a high mortality rate, it's clear now. See now the entire panoramic view on this side, what we have achieved. Now, cobbler. The septum we know is infiltrated. Posteriorly, I have removed a part of it. Anteriorly, I am yet to. दूसरा देना. The bride is all bad. 40. So left side job is done.
Yeah.
Right is not that extensive, I know, but
Tell us about the post-operative protocol also in such cases.
Same.
Okay.
Whole possible dose of amphotericin. I will give double antifungal, amphotericin and posaconazole both.
And how frequently you will do the post-operative endoscopic?
Every other day.
For how long?
Initial 7 to 10 days. Then everything if is healing good, then you can reduce the frequency.
Is there any role for ion chelation therapy since mucor thrives on iron?
Yes. Yeah. See, dafipirox and dafipiron are the ion chelators. People are trying. But role for the clinical use is still, not defined anywhere.
Is it available in India? Any centers are giving it?
Yeah.
Trials are on to see its efficacy. Yeah.
Yeah, but ion chelators are being used for other indications. Otherwise.
In COVID, the trials are on. In post-COVID patients.
Post-COVID, I have no idea if somebody is doing. Nowhere is recommendations. See why the iron level increases, inviting the mucor. Hello?
Yeah, yes, we are with you.
Hyperglycemia, ketoacidotic conditions prevent the binding of free iron to the transferrin.
Okay.
It is always the culprit is diabetes, uncontrolled diabetes. You don't need to do anything else if the diabetes is under control and steroids are under check. debrider. This is a massive, disease. You have seen the endoscopic orbital clearance, skull base clearance, debridement.
Yeah. Satish, after this extensive case, I think you should take a break, have a bite.
I am fine.
What would be the next case now?
Next case is induced? Induced? Yes.
So Satish bhai, you mean to say that it is because of steroid and diabetes only? It is nothing to do with the second wave of COVID.
Yeah, no, that is contributory.
Yeah, because people are saying that even in the first wave, we have not seen that much cases of COVID.
Yeah, we had mucormycosis in the first wave as well.
But not like
more
this.
Now, because this wave was strong. Fear factor is more intensively managed, more hospitalizations, more steroids, more tocilizumab, deadly. All these.
Okay.
Can we see one case of palate involvement?
Yes. Probably it is the next one. I don't see. Yes. Otherwise, the next I will show. See, now I have come to the opposite side.
Yes.
See the skull base completely?
Yes.
And now coming to this side, debrider. First, I will do a regular face to see what is happening.
Do you advise these patients regular nasal douche or nasal douche with the Forcon or some antifungal solution?
You can advise the amphotericin.
Amphotericin, okay. Simple one, not lyophilized.
No lyophilized. No liposomal because we are using topical. Liposomal is being used when you are using systemic. Because the excretion is through the kidney.
Right.
So how frequently should this lyophilized amphotericin douches be advised?
Daily. Post-op.
Yeah.
Daily.
Once a day.
Like you do advise douching for the sinus surgery.
Okay. So in Mumbai, we are having acute shortage of liposomal amphotericin B, and
Everywhere.
it's sold in black market rates.
It is everywhere. Everywhere. That's what Dubey sir was asking.
Today I supposed to visit Jaipur to participate in this workshop as well as to get some liposomal amphotericin B from Satish bhai because he has got ample of stock with him and he promised me. But
No ample of stock. I cannot stock.
I will not. Unfortunately, I was not able to go there because my classmate has died because of COVID.
दुबे जी आपको एयरपोर्ट पे रोक देते थे फिर
नहीं नहीं, सतीश भाई के से मिलने के लिए बहुत बेताब था और मैं 100% पहुंचता वहां पर।
नहीं, एम्फोटेरिसिन के स्टॉक के साथ एयरपोर्ट पे रोक देते थे।
नहीं नहीं, ऐसा कुछ नहीं, वो तो अपने एयरपोर्ट में सब निकल जाता है मेरा।
डिवाइडर
और जयपुर से सतीश भाई निकलवा देते।
बॉम्बे होके जाना नेक्स्ट टाइम, थोड़ा इधर भी देके जाना।
For those who are watching,
yes sir.
For those who are watching, Dubey sir is a multifaceted personality. Besides the amazing ENT surgeon, he is a Bollywood actor.
No, recently the movie which I am acted, producer is from Jaipur. When I told him that I am an ENT surgeon, so he was telling me whether you know Satish Jain or not. तो हमने कहा यार सतीश जैन तो हमारे यारों के यार हैं।
Oh my God!
तो बस वो चालू हो गया एकदम से। Recently I acted in a movie. The financier and producer was from Jaipur, and he is very close friend of yours. The movie name was Shukra Dosh.
Oh.
But after that movie, COVID was there.
Call later. Sir is a news anchor at the Doordarshan for so many years.
I have conducted an interview of Dr. Kirtane long back, I think 20 years before.
Yes, I remember, and I was in panic because you said Hindi mein karna padega.
But fortunately, after 10 years, I think I have conducted one interview of Mrs. Kirtane.
Yeah.
Our Guru Ma.
But you know,
this side is much better.
Satish said, multifaceted personality that you are.
All your blessings, sir. We are, including Satish, we always talk about you and the way you are sitting at this age. You are always, inspiring factor for all of us. Whenever we are there. And
every time I watch Satish, I learn something new.
And we take
don't say this.
We always remember our teacher.
We have been learning our lifetime from your work, sir.
Yes. And we have learned so many life from Dr. Kirtane. Apart from surgical skills, initially we used to watch his video, then do surgery.
See, this side is good.
Yes.
We saw an MRI also, there was hardly any, only the septum and part of the sphenoid bone was involved, which we have debrided.
Sir, whether any post-op issue of any atrophic rhinitis in these patients, they are...
Not really. Some crusting, yes. Some crusting is imminent initially. Atrophic rhinitis is a different entity. That's a immune complex disease. Vasculitis of the vessel supplying the nasal wall. That is a different entity. Yes, excessive crusting you can say, time being, but it mucosalizes so well.
Like in this, we have removed, most of the part of the septum. Then there will not be any problem.
Nothing, sir.
Okay.
So in step-down therapy, when patients are put on posaconazole, what is the dose and how long it is advocated?
Dose is 800 milligram a day for adults. 200 milligram, 400 milligram BD we give. 400 milligram means 40 milligram per ml means 10 ml BD.
Okay. Is it as nephrotoxic as
No, it is not nephrotoxic. But yes, you have to keep an eye on the kidney function, liver function. It is not nephrotoxic. Issue is the bioavailability. So give it a high fat diet.
Sir, it is not available in form of capsule or tablet?
Yeah, it is available in form of tablet, extended release tablet.
Okay.
To me now it is done. See everywhere.
Yes.
Remember the initial picture when we started?
Yeah, massive.
All rotten, everything.
So, is there any significance of clinical symptoms improvement in the recovery process?
Pardon?
Is there, if the pain decreases post-op,
Yeah.
how significant indicator it is to kind of, your surgery clearance or recovery process?
Pain
is the pain, the facial pain, headache, which is
it resolves. It resolves. Yeah, the moment you do a complete clearance, it resolves immediately.
And what about
decreasing
ptosis?
intensity?
What about
ptosis?
Ptosis?
Yes.
That is not going to recover. There's all orbital apex is cleared. There is no nerve supply from behind for anything.
Then what about ptosis?
Ptosis, ophthalmoplegia.
It will be there.
That cannot reverse.
Because see, most of the patient, they are coming with ptosis. They expect that, after treatment, everything will be all right. But ptosis will not recover.
Ptosis cannot. No eyes symptom will revert. The vision will never come back. Once gone, ptosis, ophthalmoplegia, nothing will come back.
And ptosis is very common ptosis. Most of the cases.
Then most of the patient come along with ptosis only.
Yes. More than 50% have ptosis.
They are coming with ptosis only. Even if they don't have any intracranial fungal, they have invariably cavernous sinus thrombosis or something there. We will not find anything intraorbital, but there is something behind. That is why they are having this problem.
So you cannot do anything to the cavernous sinus thrombosis. You have to tell your patient, you can warn them with a poor prognosis, with a more intense post intraoperative clearance, more intense post-operative dual antifungal therapy. That's what you can do. The cavernous sinus is a significant, prognostic factor. Now, this patient, next one, I told you, was operated a couple of days back. Somewhere, some clearance was done, and the next day, patient developed blindness.
What could be the reason for developing blindness?
See the residual.
Okay.
See the orbit on this side. So, I told you, once it comes to debridement, it should be adequate debridement. See this eye. Can you see? Hello?
Yes, sir. Yes, sir. We are seeing.
See this disease here.
The pointer which you have kept there, it is the area which is cleared.
Yes, by the previous surgeon.
By the previous surgeon, the area which is besides the glistening orbit, is the black area which was left there.
Yeah, this is all cleared.
Yes.
But this is left behind.
Left behind.
A lot of ethmoidal disease left behind. Disease in the pterygoids left behind.
Right. So the disease which are left behind, it will not collapse by itself only. We have to debride it.
Yes, obviously.
Like most of the bulk, when we clear, sometimes the secretions are there in the sinus, they can drain out there.
If it is necrotic area, no drug will reach.
Right.
Had this fungus not been giving vascular necrosis, why would this surgery required? Like in chronic invasive fungus, aspergillosis.
Right.
You don't need to debride each and every part. You just establish a diagnosis and give voriconazole. That's it.
Sir, most of the chest physician, what they are doing, if there are some fungal diseases there, if they are not aware of that, it should be sent to the otolaryngologist. What I have seen in my city, they are prescribing voriconazole left and right, because there is a preferred drug of choice by chest physicians is voriconazole.
Believe me, for a mucor patient, if you are prescribing voriconazole, is as good as criminal. You are making the mucor more virulent by means of giving voriconazole. This isn't proven. So mucor is a different disease. That's what we have been discussing for last 5 hours. More than that, it requires a proper diagnostic protocol, surgical protocol, post-operative protocol, follow-up protocol. This is a real deadly disease. It needs a proper dedicated treatment. So now this patient is ready in 5 minutes. And the situation is very, very clear. This patient has a disease in the orbit. You can see in the ethmoids and some part here, probably in the paramaxillary region. Let's see what it is. See, this was left behind and it developed blindness. So unfortunate. Compare with opposite orbit. See this. Hello? Compare with opposite orbit.
Yes.
This is massive.
Massive. Sir, so we will ask our radiologist to give, gadolinium contrast MRI.
Yes. Gadolinium contrast and T2 weighted fat suppressed.
Fat suppressed images.
Yes.
और वो सर हमें CD में देगा वो.
Printouts have no value. Printouts have no value.
No value. तो उनको बोलेंगे CD में देंगे सर. उसके लिए कोई और टर्म है क्या उनको बोलने के लिए?
Yeah, you have to give in DVD.
DVD.
Tell them.
Fat suppresses image.
Yes.
Because we have to teach a lot of things to our radiologists. You see, your radiologists are very well versed with your instructions. Because sometimes when they give pictures, it is absolutely inadequate information by the pictures. Satish sir.
To sit with your radiologist and tell them what exactly you want.
Okay.
Otherwise, whatever you advise, every radiologist will do differently.
I said these images will require some software from their side, or we have to install in our computer?
And you can install. You can buy this Radiant.
What is the name of this software?
Radiant DICOM Viewer.
Okay.
So in this case, which area the disease was left and from where it progressed towards the...
See, the medial part of the orbit was involved, and this inflammation led to, obviously, it's so easy to give blindness. This mucor is highly inflammatory disease. So it can easily involve the ciliary and retinal arteries, optic nerve, inflammation extending to optic nerve. Many ways to give blindness. So now we will remove this, and this, obviously, the ethmoids. Ready? Corona.
Is there any need for doing orbital decompression in each and every case?
Decompression is a different terminology for to relieve the compression. It is not the scenario here.
Like if we found that the disease is limited to middle turbinate and it is on the lamina papyracea and everywhere, whether we need to remove the lamina papyracea, give an incision over to the periorbita to see whether fat conditions is good or not in each and every case?
So if you see in MRI, the orbit from inside is normal, why to open up the periorbita?
Achha, no need to, right.
Yes. So wherever the disease is, you have to address.
So MRI becomes your main tool for guiding you.
Yes.
Right, sir.
Without a good MRI, there cannot be a proper assessment. Without a proper assessment, you can't think of a good outcome.
Right.
It is purely a planning, proper planning. So this case should not take long. Hopefully. Last one was massive.
So fat separation images for orbit.
Or PNS and orbit.
Okay. Because orbit is full of fat. So if it will suppress fat, then disease will be enhanced.
Yes, if you are not suppressing the fat, it will not allow you to visualize the disease properly.
Right, sir.
Because orbit is all full of fat.
Right.
So take the fat suppressed sequences.
Right, sir. It's very important.
So that you can make the disease areas prominent.
Right, sir.
Ready? Come on. 2 minutes. So 2 minutes, we are starting this case. This is the second last case for the day.
Sir, in each and every case, we have seen that whenever you have, removed the posterior wall of the maxilla, and when you went to pterygoid, there was a disease. Though the antrum posterior wall is, after doing Dankers, it seemingly appears very normal.
Seemingly normal.
It's a very dicey thing because invariably people will leave disease there.
Yes.
The other surgeon who are doing, faciomagnetic surgeon who are doing these diseases, these cases, they will definitely see the antral wall and they will come out.
That's why the mortality rate claimed is up to 80%.
Oh, and you are saying that in your hand it is less, 1%.
See, the whole game is to give a radical clearance to the necrotic areas.
So that drug will reach there. And your choice of amphotericin B, sir, which brand you prefer?
Pardon?
Which brand of amphotericin B you prefer?
Any brand, sir. Our Lifesaver is giving all good brands. So Abbott, Cipla, Sun Pharma, Sun Pharma's brand is good. Lambin.
So, sir, kindly share in your CD this lifesaver number, because if somebody is needy and if they are supplying
Yes,
all over India, we can always contact them.
Yes, yes.
In this era, because a lot of people have a lot of financial problems and they are really begging us that how to do it, because it's
He is very dedicated to supply everywhere quickly.
lifesaver.
Yeah. Hello?
Sir, is there any correlation with the fungal mucormycosis with any chest fungal infection?
Yeah, this mucormycosis can involve the lungs also. That is pulmonary mucormycosis.
Okay.
That is also deadly.
And then there is any role of amphotericin B nebulization?
Not nebulization, it's IV.
Acha, IV only.
Hmm.
So the IV which we are giving for the mucormycosis of the paranasal sinuses, it will also work in lung also.
Yes. But lung will require the same treatment. Clearance. Lobectomy. Oh. Lobectomies and so many medical clearance because it gives cavitating lesions in the lung. Deadly.
So then what is the investigation of choice in those cases? MRI with gadolinium again or something else?
Yes, same.
Same.
Yes.
So ideally, I think if we want to give them good results, if they are having mucormycosis of the nasoorbital region as well as there are oxygen saturation is falling or something is there, then we will ask for both the MRI, chest as well as PNS. Then why the people who are coming post-operatively, I mean, most of the patient coming 20 days post-COVID or 30 days post-COVID, they don't have any oxygen saturation level problem. They have only this, your sino-orbital problems.
Yes. So the most common is rhinocerebral.
Okay.
Because the route of inoculation is nasal, inhalation.
Right.
That's why the most common area involved is this. And obviously, when the COVID treatment was going on, that was the etiology to this.
Right.
Obviously, patient will present few days after that.
All right.
And they present mostly when some complication has happened.
Right.
That's why the emphasis is on early pickup. All post-COVID diabetic patients who have undergone steroid therapy, even non-diabetic patients who have undergone steroid therapy, should periodically get their checkup done by otolaryngologist. Should be warned of early symptoms, signs of mucormycosis, so they can be aware of this fact that they should consult early.
You see, there are a lot of news in the paper in Mumbai as well as in Jaipur and Bhopal. I think you people have given interview, like Cooper Hospital doctors also given some interview. There is a tendency into the medicine people that now they are prescribing one antifungal along with a steroid. Usually what they are prescribing either fluconazole or itraconazole 200 milligram BD. Whether this practice is, I mean, how it is justified?
Absolutely. I won't support this. This is not the answer to the problem.
Then what is the answer? Short-term prescription of steroid, judicious prescription of steroid.
Yes.
Regular monitoring of blood sugar.
Yes.
What else?
Unnecessarily,
regular checkup by ENT surgeons.
Yes. Avoid broad spectrum antibiotics, all these antiviral, tocilizumab, immunomodulators. All these are precipitating problems.
And if there are any black discharge from the nose or bloody discharge from the nose, consult immediately to the...
For diabetics, excessive dryness, excessive crusting, numbness in the nose, palate, cheek, swelling, pain, these are early symptoms of mucormycosis involving the nose and paranasal sinuses, which is the best time for the treatment for this disease, for cure. But the patient will come to the ENT surgeon once they are warned about these symptoms. Physicians are overloaded this time with the COVID treatment.
Absolutely right, because they are seeing 100 and 120 patients every day.
New.
So
the old patient, if they find little bit okay, don't come.
Don't come.
And now what is happening to those old patients, God only knows. So the post-COVID sequelae are not being taken care of properly, I would say. That is the reason behind all these issues.
And this time, because infectious rate is very high, so a lot of patients are wandering here and there.
मुझे समझ नहीं आया क्या बोल रहा है. कब? Sir, you were asking something?
No, sir, that is what I am asking. I mean, saying that this time spreadability is much more.
Volume
a lot of patients are advised that you take this treatment for 28 days, keep yourself in the home, and then we are coming for the first time, they are with some complication.
This home treatment is again a big problem.
Right, sir.
Because it is not being monitored at all.
Sir, I think you have not stopped any day operating during this COVID period, as Dr. Ashish Bhunkar was saying. You are seeing patients regularly.
Sir.
What you do, like one fellow MD doctor in Bhavnagar, what they do every day when they enter in their clinic, they put 2 ml of methylene blue below the tongue. And they don't use any mask, and they say that it is very preventive. What you do for yourself? Because you see,
he has stopped putting anything below the tongue. I am so happy.
The current is over, that I know.
Yeah.
But ultimately, what you are doing for this? Because you see, we are seeing a lot of our colleagues who are dying because of this. Satish sir.
Sir.
What is your safety measures? What safety measures you take in your OT and OPD?
Nothing, sir. Same mask and sanitizer and all. Nothing else. Practically nothing.
Then we have to ask you in detail off time that what diet you take and what exercise.
Nothing. Jain food.
Jain food. Okay. And what, sir, other thing you advise your patients who are coming, post-COVID patients, like some patients are coming to you with loss of smell, loss of taste, in which what you advise them that how soon it will come back?
Nobody knows, but we have seen those patients getting the sensation back after some time, variable time. And even the physicians say those present with sensory abnormalities, they carry good prognosis for the COVID.
But
I don't know the rest.
I think this theory has been reversed. Initially, it was told that it is very good prognostic sign, but nowadays they are telling that it was misleading information. Somewhere I read.
कहाँ गया?
Even then, it's 10:30. We have more than 2,500 live people who are like live audience.
Oh my God, crazy.
So yeah.
10:30 क्या वो तो 2 बजेंगे तो भी 2000 तो रहेंगे.
सतीश कितना बजे तक करने वाला है?
Last 2 cases.
अच्छा, okay. Midnight.
This is a short case. It's not going to take long.
We were just saying, Ashish, it's more than 2,500 cases, live audience, and here comes 2,501.
So I'm coming with the news that Shrikant Shinde has already spoken to the PM, and they are going to come out with the steroid audit. And tomorrow or day after, he will connect Satish with Uddhav Thackeray and some more people.
So even what they are saying in Rajasthan is the price of amphotericin and how these life-saving drugs they are managing. So that is also a very good one. They are getting for 2,000 rupees amphotericin in Rajasthan.
No, that is the life care which is doing that. But I think there should be some initiative from the association. You should write a letter to the PMO that amphotericin B should be a DPC product, because you see a lot of poor patients are there who are not getting this. And the amphotericin B is out of stock right now. So like they have put in some, you see the next epidemic is mucormycosis, I can tell you. So there should be a, campaign from all associations that it should be, price should be come down and it should be labeled as a DPC product. There should be price control over it.
Because it's not worth having a blindness or such a morbidity at young age, middle age and young age. It's not worth it. So there has to be some strong measures so that at least we get our weapon in our hand.
Correct. Regulatory bodies only can help here. We as doctors, what can we do?
Yeah, exactly. Means we are not a pharmacist or we are not distributors. So
yeah, we don't have the zone of influence only.
True.
No, but Ashish Bhunkar cannot tell that we don't have any influence.
We as doctors, so we have to approach to these guys, no? Jaisa, like you will tell your CM.
I mean, if you will write to the from the association and the people who have got influence in the government, like you make.
The way is, actually, honestly, now they are scared. Yes. They are actually scared, so they are reaching out to us कि कुछ करो. अभी मेरे को बोलता है ट्यूसडे या वेडनेसडे का अपॉइंटमेंट ले लो सतीश जैन का और सब महाराष्ट्र के कमिश्नर्स का ये करो. Then they want to conduct for all doctors, sensitizing them to steroid use. So they are scared now because ultimately it is going to add burden to the whole thing. The way it is going, he immediately called his he's from Dombivli. He says in that one hospital that he typically 10 patients are there right now, Mucor.
Okay. Then I think same thing. I am going to also meet my principal secretary because he was there before he started to show me his year. I will tell him that like you are doing in your Mumbai, we'll try to do it in Bhopal also, in Madhya Pradesh. So that message should be very clear that what physician has to do or what should not do. Because you see so many quacks. Nowadays we have a meeting and I asked my minister कि आप इन पे कंट्रोल करो. तो वो मुझसे बोले डॉक्टर साहब इनके कारण ही तो हम बचे हुए हैं वरना लोग सड़कों पे मर जाते. तो quacks have opened up short nursing homes छोटी-छोटी जगह पर.
First aid, I think at least they are providing first aid to the patients. You know, I mean, some do gross mistake, but otherwise, by and large, they play safe, no?
But government is happy for them because people are attended by somebody. They are not on the roads. So that is why they are happy that in my constituency, in which whole slum areas are there, if those Jhola Sahib doctors are not there, they will be on roads. So doctors, we are thankful to them.
Yeah, correct.
That is what.
Endoscopic picture.
It's a social problem, no?
It's a social problem.
Endoscopic picture. Hello?
Yes, sir.
Yeah, Satish.
Yes, sir. Let me know when you get the picture.
We are seeing the MRI picture right now.
MRI picture is there.
यार उसको मेरे को बोल के आना पड़ेगा क्या?
We got it. We got it.
Got it?
Yes, sir.
Now see.
अभी ये betadine का gauze भी मेरे
I'm just waiting for Amol Deshpande and Arvind Patil. They were supposed to join.
They are watching on a large screen like an IPL match. Amol
yes, I know. I know that.
Really?
The Dhoni is batting, but I think they should come down.
I don't know. They are probably in Arvind's home On a
Yeah,
big 20 or 100-inch screen, they are watching the surgery.
But I'm sure they can. They must be having mic.
See, Ashish.
Yeah.
This was operated 3 days back.
Acha.
My God, then a lot of disease is there.
And see, this is the orbit. You saw the disease in the orbit?
Orbit, yeah.
See this?
Yeah.
All rotten?
Yes.
See that?
The fat looks very rotten.
That's why he developed blindness. Now, for this, the Denker was not done, number one. The mistake number one,
Access and approach, yeah.
yes. See all this tissue, all.
Let's be honest. I think until you make it a point, it was not. It used to think कि थोड़ा रह जाएगा तो amphotericin कर लेगा उसको.
Yeah, that cannot work.
Yeah, that cannot. So this is like cholesterol. You cannot leave even a millimeter of it. I mean, worse than cholesterol actually.
Cholesterol is different. You can exteriorize and enjoy.
No. What I mean is, you cannot leave behind the cholesterol.
Satish sir.
Yes, sir.
Thanks to your teaching, day before yesterday, there was a VIP admitted in Bhopal AIMS where you were there in NES conference. And people have prescribed him 30 days of amphotericin B without any surgical intervention.
Oh God.
But they came to me. Then I told them, like you taught me, MRI करो, उसमें देखना है, medicine treatment है इसका, लेकिन we have to debride it completely. Then only it will help it out. Then they are coming tomorrow.
Oh, very nice.
Oh, great.
A lot of difference is being made because of your teaching, and a lot of people will be benefited. Their life will be saved.
Most definitely, yeah.
Thanks to you.
Arey, sir, you are great.
अरे आपके चेले हैं सर.
Arey, sir. See now.
Yeah.
This, I would say, is a half-hearted job.
Yes.
Debrider. अजय वो तैयार करा दे next. See, this is all disease. First of all, we need to have a good access to assess thoroughly. Drill. पानी लगा थोड़ा retract पानी बड़ा retract में Fiction. See inside the sinus.
Yeah.
The worst is it's not the leaving behind the disease. The important thing is you're not left any way to identify it.
Correct. Surveillance is not possible.
That's why Danker is important. It gives you amazing access, amazing opportunity for surveillance. See this all rotten.
Yes.
Because everything is, is in bad shape. See the nasolacrimal duct. See the NLD involved by fungus.
Yes.
See?
Oh, yeah, it's black.
Black. Black. रिट्रैक्ट कर इसको रिट्रैक्ट कर हाँ इसको रिट्रैक्ट करो हाँ वो कर रिट्रैक्ट भाई तो मैं बुलाई देना उसको See this. I told you this disease here, paramaxillary region. Can you see? Hello?
Yes, we can see.
This entire area we could pick up on MRI. This paramaxillary region. You remember MRI?
Yes, of course.
I will show you the MRI again after this. See all this. See this necrotic tissue. This is in the soft tissues.
Yes.
40.
40.
Give me 40. The orbit is completely involved. See the orbital wall.
Yeah.
That's why you develop blindness. No. नहीं Now it is good.
ठीक है मैं जाके बुला लेना ना 1 घंटा लगेगा बोलोगे तो खाना भी ले आऊंगी यहाँ क्यों खाना चाहते हो यहाँ क्यों खाओ
ठीक है
कितना टाइम लगेगा
Now give me the chisel. See, there is disease in the floor of the maxilla. for which I want to chisel out this bone.
Can see the disease now. Yeah.
Orbit is the key in this patient. Forty. Divided 40. पॉज कर कुछ पॉज कर दिया कर कुछ रुक जा. This is all
Necrotic.
bad mucosa.
What is that? Inferiorly? What?
Pardon?
What was that? Inferiorly, the bone will.
हटो. रुक जा यार. Now the floor area laterally inside the maxilla all are good. See now everything is visible. See the nasal septum. Gone. See this?
Yeah.
Yeah, not looking healthy.
All necrotic. And see your, this is the skull base. Skull base. The sphenoid.
Yeah. Yeah, that is a sphenoid.
It's bad. Debrider. See what I've been telling since evening about the retromaxillary area. It looks okay, but you'll see where the disease is. Behind the maxilla. Now the most commonly affected area which is easily overlooked. See this maxilla?
Yeah.
And behind that, see that?
Yes. In every case, it was present.
Yeah.
It's a Satish Jain master stroke. Everywhere it is there.
Imaging. All that previous, he taught us that.
Orbit is bad. No. Look. Leave it. Give me for later.
The earliest which day of the COVID illness you encountered mucor?
10th day.
10th day?
10th day. 10th day earliest I have seen.
Then you still go ahead and operate, no? No problem.
Yeah. Once you have identified mucor, you cannot ignore.
If you are going to somebody else's center, you are going to operate in your center only.
Satish is operating.
Or
you are operating in your center or going to operate somewhere else?
Our center only.
Your center is a COVID center or non-COVID center?
Non-COVID.
Then what precaution you take, whether you change your all circuits
Yes,
which are
sir.
there in your anesthesia machine for each and
Yes.
every case, because they
Or that particular, after that particular case,
yeah,
you close the OT for 3 days, particular OT.
and they say that you should use some viral filter at the entry and exit of which is connected to your anesthesia machine. Whether you do that?
Sir, if you close everything for 72 hours, everything
it will
dies.
clear.
Now with the 70 degree, look at the orbit.
Right.
We have cleared the maxillary area, paramaxillary area I've already cleared earlier. Septum is yet to be cleared. This I will clear later. And now see the key area orbit. See that?
Yeah.
Orbital clearance, day by divider. See this?
Yes, Satish.
All dead tissue. See the mucor.
100.
Wow.
So Satish, what precaution you take for these COVID positive patients?
Same level 2 PPE.
Level 2 PPE.
From top to bottom.
And your assistant, your anesthetist?
Everybody.
Everybody. And after operating, where you keep these patients?
In a separate unit.
Okay.
See this. I told you the medial part of the orbit is bad. You saw an MRI. The medial part of the orbit is affected.
Necrotic material is there.
Rest of the orbit is good. And see the medial part. See the globe anteriorly.
Yeah.
See the normal tissue, healthy fat.
Yeah.
See this all dead material. Dead material, see? What a deadly disease it is. Later. See now my posterior part of the orbit. See, rest of the orbit is healthy. So exentration is terminology which is actually not used for mucor clearance.
Yeah.
Exentation is a very, I would say, extreme terminology, earlier defined for the malignant conditions. Here the philosophy is different in mucor as compared to the malignancy. See that? All healthy tissue. See the orbit, all healthy now.
Yeah.
Little bit left, I am removing. Different. See, this is healthy. Posterior artery. 20th model artery, this is. Now it is ultra clear on this orbit. See, this is maxillary sinus. Orbit with 70 degree. All parts of the orbit pretty healthy. This is the anterior unhealthy mucosa. Now lastly, layer behind is the nasal septum area. So if you are doing debridement, must have a proper assessment what all to be debrided. Keeping a 3D picture in mind, now 0 degree. Wash. मोटा दे Hello.
Yeah, Satish.
Yeah, how the picture is good, Ashish?
Yeah. Good. Very good.
So with 0 degree now, look at the skull base.
Yeah.
Orbit, inside of the orbit you can see.
Yeah.
All dead areas have been removed. This was paramaxillary area I showed you earlier.
Beyond the lateral wall, yeah.
रुक मेरे रुक भी जाएगा. This was the paramaxillary area affected. And now finally, this little bit of the nasal septum and this sphenoid wall. See this septum and this. That's it.
Yeah.
Uday. So I will remove this part of the septum. See this dismantled? Everything dismantled. Divider. See this sphenoid wall.
Yeah.
All bad tissue. See now? Healthy?
Yeah.
Now lastly, the retromaxillary area. Chisel. See now the retromaxillary area. These are hidden areas. The brighter देखो. Now chisel.
This posterior wall looks.
Yeah, I will open. I will open.
Yeah, but it looks deceptively healthy. And if you have a MRI to guide you,
Yes.
you will not suspect. Yeah.
Yes.
It's nice and hard, not fragile.
Welcome.
Is it a special osteotome or it's just a
regular one?
Only the surgeon is special.
Section करो. See this. See this.
Yeah.
This is bad disease. Oh my God. Completely rotten. See this? Pus.
Special affinity for that region. No?
Section करो. Yeah. See this. All rotten.
Yeah.
See both the nerves even.
Yes, we can see the V2 and median. Yeah.
The brighter. What do उसको क्यों करे? This is the maxillary artery now. Section. नहीं हटा. Flip. ला. देखो. दूसरा दे. Flip. वो देख कैरिसन.
Yeah.
कैरिसन थोड़ा दबा के रख लेना उसको. हटा हटा. ला क्लिप. एक और है. ऑबलेटर दे. इसको बुला दे. बुला दे. एक बार के बाद दोबारा नहीं कहता. See this?
Yeah.
Opening of the pterygopalatine fossa.
Beautiful.
See, this is the vessel. इसमें है कुछ. उसी दे forceps.
That's what I'm thinking now. We have to buy that clip also. Stoves ka clip also.
Section. See, I opened up the vessel. इसको पकड़. Opened up the pterygopalatine fossa to catch the vessel. उधर रख.
Right.
छोड़ना. छोड़. अरे क्लिप.
कितना जगह लगाया तू?
क्लिप. Yes. Clip. Article.
नीचे है. हाँ. Okay, perfect.
Now.
No, yeah.
Great.
अंदर बुला नहीं पाता क्या? See, this disease which was going here need to debride further. जो रख. जो ऊपर हाँ ला debrider. See this still necrotic area. Hello.
Yeah. We can see. Part of the infraorbital area, no? कल से all MRI centers busy in the country.
Huh?
कल से all MRI centers will get busy. CT चल रहा था, अभी MRI से शुरू हो जाएगा.
MRI. See how much the necrotic area was. Hidden areas. See, to orient yourself, you all, this is maxillary sinus. This is your sphenoid sinus.
Yeah.
Can you see?
Yeah.
That's the sphenoid sinus. That is the pterygoid region. Yeah. Still left behind. This is. See this necrotic region. Now it is healthy.
The timing of the MRI should be also ideally a day before the surgery, no?
Pardon?
The timing of the MRI about a day or two before the surgery, not earlier.
As close to the surgery as possible.
Yeah.
Like you are operating tomorrow, plan it today for the MRI.
Yeah. Once the fitness for anesthesia and all is done.
Yeah, simultaneously. See now this pterygoid region.
Yes, you can see.
This is the key. Above is the orbital apex.
Viren, are you planning to do mucor surgery?
Googly. See, the problem with me or even with you is the anesthesia setup. In the sense, all these patients are with solid comorbidities. So it's okay, we can operate, but then there has to be. Previously, there was still there is a ICU in front of me, and we used to transfer the patient there. But then that has turned out entirely converted into a COVID hospital. So
for us, it is best for us to go to the institute and do, if at all we want.
Yeah, that's true.
These are elderly patients.
Yeah.
Have a lot of comorbidities.
Even post-op.
Renal issues. This is the last part now. See the orbit, otherwise.
Yeah.
Yes.
Now this is done. See now it is all healthy areas all around. This is anterior ethmoidal artery. See that? Ashish, anterior ethmoidal artery. Taken away.
Taken away. Okay. By the mucor before you.
So now, Pani, this is the final section. This is the final picture. This important area, pterygoid region. See, this is absolutely flushed.
Yeah.
Orbital walls, the skull base, the septum, everywhere fresh bleeding areas. So the mistake number one in this case was not doing a Dankers. Number two was not having an MRI before.
Yeah.
Third was orbital disease was not addressed, which led to blindness.
What is the role of an oculoplastic surgeon in this? What do they do? What do they do differently or what?
Nothing.
Maybe like for a skull-based neurosurgeon, medico-legally, he has to be in the OT, something like that. If you are treating the orbit, the oculoplastic surgeon has to be there. Maybe medico-legally.
But even if he or she is there, I don't know what can they do. So they will not be doing through the endoscope.
This is not a reconstructive surgery.
Yeah.
See the opposite frontal.
Yeah, yeah. I can see it.
This is not a reconstructive surgery. Now it is done. Chalo, wash karo. The last case is ready. And the last case, the difference from others is the involvement of the skin. Change kar do. ये करो यार समझ मैं इधर आया हूँ तो समझते नहीं हो क्या Hello.
Yeah, Satish, yeah.
Yeah. So we'll be doing 7 cases tomorrow. So this patient, see this. Yes.
साथ बोले तो दुबे, अरविंद, अमोल, everybody will come to Jaipur.
आ जाओ कर दो सब. See this. This patient has a blindness in the right eye. Has this disease, non-enhancing lesion. See this. Turbinate. Maxilla.
Right.
This retromaxillary tissue. See this? And
Yes.
from there, it has gone to the orbital apex. This is orbital apex, completely infiltrated. See this? What you have seen in the previous cases, it is much more than that. The entire pterygoid, greater wing of the sphenoid is involved. This is greater wing of the sphenoid.
Right.
And this will require drilling. A lot of drilling.
Okay.
Interesting.
Difficult.
Not really. This is the pterygoid region. This is the greater wing of the sphenoid. And this part is affected and the orbital apex is gone. That's why this patient lost the vision. Orbital apex is completely gone. See the enhancement in the orbital apex as compared to the opposite side.
Opposite side. Yeah.
See this enhancement. That is showing inflammation. And see these muscles are never need to be removed. Let me tell you, it can give necrosis in the bone, nerves, lymphatic tissue, skin, whatever, but not the muscle. This is typical for mucor not to give necrosis in the muscle. Muscles are always spared.
Okay.
In no case you will find necrosis of muscles. And muscles, see this intensely hyper intense muscles you will find like inflamed. but they do well with the amphotericin.
Okay.
Now, about the outside skin, this can see outside. So probably we'll do something to it. We may have to resect a part of it and rotate a flap later on in the end. But this disease is massive. This is classical for anybody finding mucor here in the retromaxillary region, going to the orbital apex. This is the ideal example. This is the ideal example. See this huge infiltration of the orbital apex. And this is classical. Interesting case. Ready?
Ready.
Satish, just a technical question.
Yes.
Any mucor you have done without doing Denker? I know it's a foolish question after seeing so many cases with all Denkers you have done. So just I'm asking, maybe a Denker without doing a Denker, maybe have you done any cases, any indications or so?
Very early lesions where the bones are spared, maxilla. In early lesions means lesions involving turbinate and surface mucosa of the nose.
Only.
Those fortunate patients picked up early in the course, they present early, are the ones which are candidate for that.
Okay.
Once the maxillary and retromaxillary tissue is not involved.
Some issue with the voice. Dinesh, just see some issue with the voice, overlapping.
No, we are able to hear very well.
So that's why the early diagnosis is the key.
Okay.
Because the earliest lesions appear in the turbinate, lateral wall, nasal septum, where the fungus invades earliest.
Right. Only those cases.
Yeah.
Okay.
And only physician can direct to ENTs post-COVID treatment. At least they leave a single word to the patient. Now your COVID part is over and go to ENT to prevent future problems. That's it.
Last.
Ready? So starting in a minute.
Sure.
Are you cutting the cake?
Incidentally,
double.
Satish,
This patient has a double vessel coronary disease.
Oh.
Hello?
Yeah. That is the skin involvement, yeah.
Ajay, volume आ रहा है? Hello?
पूरा आ रहा है.
That is the skin involvement. We can see, Satish. Yeah.
Yes.
Big involvement.
See, this is almost a 3 by 4 centimeter skin involvement. And this will rotate this local nasolabial part. See, all these patients were diagnosed on clinical grounds. Clinical and radiological grounds. See the turbinate?
Yeah.
None of the patient was, biopsied before. So mucor, you should have a low threshold in diagnosis if you have a good clinical background of the patient.
No need to do microbiology tests.
No. You can take a swab for the KOH mount if you want. If you really want to prove before surgery, take a swab from here for the KOH mount. See what a tool this cobblator is. So this is pyriform aperture. This is our Virendra Gaisa's line. If you cross it anteriorly, he has to come.
Virendra Lekha. Lakshman Rekha जैसी.
भाई मेरा क्यों मजाक उड़ा रहे हो?
मजाक नहीं, आदर से बोल रहे हैं.
यार राइनोप्लास्टी गुरु.
इतना डीप रात तक देखने में ऐसा थोड़ा अभी बंटी को भी हो जाएगा शायद.
Must have board of dankers. Cool. This picture good?
Very superb.
See, this is disease.
In the substance of the inferior turbinate.
Even inferior turbinate.
अंदर है, ऊपर से चला.
Bill दे दो. No, sure. Second. Section. जो कुछ forces भी.
Hello.
This drill is addictive.
And your this stylus is also eating bone like a butter.
Yes. And it is a coarse diamond one. It is not cutting.
It is not cutting it. I can see.
Section karna.
It is from Zomed, na?
Yes, Metronic, Zomed. Straight. Okay.
But if you don't have stylus, you can use goose and 4 mm kerosene punches, but the few edges are little ragged.
Kerosene punches?
No, kerosene plus, I mean, you can buy some chisels from your orthopedics colleague and hammer.
Yes.
In COVID era, people are saying that don't use debrider or aerosol generating instruments. Use better chisel and hammer.
I don't know who studies all this.
If you don't have immunity like Satish Jain, people are telling me directly, why are you using this? Use that, because Satish Jain is, superhuman.
No.
Don't have any long-standing disease. Playing cricket in Amritsar during COVID era, along with his 5 friends, but you can't do this. Don't endanger your life. Otherwise, he will come in your Termi. Why you are going there in Jaipur in this time? Your deep friends advise me this, and put shackles in my legs. Don't go there. सतीश अलग मिट्टी का बना हुआ है, उन्होंने मुझे ये बोला, मैं वही पूछ रहा हूँ आपसे, क्या है यार आपका सक्सेस क्या है?
See this in the maxilla.
Yeah, this is a lot of this is there.
See this all in the soft tissues.
So the difference is सतीश अपने वाइफ के बर्थडे को भी ऑपरेट कर रहा है और आप इतना सुन रहे हैं उनका. That's a difference.
तो इसलिए वो अमर है.
This is pre-maxillary tissue.
Yeah.
Oh. I am working in the subcutaneous area.
Right, it is just below the, skin.
Yes. And see all this.
I think after a few days it will come out from the skin.
Yes.
Like you did in last video.
Yeah.
In which you did maxillectomy and all.
Yes. December. See now?
Yeah.
दिखा भाई.
Virendra. Dr. Gaisas. Hello. Virendra is not there.
आएगा इतना जल्दी नहीं सोएगा वो है.
अब इधर गया होगा शायद.
देखो. See so much of necrotic areas.
Lot of necrotic area, yes. If you do the accentration of eyeball, and if the skin over the maxilla is very thick, and you have to remove all both eyelids, like I sent you the case, picture of the case, you advise me to remove all the lids, upper and lower eyelids.
Not really. Those eyelids, what I saw in the picture was swollen. Swollen eyelid is reactionary.
Okay.
That is not infiltrated by necrotic tissue.
Okay.
That is because of the underlying inflammation, periorbital inflammation. See this?
Yes.
Soft tissue, premaxillary, somebody was asking what to do if the disease is anterior to the maxillary sinus. See that? You can remove very well.
With the debrider.
Yeah, endoscopically, later. See this entire region. All vascular now?
Yes.
what happens to the raw bone? Where does it epithelize or?
Yeah. It mucosalize. Get fibrous sometimes, depending upon how it is healing. Okay.
Actually, in dankers, usually you remove the medial wall of the maxilla. If you do the accentration of the eyeball and close the wound, if the secondary they want to put some artificial eye or something, then medial rim of orbit is not there. Is there any problem in reconstruction?
No. They create socket. No worries.
They create socket.
Hmm. So this was the soft tissue debridement. Debrider. This is maxillary sinus. See the interior? So I think today is covered all common extensions of the disease.
Absolutely.
Though it has varied extensions. But these are the common extensions which we covered today.
True. Everything. I think we covered everything.
See, this mucosa has become bad.
How to decide by seeing the consistency of the bone, whether it's a necrotic bone or it's a normal bone?
Yeah.
If there is any something below the mucosa, which is
See,
just like
it depends upon the surroundings. Like this bone or the maxilla here behind,
yes.
laterally, posteriorly, it is well supported by the muscles. So, if it is not completely, broken or, brittle, like this bone is reasonably good. See this?
Okay.
With the vascular muscles all around, you don't need to do anything. See this? See the bone?
Yes.
Muscles all around, you don't need to do anything. Like that.
Right.
Can I call that away? Suction लगा? हटा इसको, हटा. नहीं है, इसमें सेक्शन नहीं है. Now we'll move on to the maxilla and retromaxillary tissue. This is see the terminates. See, this is full of disease.
Absolutely.
This is the inferior turbinate. This part of the middle turbinate, see, all involved. See this maxilla?
Yeah.
And this retromaxillary tissue, key over there, Karison, is the key. If somebody leaves this surgery here, he has left the disease behind. You can imagine how much. You see this? See this?
Yeah.
Debrider straight. All bad.
Bone is also looking very diseased.
Very. See, extensive infiltration of the turbinate. I've taken the turbinate out. अजय कहाँ है? See, all disease. All sinuses. This is the first I'm doing. Fast endoscopic sinus surgery.
The whole area is embolized, Satish.
Fast endoscopic sinus surgery.
That terminology is there only in Jaipur. That also in your center.
Sit there, पहले मोड़ा मत करो.
The orbital part which you showed with 70-degree was something which most of us had not seen, and how deep you went into the orbit for the clearance was simply amazing.
That's right, Ajay.
You make it look so simple. I think you should put a disclaimer also before starting the surgery.
A lot of people are doing.
Do not try these stunts in your roti.
In your roti. Especially rhinoplasty surgeons. You are too superficial. You remain anterior. No, very true. It looks so simple, but it's not.
This sphenoid bone, the pterygoid bone, greater being sphenoid is invaded. We have seen. debrider. This is sphenoid. This is pterygoid region. Imagine. Now you can anticipate the disease there behind.
Yes.
Right.
Give me 70 degree. 60. Brother. $120. That's the frontal sinus. That's the frontal sinus.
Sir, how often you see diseased frontal sinus?
Yes, not common, but we have seen in some cases, not common. We have seen 2 cases with complete osteomyelitis of the entire frontal bone. So we had to do the craniotomy and remove the entire frontal bone. Frontal bone means entire floor of the anterior cranial fossa and the anterior wall completely. So
as a routine, you always inspect frontal sinus in each and every case.
yeah, this is required for the future drainage also, because these patients have secondary sinusitis also because of blockage.
Okay.
So why to give another environment for sinusitis?
Right.
Now coming to the key area, 0. Pterygoids, Cheney. See, looks much better.
Yeah.
Logged. So now this will take us to the orbital apex. Okay, चलो आ जाओ. See the box.
This is the pterygoid region, right?
Yes, and orbital apex.
So it is the lateral part of the posterior wall of the maxilla, which you are removing.
Yeah.
Which will lead you there.
See this?
Yes, fungus is there.
In the closed box. How can you predict?
MRI.
Yes.
Wait, now अभी मुझे भी अभी याद आ गया.
Not slept yet.
No. Fat suppress image.
What a great sir.
सतीश भाई ने याद दिला दिया सब. ये बिल्कुल आशीष भाई का व्यवसायिक दिमाग बिल्कुल सही कह रहा है. आज के बाद सब एमआरआई सीटी सब भूल जाएंगे.
No. See this all macros material.
Oh my God.
See, had I not opened this bony box, I would have easily left behind.
And even if how much amphotericin you gave or posaconazole, it will not going to.
Nothing.
Nothing.
It will not reach, sir. देखा.
So at least people should have this concept, because you see, I told you the incidence where patient is prescribed.
Yes, sir, all completely necrose material.
Necrose material, yes. My God.
Maxillary artery will find somewhere.
Must be thrombosed.
It will find you, don't worry.
See this? अरे वो देख करीसन.
मैग्नेटिक आर्टरी कैरी होगी. सतीश भाई क्लिप लेके आ रहे हैं अभी, स्टोरेज वाला जो बहुत महंगा है. 30,000 सामान है.
He believes in stores only. We have Kalal one. Even Kalal is doing good.
Sir, the stores clip is so well designed, so easy to use.
एप्लीकेटर दिखाना बाद में.
एप्लीकेटर भी इंडियन भी आता ना, वो जो
Kalal
थोरेसिक सर्जन यूज करते हैं.
I have some other brand, I forget the name. More bone.
Done? Hello?
Yes.
Yeah.
देखा यार. क्या करता है करते हुए को. See, this is lateral pterygoid muscle. This is pterygoid process.
Yes.
Okay. Right.
Lateral pterygoid. Somebody was asking where is V3. See this lateral pterygoid plate ending behind there. See the plate. Where it ends behind, just above that is the V3.
Okay. This bleeding is from the muscle?
Yeah, this is venous plexus. This is pterygoid venous plexus.
Okay.
खुल गया. बैकपैक दे दे 1 मिनट के लिए. रुको. Leave it. Leave it. Section there. No, give me. See, all this is full of disease. Later. Chisel there. Section लगा दे. Yes. Yes. Thank you. The thick bone निकालना. बीच में मार. पानी. Yes. Yes. Now, here there is a huge pterygoid process. See, this disease invades the Haversian system of the bone. See that?
Right.
This is all necrotic fungus. उठा उठा. That is the region of the orbital apex. This is superior orbital fissure. This is superior orbital fissure. It is anterior continuation of the cavernous sinus. रुक जा, रुक जा, रुक जा. अब later. Now give me the drill. See the most important part of the drilling. यार मेरे को करने देना.
Floor of the sphenoid, start drilling.
Yes, this bone is involved. See this. Get it. It's all involved bone. Look at it. See this pterygoid bone which I have drilled. अरे यार बीच में क्यों? Divider. Almost drilled off.
It is same feeling that we used to see the JNA cases. Same drilling, same dissection.
Sir, have you encountered in a case in which you have done full exenteration of disease from one side and you are taking that patient in regular follow-up in meticulously, but he has developed some fungal infection on the other side? Satish sir.
Pardon?
Hello. You have done full dissection at one side and opposite side there was no disease. But during your follow-up, he has developed some disease on the opposite side.
Sir, if you are doing the post-surgery, if you are giving the antifungal therapy,
okay,
it is unlikely to develop. Why will fungus develop? New fungus develop?
Okay. Because I am asking because you see, somebody told me that you should also, whenever you wash your right side operated, take a look on the left side also that something is not developing there.
It is common with the AFRS actually. That
not for fungal.
Yeah, not for the AFRS is a different pathophysiology.
Yeah, it is common with that.
And
yeah, see the final drilling.
What are the limits of this drilling, Satish?
Until you find the normal bone.
Okay.
Though I don't find any disease bone here, I've already removed the disease bone. See this?
What structure is beyond this bone?
Carotid. See, here is the carotid. I showed you in the last case the carotid.
Yes.
Remember? Okay, section. See, this is V2. Can you see the median now?
Yeah.
Median now.
Yes.
That is the guide. Just close up view. I am just ensuring that no disease is left behind. Now it looks good. Now, see the sinuses. This pterygoid region we have drilled off. Use taken tube. This is your retromaxillary, premaxillary area. This premaxillary area was a bigger one.
Yeah.
This is premaxillary. This is maxillary. This is retromaxillary. See the levels.
Yes.
Right.
That is pterygoid. That is orbital apex. And here is the cavernous sinus. This is supraorbital fissure. Here is the cavernous sinus, where this internal carotid is running. That's the carotid artery here. And from here, this is the foramen lacerum carotid here. So it looks all healthy areas now. I don't see any necrotic lesions. What we saw on MRI. See the final picture.
Fantastic.
Okay. So any questions?
No questions.
Any suggestions? Anything? Mr. Chairman, Dr. Virendra Gaisas.
He's
ये हटा देना
this is out of scene.
कुछ कर दे
He's sleeping in his bed and watching.
चल देख लेंगे ये ऊपर का तो हटा दे
ये हटा दूंगा मैं मेरा पॉइंट लगाना ठीक हो जाएगा
हेलो
Satish, we had a fantastic session. Thanks to you. We saw a variety of cases, and I think most of the doubts, queries which our ENT colleagues had in their mind probably are solved, and you have given very important take-home points like MRI is key. Dankers is to be used at free will, and role of amphotericin, as literature says, is little can be cut down to reduce. So if your surgical debridement is good, then what textbooks and what intensivists and infectious diseases advocate, I think that can be limited. And prevention is the key, rather than going in for an aggressive, devastating surgeries like this. So awareness amongst our colleagues for stopping abuse of steroids and judicious and rational use of steroids, tight glycemic control. I think these are all excellent points you have made through the last 5-6 hours, which we have been continuously watching you, and I'm sure more still watching you live. Virendra, any points?
Yeah, I mean, it's a lot of points. It looks so easy to just open up that pterygoid box from here, but then it's amazing. But that importance of leaving back the fungus there, and so many points, it's awesome. And then we are so grateful to you, Satish, for accepting our invitation and just spreading the knowledge. And so many patients will be benefited by you, so many surgeons, and in turn the society will be benefited for you, Satish. I think we'll be really grateful. And as Ashish said to me, maybe AOI Pune and AOI Mumbai, once Satish comes, it becomes global. So it was a global show. Did not remain with AOI Pune and Mumbai, but then we assure you that Pune and Mumbai will combinedly do something really great in future too. And we have great support of Sun Pharma as well. And thanks to them also. So thank you so much, Satish. You made our day.
All thanks to you. All thanks to you, man. It could be possible only because of you, Dr. Ajay, and of course Ashish. Big thanks to Dubey sir for sparing so much of his time. Arpit did so much of hard work. Of course, Sun Pharma is instrumental, and we request Sun Pharma to make sure the availability of amphotericin B. They have they produce amphotericin.
Satish sir, sorry sir.
And not to forget Dinesh.
Yeah.
I request them to deliver to Dubey sir immediately.
Yes, immediately. I need.
Satish sir, Dr. Ashok sir want to talk with you. Just can you
Yes,
talk
sir.
with him?
Yes.
Hello, Dr. Satish.
Yes, sir.
This is Ashok Karupure from
Yes, sir.
Academy.
Sir.
So, it was a wonderful privilege to have you part of our two-day live broadcast. So really thoroughly enjoyed it. It was really a grand finale. So really thankful to you. And,
Thank you.
Privileged for you to have you on board.
Thank you, sir.
Thank you once again.
It's a privilege for me to be part of your network.
We called it as a grand finale by the man himself. Great.
Arpit will, I think, like to give a vote of thanks and.
I would like to thank Bhumkar sir for getting Dr. Shrikant Shinde and Dr. Charuda Shinde also into the program and creating awareness and getting the authority and the administration to increase the awareness. Thank you, Dubey sir. Thank you, all the other moderators, Dr. Kirtane, Dr. Karmarkar, Dr. Abhijit. And thank you, Sun Pharma. Thank you, Dinesh, for this, arranging this webcast. Thank you so much, everyone. And of course, Dr. Satish Jain, sir, always there. And he could have, I think, continued for a few more hours if we would have allowed him to. But thank you, sir. It was a great learning experience for all of us.
Thank you. Thank you, man.
Just a small request that we have got a lot of requests for this session to be made available. So those who have missed it and couldn't join us live.
It is available on YouTube.
Okay, it will be right.
Yeah.
So great. So once again, Satish sir, thanks a lot. And
thank you all.
Thanks to AOI Pune for associating AOI Mumbai, and a big.
And lastly, personal birthday wishes to Mrs. Jain, and say sorry to her from our behalf.
For keeping you away.
Yeah, right.
12:20 हो रहा है अभी 20 मिनट लेट है सतीश भाई.
Yeah,
right.
Good morning, faculties. This is Manoj Sharma.
Last comment before we say goodbyes. That in the Western world, we haven't really seen any cases yet, but probably it's not long that such cases, although not in such big numbers, will be seen.
Sir, thank you.
Incidents there in UK.
Equipped us
Ask Dr. Ashok about the UK incidents of mucor.
Thousands of these cases, and it's the best optimum management. So it's a really great service to humanity. So thank you for that. And you all stay safe. Happy birthday to your wife. I just heard that your birthday in the family. So thank you again.
Thank you, sir. Ashish, you were saying something?
I was saying, ask Dr. Ashok the incidence of mucor in the UK, if he's still there.
Dr. Rokade, Dr. Ashish Bhumkar is asking about the incidence of mucormycosis in UK in the present situation.
We are done with this grand finale, as we said. So thank you for all of us to hang on with us till the last minute. Just to remind you that the recordings of the
उनकी आवाज
is available on
वो आवाज बंद
our
करो
academy website.
उनकी आवाज
So subscribe to it, and also we are really thankful, especially to Professor Vilki Groman for providing such a
It's there, which is going on. Right then, thank you, Ajay.
Thanks, Viren.
Yes, we'll meet online and offline soon.
Sir, good morning to everybody.
Somewhere in Lonavala. Yes.
Virender
Bye,
sir,
Ashish.
Manoj.
See
Virender
you.
sir, Manoj Sharma here.
Yes, Manoj. Yes, thank you so much.
Thank
Mr.
you, sir.
Kadam, thank you.
Yeah, good morning
Thank
to
you, sir.
everybody.
Thank you very
much. On behalf of all, a very happy birthday wishes to Mrs. Jain. And indeed, we are very thankful this mucormycosis burning topic. I was just reading a couple of days back the newspaper with the Times of India, Ahmedabad, the tsunami of mucormycosis patients. So, in fact, today morning also I was talking to some physicians, and in fact, in the evening, some of the physicians took me the link for this excellent webinar. And the take-home message, which I would like to say, yes, the judicial use of steroids, and there should be some directives for the use of steroids, so that people coming with some problem and don't let other leading to some other problems. Thank you, Dr. Satish Jain, our operating faculties. And in fact, thank you, AY Pune, AY Mumbai, under the post bearers, Dr. Ajay Doifode, Dr. Adip Shetty, Dr. Pich Sharma, Dr. Amrapali Pawar, and AY Pune, Dr. Virender Gaisas. Thank you, sir. Dr. Shiv Mehta, Dr. Pooja Palapure. And indeed, thankful for all the moderators, Dr. Milind Kirtane, Dr. Sujata Muranjan, Dr. Sandeep Karmarkar, Dr. Abhijit Mantri, and Dr. SP Dubey, who joined after first case. Dr. Rajiv Pachori, till the end, he was there. Dr. Ashish Bomkar, thank you, sir. Dr. Ramesh Murthy, Dr. Aisha for adding their expertise on the topic. Dr. Arshal Tak, Dr. Namrata Sharma, Dr. Mukesh Sharma. Thank you, sir, for making the event very successful. And thank you we are privileged enough for choosing Sun Pharma as the partners for spreading academics, doctor. Thank you indeed. And
I have one punchline for you, sir. You can have Satish Jain from sunrise to sunset or from sunset to sunrise.
Thank you, sir. Thank you, sir.
बॉस दुबे जी को कल एम्फोटेरिसिन भिजवा देना.
नहीं बोल रहा था. Okay, thank you.
Right, sir.
Thank you.
Thank you.
Thanks, everyone.
Thank you. Thank you all. Thank you. Good night. Good night.
Yeah.